Alaikum and good morning. So we'll like to start the session. Please take your seats. Thank you very much for being here today. It's our second day of PMOC 2026. Please save the dates for next year as well. Hopefully, same weekend next year, we'll see you again. So I'm really pleased to invite you all to the GU session. We've got an exciting lineup of speakers, nationally and internationally. We'll be starting with an excellent talk about optimizing perioperative therapy for muscle-invasive bladder cancer. It's my pleasure to introduce Professor Saeed Hussain, well-known international figure in GU cancer. I had a pleasure to work with him in Birmingham as well. He's currently serving as a professor and honorary consultant at the Sheffield University Teaching Hospital, and his work focuses on clinical trials, early clinical trials. He's been PI and sub-PI of multiple clinical trials. He managed to get a grant up to 22 million for the research funding, which is amazing, really. And we also know him very well for his BC 2000 bladder preservation study as well. So, Dr. Saeed Hussain.
Assalamu alaikum. Thank you, Hamad, and thank you, Farouk, and the team for the organizing committee for this kind invitation. It's a real pleasure to be in Dubai, a beautiful place, and exciting to be with my friends and colleagues. There's so much to learn from each other, and so many exciting things are going on. I will try to just run through in the next 15 minutes very quickly about how the field in perioperative setting is changing, and changing for better, really. Patients are living longer, outcomes are improving as well. These are my disclosures. Again, to set the scene, background, we have that cystectomy versus with neoadjuvant chemo versus without neoadjuvant chemo. This was 2003, Grossman's paper, New England Journal of Medicine, 46 months versus 77 months in patients who are having neoadjuvant chemo. Then this sort of a BOA trial looking at the MRC neoadjuvant studies, long-term outcomes, 3 years, 5 years, 10 years, 6% survival benefit. But we all know that it was very challenging to convince our urology colleagues at times, 6% survival benefit to get neoadjuvant chemo or not. And I remember lots of debates where we used to say that actually these small steps are important. And I think I'm glad to say in many parts of UK and many parts of the world, neoadjuvant chemo was still being adopted. And quite often we learn that from breast oncology and others, that actually 3%, 4% adjuvant benefit, you move forward. And if you don't move forward, then basically you don't take those small steps, things will not change. At present, NICE recommends nivolumab adjuvant setting only for PD-L1 positive patient population. So not a lot has changed really, and huge amount of unmet need was there. And that's what we need to see, that 50% experience recurrence or progression. Median survival was modest benefit, about sort of 5 to 8% modest survival benefit. This is, we are talking about absolute survival benefit. And then restricted patient population for IO, like nivolumab in PD-L1 positive in many parts of the world, and needs for better biomarkers. And to integrate those biomarkers, I will encourage you to think about window of opportunity trials. It's great to see studies coming up from, we were talking with Saeed yesterday, Dr. Rafi, about a lot of things that can come from Middle East, because you have got these opportunities with number of drugs and sort of treatment options that are available. So in terms of unmet need, we really need to say which patients we give immunotherapy. Is neoadjuvant chemo followed by radical cystectomy an outdated treatment? Should we have adjuvant treatment, perioperative treatment? Can it be guided by ctDNA and things like that? Is there a delay in radical cystectomy? Great to see our urology colleagues here as well in the audience. And it is important because this is a multidisciplinary field. You really cannot work on it on your own. And it's so important to have these multidisciplinary fields, have family physicians here, have respiratory physicians here, because that is what will make change. We learn from each other's experiences and how to move things forward. So potentially, why would you add immunotherapy into with chemotherapy? Again, there is science behind it. And you look at the stimulating T cell activation by increasing the expression of MHC1, stimulating dendritic cell maturation. So there are a lot of reasons where basically giving chemotherapy with immunotherapy may make a big difference. and then adding a PD-L1 antagonist promotes antigen presentation. This is the background for Niagara study. I won't go into much detail. You're well aware of that. In terms of over 1,000 patients, 1,063 patients were randomized between durvalumab plus chemotherapy, followed by adjuvant durvalumab with cystectomy in between versus standard of care chemotherapy. It was well balanced that you would expect in a big clinical trial like that. And again, what was really important, which I want to highlight on, is the patients with GFR 40 to 60. So basically, you're increasing the spectrum of patients who are receiving now neoadjuvant platinum-based, cisplatinum-based chemotherapy. That is important because when we talk about the Keynote 303 study and others, it's important to look at the number of patients who had GFR below 60. In fact, there were 40% of patients above GFR 60 in the Keynote, in the EV303 study, which was called cis-ineligible trial. So overall, if you look at the key thing, event-free survival hazard ratio of 0.68, so significant benefit in terms of event-free survival, and overall survival hazard ratio 0.75. I think these are convincing data. These are exciting data, which will change the field because I work as a NICE expert witness for durvalumab in this setting. We are hoping to get some results and outcome from NICE very shortly, but it is being approved in many parts of the world. Again, looking through the event-free survival benefit that was basically across various subgroups that included patients with lower GFRs. So I think that is important to see that actually these benefits we are seeing are significantly, and in terms of overall survival benefit as well, if you look at the overall survival benefit as well, consistently across various subgroups. So these are important figures. Looking at the analysis in terms of the PathCR rates, we are seeing 33.8 versus 25.8, but reanalysis in terms of ITT, it was 37.3% versus 27. And if you look at radical cystectomy patient population, it was 42% versus 33%. There were no new safety signals that came from addition of durvalumab. And if you look, one of the key things which I want to look at is the outcome of death, which is important. Remember, these are the patients who are being cured by surgery alone, 50% of patients. So one death is too many. So always look at what led to those deaths. So there are 3 deaths, 0.6% both in the gemcis plus durvalumab and gemcis alone arm. So really adding durvalumab, and if you look at toxicity, safety signals generally well tolerated. In terms of the perioperative, as I said, overall, fewer grade 3-4 toxicities, generally well tolerated, more linked with immunotherapy and things. Key takeaway, yes, it is generally well tolerated, and it does tell that actually by adding chemotherapy and immunotherapy together, it is safe to give it and also improves the outcome. And does it have any impact on radical cystectomy? Because what we don't want is that patients missing out on cystectomy because we are trying to improve on our perioperative treatment. And what did that tell us? That tells us very clearly that actually within this patient population, number of patients, this had no impact on patients' ability to undergo radical cystectomy. The number of patients in both arms are very similar, no change by adding radical cystectomy with basically chemo plus IO, was not delaying cystectomy and was not limiting the cystectomy as well. And this is the time to difference if you look at 5.6 versus 5.4. So no difference really in time to radical cystectomy between different arms. Median time to randomization to cystectomy, 16.3 in the experimental arm, 16.1 in the control arm. Similarly, in terms of within 56 days, 90% and 90%, and within 70 days, 96% and 95%. So no extra delays are happening with the use of durvalumab. Surgical complications were very similar as well. So perioperative, generally well tolerated, as I talked about, limited toxicities, well-tolerated regimen. And I think that is the reason that it will be taken up as standard of care by many parts of the world. One of the debates I had at NICE was that they came and they said, you guys come back with always some expensive treatment opportunities and options for these patients. The way I look at it is actually by increasing by hazard ratio of 0.75, improving on the overall survival benefit, you're increasing the subset of patients who are achieving cure by 1 year of perioperative treatment. And that's a big gain. So actually, you will be saving the cost in the long run for the same advanced bladder cancer patient population. So that's one way of looking at it, that actually these sort of earlier treatment intervention can actually be cost savings. So in terms of neoadjuvant IO, no impact on the cystectomy. in terms of the delays in cystectomy. And if you look at the EFS, event-free survival, you can see that overall, whether they had Durva plus comparator plus followed by cystectomy or standard of care arm, there was no difference in terms of patients who underwent radical cystectomy. PAT-CR rates are encouraging, and overall, it reduced the risk of death by 31% in terms of event-free survival and overall improvement in terms of the OS as well. Both PAT-CR, whether you had a PAT-CR or non-PCR, and that is important. This is from Niagara because InVigor 011 says ctDNA positivity can pick these patients, but on this trial, in a subset of patients, it does not. Basically, whether you were ctDNA negative or ctDNA positive, in terms of PAT-CR as well, whether you had a PAT-CR or you did not have a PAT-CR, disease-free survival is significantly better in the experimental arm. In terms of the pre-ctDNA clearance was 70% in the experimental arm and 57% in the control arm. In terms of the event-free survival, regardless of ctDNA status, you were benefiting from it. So I think based on Niagara, a large randomized trial, it is difficult for us to say that we should stop after completing neoadjuvant treatment followed by cystectomy in patients who had PAT-CR or who had ctDNA negative status as well. So it does not support ctDNA-guided treatment de-escalation at time based on Niagara. This field is evolving and changing, and we need to be aware of that. So I think we've talked about that you can give it safely, no new safety issues, improvement in event-free survival and overall survival. So these have come through into various guidelines now, which is helping us to get these drugs through into standard of care practices now. I think overall we've talked about these sort of key points that we see from Niagara. So the field continues to change and evolve, and it's important to understand there are new trials coming on. InVigor 011 is exciting, looking at ctDNA on its own, but we have got Niagara, which is positive trial, which is primary endpoint is met, secondary endpoint is met, and it is really interesting and is likely to be taken up nationally and globally, and a lot of sites are using that already. I think this is InVigor 011 key efficacy results, and you can see that overall ctDNA randomized cases, both disease-free survival and overall survival significantly improves with very, very sort of significant hazard ratios. Improvement in hazard ratio 0.54 in disease-free survival and 0.59 in overall survival. So this is in the subset of 250 patients. This is a 250 patient trial, 2:1 randomization, where patients who are ctDNA positive, but at the same time, the CT scan shows no metastatic disease. They are randomized to basically atezolizumab versus placebo. So really interesting and exciting trial, which was based on InVigor 010, if you remember, where basically the hazard ratio was 0.4. If you remember, Checkmate 274 had a very similar data as well, but these were retrospective analysis, while InVigor 011 takes us a step forward with the prospective data. So I think these are important. Keynote 905, it's in non patients who are cisplatin ineligible. But the reason I wanted to mention it because we will soon have the data at ASCO GU for cisplatin eligible patients at EV plus P as well. So just wanted to show that to you. But it's important to remember this is a 340 patients trial. It's a smaller data set, 174, 170 patients. Really exciting data in terms of event-free survival, hazard ratio 0.4. Overall survival hazard ratio 0.5. But remember, these are the patients where 40% of patients had GFR above 60. So it's a little bit difficult to say that they were all cisplatin ineligible or patient could not have had any treatment. There was a subset of patients who declined neoadjuvant chemotherapy as well. So there are things, and then PAT-CR rates is really significant in that 57%. And that is why it is a debate going on whether these patients could be cured by this chemotherapy on its own. But remember some of the toxicities. Neuropathy is important. These patients could be cured by cystectomy alone. Do they need my perioperative chemotherapy or perioperative treatment? When we go to these treatments, remember about toxicity. There were 13 deaths in the experimental arm, and there were 9 deaths in the control arm. So this is a group which is a bit ropey group, cisplatin ineligible, but still then we need to be very carefully looking at it. Toxicities, if you look at, there were 13% grade 3/4 skin toxicity. The skin toxicity with EV is different, and we need to be careful about. I'll be finishing with some of the window of opportunity because this is where things will change and improve the outcome. Primary endpoint must be well defined, and multidisciplinary teamwork is the key here. This is a trial that we are doing, myself and Jim Cato, my urology colleague as chief, both of us run that. This is where passive instillation of atezolizumab, localized treatment, or intratumoral injection of atezolizumab. So this is how we work in that. And this, I'm delighted to say that we are starting to get some data here already. And this was 2 cohorts, passive instillation and intratumoral. And we have now treated 20 patients on that trial. We have moved from 600 to 1200 milligram. And now we are on multiple weekly injections, maximum 6 injections, then cystectomy. So this is how we will try to learn about what is the mechanism, what is driving toxicities, but also, and at the minute, we are not seeing any toxicities at all, any IO toxicity. This is the tumor in patient 19 with intratumoral injection. What you can see, we started with quite a decent big-sized tumor in the bladder. Jim has been doing weekly injections, and then this is the last 6 treatment. I'm delighted to say that this patient has a PAT CR, PT not. We had about 8 out of 19 patients so far who had PAT CR. So this is important to remember. The treatments as well. This is between myself, Jim Cato, and Simon Crabb. And I will finish with that, that actually this requires multidisciplinary team. This requires working together. All of us working together can really make a big difference. This is me with the robot, not that I'm doing robotic surgery, but Jim brought me in. We had a good case of cystectomy that we did. And I watched him. I did not do anything. But he took that picture and he put that on. So I borrowed that slide from him. And I call him, he's a medical oncologist working with me. And he calls me that we both go to each other's clinic. We get share our patients together in that sense. But that's the model I will encourage you to have a joint clinic and things like that. Thank you very much.
Thank you very much for excellent presentation as always. Let's welcome Dr. Jawahir Ansari, consultant medical oncologist, who trained in Birmingham, then worked in Beeston, and he'd been chief of Tawam previously, now moved to Dubai. He will be talking about advanced urothelial cancer. He will bring the clinic to the meeting today. Dr. Jawahir.
Assalamu alaikum. Good morning, everyone. Thank you so much to the organizing committee, especially Dr. Hamad and Dr. Farouk for the kind invitation. So I was given this talk to talk about advanced bladder cancer. When I looked at the things I was expected to cover, they wanted me to discuss a case-based discussion, look at the first-line management, sequencing options, patient selection, look at frail patients, and look at multidisciplinary approach to this. So that looked like it was Professor Saeed Hussein's talk, looked at the early bladder cancer, and they wanted to do the rest of the advanced bladder cancer in 15 minutes, I believe. So I thought it'll be a bit of a challenge to discuss the significant advances that we have, but I'll try to give some of the highlights really to do justice to the talk. So one of my recent cases, a 68-year-old male presented with hematuria, urinary frequency and nocturia. He had multiple comorbidities, diabetes, a prior history of non-muscle invasive bladder cancer about 5 years ago, for which he had treatment, and he was disease-free until at least early 2025. He was on standard medications, good performance status, and PS0. So this was his scans in May 2025 when presented with his urinary symptoms, TURBT confirmed, grade 3 urothelial carcinoma, which was muscle invasive, and bone scan and MRI pelvis confirmed multiple bone metastasis, as you can see, and the left iliac crest and the right SI joint, consistent imaging, and also in the left acetabulum. And there were other multiple pelvic and paraortic lymph nodes as well on these images. So the key question is, if you were to get this patient fit 68-year-old male with a T2N1M1 metastatic urothelial cancer with bone and lymph node metastasis, if cisplatin eligible with a good EGFR, good performance status. He was diabetic, but reasonably well controlled. HbA1c slightly on the higher side, 7.2%. What would be the preferred treatment option in 2026 now? Historically, platinum-based chemotherapy was the gold standard. We know that the outcomes were quite poor, median survival around 13 months, response rate just under 50%, and multiple toxicities were seen with platinum-based chemotherapy. And there were no long-term cures with this approach. And clearly, there needed to be newer treatment options with better outcomes for these patients. Then came Javelin Bladder 100 trial, which looked at maintenance avelumab. But specifically, this trial looked at patients that had some form of response to initial platinum-based chemotherapy, 4 to 6 cycles of platinum-based chemotherapy. Patients needed to have either
Let's welcome Dr. Ashur from Kuwait. Dr. Ashur is a consultant medical oncologist working in the Kuwait Cancer Control Center. He's a well-known regional speaker, and he'll be talking about prostate cancer biomarker-driven therapy.
Assalamu alaikum. Thank you, Dr. Said, for a nice introduction. Thank you for a kind invitation to this conference. I was requested to present the management or biomarker-driven management in metastatic prostate cancer. Actually, let us to talk about what is the need of biomarker in prostate cancer. Prostate cancer represent a continuous and major unmet need and the challenges. This is due to a large number of patients presented every year and large number of deaths from this disease. In addition to this disease, usually having a good survival in patients with all metastases reached to 5-year survival to above 90%. However, in metastatic case, it dropped to 37%. This metastasis usually is different from side to side. Patients with lymph node metastasis differ largely than patients with liver metastasis in survival. In metastatic MSC-RPC or metastatic castration-resistant prostate cancer, this is a very bad area, or the most critical area in the journey of prostate cancers. It needs more specific treatment. It needs personalized treatment and very high needs of unmet needs. So in this group of patients, we need to have, and this group of patients is not homogeneous. We have a heterogeneous disease, either in the treatment received or in the biology of the disease. So we are dealing with different disease in the same patient. In addition, what we need from these patients, what we need to know the target, the right target. We need to know the right patients. We need to know the weaknesses. All this can reflect it to achieve successful outcome. How we can reach to this point? We can reach this point according to the solid tumor. Now we are going to personalize treatment for every tumor. So we need to have comprehensive biomarker for this patient, including the HRR gene, including the MSI, including the DMMR, including the AR alterations, and including also the RP1, the B10, and the B53, in addition to the surface targets of PSMA and STEP1. So all these targets, if we know this before starting the treatment, this will help to improve the outcome. How to test? How, according to the guidelines, most of the guidelines recommended to test molecular for prostate cancers. If we summarize this in this slide, germline testing tested for all patients with MSC-RPC or hormone-sensitive prostate cancer. Patients with high-risk features should be tested for. Patients with high family history, first-degree family history should be tested. When we test these patients, this testing, it could be a diagnosis to determine the heritage or the heritable risk for these patients. And in other hand, if we have to test for somatic mutations, if we look to the guideline, it is MSC-RPC, but in the futures, I think all patients should be tested in hormone-sensitive and in castration resistance. And this is helpful for treatment predictions or treatment selection for these patients. We need to test many targets. The current target, we have treatment like the HRR and like the MSI. How to test? This is an important point. To test in the tissue, this is the standard care if we have available tissue. But according to the trials and according to most of the trial, we have 30% in profound trial. We have we cannot test in the tissue. It is failed to collect data from the tissue. So we have a substitute with ctDNA. So ctDNA can replace tissue to test for molecular marker. HRR deficiency in prostate cancers is different from hormone sensitive to castration resistance. In hormone sensitive, it reached to 20%, while it increased in metastatic castration-resistant to reach it to 33%. The most common gene, as you know all, is a BRCA2 mutation. And this is important for treatment and prognosis for the patient with prostate cancer. And you know also, this patient with HRR, specifically with BRCA mutation, is highly aggressive variant. We know it is characterized by increased tumor size, characterized by high glycemic score, characterized by nodal involvement, highly nodal involvement, and high metastatic site. This is aggressive variant of our aggressive features of prostate cancer. And also we know the role of PARP inhibitor in solid tumor, and the PARP inhibitor is enrolled in many solid tumors. And if we look at the PARP inhibitor in prostate cancer, in 2020 it appeared as a PARP inhibitor as a subsequent line, and in 2023 the combination appeared in the first line. We have here as a monotherapy, we have two important trials, the PROfound and Triton 3. Both have significant improvement of survival and significant improvement of radiological progression-free survival with addition with a given PARP inhibitors, either the olaparib or locaparib as subsequent line post-ERPI or post-taxane. And we have the combination trial in the first line. We have three important trials. Three important, the Propel, Magnitude, Talapro, and we have the Casper ongoing. If you look to the Propel trial, this is the first trial combination trial of abiraterone plus olaparib. This included patients with MSC-RPC, patients allowed to receive docetaxel insensitive, but none didn't allow to receive abiraterone insensitive phase. In this group of patients with good performance status, either to give abiraterone and plus olaparib, all placebo plus abiraterone. Radiological progression-free survival is a primary endpoint and overall survival secondary endpoint. The trial was positive for radiological progression-free survival with improvement of survival from 16 to 24 months and hazard ratio 0.66. Also improvement of the response rate, about 10% difference in the response rate between the use of combination than single agent ERPI. In updated analysis in specific group patient with BRCA mutation, we have, you can see the curve in patients with BRCA, either germline or somatic mutation. It is clear difference between the control arm and investigational arm with hazard ratio 0.2. The second trial, which is the Magnitude, is the difference between the Propel and Magnitude. Here, they allowed to ARPI and allow the taxane in MSC-RPC, and they are all patients screened for HRR before in randomizations to two groups, either the HRR biomarker positive or HRR biomarker negative. However, the negative arm is closed early due to futility. The radiological progression-free survival is the primary endpoint, and we have many second endpoints. The trial was positive for radiological progression-free survival with improvement and with a hazard ratio 0.55. And in patients with BRCA mutations, the niraparib plus abiraterone improved also the survival with hazard ratio 0.5. The TALAPRO-2. The TALAPRO-2 is a trial using the talazoparib plus enzalutamide in MSC-RPC phase 3 trials. I think these patients also included patients with MSC-RPC, included patients with abiraterone, despite of ERPI, the percentage of ERPI used in this trial is very low. But it is allowed to use ERPI in previous line. These patients also randomized either to use the investigational arm with combination treatment or to use single agent with enza alone. And the radiological progression-free survival is a primary endpoint. We have second endpoint like time to cytotoxic chemotherapy and overall response rate. The trial in updated analysis in last year, the update analysis for this trial, the radiological progression-free survival improved in HRR deficient populations, and the survival and radiological progression-free survival improved from 12 months to 30 months. In addition, in the radiological progression-free survival, we have here overall survival clear benefit, and in patients with HRR mutations, it is 30 months versus 45 months, and it is more clear in patients with BRCA mutations. It is about 28 months and not reached in investigational arm. Step forward, the castration resistance, we are use the castration PARP inhibitor in castration resistance, but it is not this the end. We have the PARP inhibitor moved from castration resistant to hormone sensitive phase. In hormone sensitive phase last year in ESMO, we have the Amplitude trial. The Amplitude trial is a phase 3 trial. Phase 3 trial and use the patient with HRR mutation. All patients tested with HRR mutation. All patients is metastatic hormone sensitive prostate cancer. Patients in this group of this trial, any prior PARP inhibitor excluded from the trial. ARPI other than aprituron excluded from trial. They allowed ADT less than 6 months, they allowed docetaxel less than 6 months, and aprituron less than 45 months, and palliative radiotherapy. The trial randomized either to give niraparib plus aprituron or aprituron plus placebo with radiological progression-free survival as a primary endpoint and time to symptomatic progression, overall survival and safety. Amplitude trial was positive with reductions of risk of '81. Percent is B10 mutations, and the patient in investigational arm started cabivestrib versus placebo plus aprituron. The radiological progression-free survival in this trial was the primary endpoint, and overall survival is the second endpoint. In this trial was positive for radiological progression-free survival and improvement about 7.5 months improvement in radiological progression-free survival. However, the overall survival is still immature to be presented, is still not significant. And finally, we have this DMMR, tissue agnostic therapy. Tissue agnostic therapy is widely used in all solid tumors. One of this is DMMR is very low, 3% for DMMR, and TMB is about 15%. It's approved since 2017 as a tissue agnostic therapy for patients with MSI high, and approved as a TMB in 2020. Finally, let us to say that this algorithm, this is a proposal of algorithm can be used in the future for metastatic prostate cancer. All patients should be tested for molecular biology, tested for MSI, tested for DMMR, and the patients, according to this, can be treated. If the patient's HRR positive, we can consider PARP inhibitor. If the patient is DMMR, we can consider immunotherapy, and the other patients, we can consider standard of care, the EDT and the RPI. By this, I finished my talk. Thank you so much.
Thank you very much, Dr. Ashur. Next talk will be about radioligand therapy in prostate cancer. Please welcome Dr. Munir Ghassani, all the way from New York. Dr. Munir Ghassani is the Chief Medical Officer at United Theranostics, and he is also a Clinical Associate Professor of Radiology at Peacham School of Medicine. His expertise spans over oncological imaging, theranostic, and targeted pharmaceuticals. He has authored up to 200 papers and is also editor-in-chief of nuclear medicine. Dr. Munir.
Good morning, salam alaikum, and thank you very much for inviting me to present. As you just heard, there's quite a few evolving applications targeted to specific patient situation, and radioligand therapy is no exception to that. So I will actually go through some historical perspective of this as well. So these are my disclosures, and this is the outline. So we'll go through first with historical perspective, then current status, and we'll go through future directions. Since I have to share a lot of stuff, I have made sure that I can go through the slides in a rapid but still informative manner. So this is Maya Angelou talking about you can't really know where you are going until you know where you have been. And to better understand what has happened over the last 3 decades, we need to go back 100 years to how things happened. So in actually 1920s and 30s, this is the beginning of nuclear medicine, where Bloomgart and Weiss actually performed arm-to-arm transition in patients with cardiopulmonary disease as opposed to normal volunteers. And using bismuth 214, they actually found that there was a difference. So that was the concept of nuclear medicine in vivo, in vitro, and then ultimately going into therapeutic side another 20 years later in Boston, in MIT, at a conference. This discussion starts about making iodine radioactive. It goes on to Sol Hertz then administering the radioiodine therapy. And then subsequently, biology and medicine concept starts with the discussion at the Compton, who was the president of MIT, in making radiopharmaceutical therapy feasible. So here's the example of how powerful this theranostic technique is, where these lesions that are iodine avid are diagnosed on a whole body scan, with more specific with SPECT CT, as you need to characterize their location and extent. And then you find that, you treat that, and you follow again with the treatment follow-up imaging and confirm that there is complete resolution. So that's the fundamental basis of theranostics back 80 years ago. And then obviously, in order to complete the cycle, you need also imaging, which is where Hal Enger, who still, both Hal Enger and Benedict Casson still have their legacy in our society as NMMI, where every year we give an award to one person each for the work they have done in bringing imaging to nuclear medicine. And this is Hal Enger's worst concept. After all these decades, even more than 50% of the gamma cameras today still use the Hal Enger principle in imaging. And then now more specifically into PSMA, this was the origin, the LNCAP cells. There are multiple attempts done to make it more specific. What was interesting was that out of 28, 26 specimens, and then total 26 tumors and 122 specimens, only 120 were negative, only 2 were positive to that specific marker of PSMA. And there was a conclusion of that. This is 87. This biomarker may be a clinical potential in prostate cancer. Another 6 years later, Ron Israeli and his group isolate this protein with 100 kilodalton. And I have the image to show how specific that one is. What is most remarkable is that after discovery of this, they conclude, again, showing that majority of the controls had no expression, but all the disease-specific LNCAP cells were all showing the CYT356 staining. Then they mention about the future projections. And there's a baseball player of New York Yankees called Yogi Berra. He's known to make very witty comments. And one of his was, it is tough to make predictions, especially about the future. But this group, back in 1993 publication, actually predicted that one day this marker will become a target for not only diagnostic, but potentially also therapeutic approaches. And that target is the PSMA. We know majority of it is extracellular, a smaller component is transmembrane, and even smaller is intracellular. And it's expressed in the secretory cells within the prostate epithelium. Majority of the benign and hyperplastic tissues, they are absent in prostate. We do know that we have to be mindful that in the salivary glands, there's quite significant uptake, irrespective of the retention, like prostate cancer cells, but we need to protect them when we treat them with lutetium PSMA. And so this is that concept of expression of PSMA. Not only you can use that for diagnostic PSMA PET, but once you confirm the expression, you can switch out and use the lutetium-177 based therapy. There are multiple attempts at developing these. It started with iodine-131. There was also an attempt to Y90, but ultimately this became the widespread use with lutetium-177 PSMA. And then Hoffman conducted the first prospective trial using the 617, which is the one that is contained in Pluvicto. And then ultimately that company, Endocyte, was acquired by Novartis. So what is the current status? I'll go through two trials. There are multiple others, but these are the two groundbreaking ones. The first one is the Vision trial, international open label phase 3, and treated with at least one androgen receptor and one or two taxane regimens. And they were required to have gallium PSMA 11 PET-CT. FDG PET-CT was routinely used in Australia, but knowing the difficulty in many parts of the world getting both FDG and PSMA, including US, there were surrogate markers of PSMA used instead of actual FDG PET-CT to qualify the patients. And what it found was that there was a median survival of progression-free survival of 8.7 months with treatment arm versus 3.4 months with control, and overall survival benefit of 15.3 versus 11.3 months. Also, imaging-based progression-free survival separation on Kaplan-Meier curve are impressive, and then overall survival. This led to the approval by the FDA in May of 2022. Also, the adverse effect, it was higher of grade 3 or above with PSMA than without, but these were all tolerable and quality of life was not adversely affected. In fact, I'll show you in the subsequent slides that there were some other advantages as well, including the improvement of pain. And we see that in our clinical practice as well. After just 1 or 2 cycles, patients report quite significant improvement, especially if they have multifocal bone pain. And then first symptomatic skeletal event also was delayed with Pluvicto. And here's one such example of PSA of 425 after completion. About 7 months later, it's 17. And that was, again, what led to the FDA approval. We were one of the 4 centers in US to participate in the expanded access program. And some of you who were in the conference in Dubai about 15 months ago, I had presented this particular case that was on a wheelchair-bound 87-year-old. And on the next cycle, when I'm looking for him for a wheelchair to arrive, my nurse comes and says, "Can you start the treatment?" I said, "I'm waiting for the patient." She said, "He walked right past behind you and went onto the infusion room." So quite remarkable improvement with just 1 cycle. After 2 cycles, he's from Boston and in fact went and bought a new car and started driving his wife around for dinner at multiple places where they had gone for dating 60 years before. So quite impressive difference in the outcome of the patients. We see this playing out over and over again. Next trial is a PSMA-4, understanding when it is necessary to delay the taxane-based chemotherapy. So this trial was also phase 3, required 1 prior ARPI, and these were taxane-naive patients. Again, just like Vision, they were required to have gallium PSMA PET-CT to qualify them for treatment. Primary endpoint was radiographic progression-free survival. Secondary was overall survival, and there were several additional endpoints as well. And upon centrally reviewed progression, the patients were randomized to either a change in ARPI versus crossover to lutetium PSMA arm 617. And ECOG status and changing, these are the two columns of the control and treatment arm, very similar. And again, I can't go into the great details, but this is a breakdown of the patients. And these are the results. So again, radiographic progression-free survival, significant advantage. The reason why we didn't get the overall survival was because of the crossover. 60% of the patients in the study crossed over to treatment arm. That impacted the overall survival analysis. But if you did the alternative analysis for crossover correction, there was hazard ratio of 0.6 in improving the outcome of the patients. And when it comes to the FACT-P score as well as the pain intensity score, they all were improved with lutetium PSMA 617. Also, the PSA response, again, better with lutetium PSMA versus the change in ARPI. And soft tissue response. You saw the earlier data about the lymph node metastasis. We see this playing out in the radioligand therapy aspect as well, that patients with lymph node metastasis in general respond better than bone. But again, in the bone metastasis, we are still finding quite significant improvement. And then there's a next trial that is still being reviewed by the FDA. We are hoping that their readout will occur in about a year to 12 to 14 months, but we'll see how that works out. And this is going to be in the hormone sensitive arm. And these are the endpoints, again, very similar to the previous two trials that I described. In the interest of time, I will just show you this particular separation. So it's 617 6 cycles versus ADT plus ARPI. And again, crossover there is allowed as well. And then similar to the other trials, there are going to be other secondary endpoints as well. These are the baseline characteristics between the two arms, very balanced. And currently, at the ESMO, some of the data were presented, and the primary endpoint was met in the PSMA addition trial as well. Again, interim overall survival, you have to account for the crossover as well as follow-up of these patients to see what the ultimate outcome turns out to be. Okay, so the conclusions are that benefit was consistent across the subgroups, positive trend in overall survival, but again, follow-up for mature data is going to be necessary. And then these are other key factors that were discovered. So what are some of the future directions? Then I'll end the discussion. There are alpha particle-based therapy options coming up as well, and these include actinium-225, as well as lead-212, and many other isotopes, but still currently the standard of care and proven through the trial and approval is still lutetium-177 PSMA. There are some examples of very sustained and prolonged improvement in the burden of metastatic disease using these treatment options. And this was one of the first data that came out from one of my colleagues, Morgan Stern, in clinical radiopharma in 2018. So it was about 7-8 years ago. The other frontiers include the personalized dosimetry. No doubt this will become more and more relevant because not only from patient to patient you have to account for the differences, but for the same given patient. As the disease burden decreases, radiopharmaceuticals are then going into the organs at risk. So theoretically, there might be some options to customize this for each patient as well as for a given patient from one cycle to the other. But still currently, the fixed dosing is the standard of care. As I mentioned, there are other options as well, including copper-67, lead-212. Then there are other treatment-targeted options coming for other tumors as well. And again, as I mentioned, some of the promises need to be played out in the clinical trials. So in summary, foundations can be traced back to 100 years, remarkable achievement in the radioligand therapy for metastatic prostate cancer, thanks to the hard work of many. And close collaborations include our colleagues in oncology, radiation oncology, surgery, our physicists, technologists, scientists, engineers, administrators, industry, and regulators. They're all going to be necessary to collaborate together. And if that happens, there are many promising developments to look for in the coming years. Thank you.
Thank you very much. So we'll move on to the renal cancer. It's my pleasure to invite Dr. Deborah Mukherjee, consultant medical oncologist, currently working in Clementia Hospital, trained in St. Giles and Thomas Hospital, and also worked at Royal Marsden Hospital. She's the expert in juju cancers. Dr. Mukherjee.
Thank you so much for the invitation. A great pleasure to be here with many friends and colleagues. So we're now going to shift gears to kidney cancer for the next few minutes. And it's a great pleasure to be presenting a very difficult topic on the post-immunotherapy landscape. These are my disclosures. So we know that the landscape of therapeutic options for renal cell carcinoma has been ever expanding, and it's just an incredible testament to all the clinical trialists and the patients who put all their efforts into expanding our treatment options for this very challenging disease. So first-line therapy options, we're all aware that we have multiple options which are now giving excellent results. So these are the 4 summarized main treatment options that we are using in the first line, which usually involve either an IO and TKI combination or the combination of 2 checkpoint inhibitors with ipi/nivo. We have to be aware, of course, of cross-trial comparisons, and we've all seen this slide updated routinely by Brian Reaney, looking at the differences in these different clinical trials between these combinations. But the bottom line for first-line treatment of metastatic clear cell RCC is that we need to, of course, pick one and use it well. So can we increase our responses by intensifying? And unfortunately, we saw that in the COSMIC 313 study, adding an extra immunotherapy to our IO-TKI combination very sadly didn't really give us the improved outcomes that we wanted. And perhaps this is very relevant when we're thinking about what to do in the post-IO setting. So at the moment, we still have those 4 combinations, and we may have reached a plateau. We may have reached a plateau with all of these clinical trials of the progression-free survival and perhaps the median overall survival. So the question now is, how could we push these boundaries if we aren't allowed to, or we aren't able to push the boundaries by adding extra immunotherapy in the first-line setting? Can we do anything to the patients who progress after these therapeutic options to improve our overall survival outcomes? So this is a slide I made last year, which I'm going to show again and again because I keep liking it. We need to pick one of these first-line options and use it well. But what does using it well mean? It means proactive management of treatment-related toxicity. It means ongoing input from the MDT, looking at potentially metastasis-directed therapy in selected patients, cytoreductive nephrectomy in selected patients. We need to involve our palliative care teams, which we're not so good at doing in urological cancers. And of course, attention to the psychosocial and treatment access issues that all of our patients have. So moving on, our challenges in the subsequent therapies, the main body of the talk. 2 main areas of interest: progression after adjuvant pembrolizumab. So now we're using adjuvant pembrolizumab for 1 year following resection of high-risk disease or even M1-NED. And also the evolving role of treatments beyond progression on our IO combination therapies. I've just put our picture of our colleague and friend Tony Schwery with Micheline and Humaid there, who has been pioneering the data on adjuvant immunotherapy. So first question, is there a role for genomic biomarker testing? We've seen very nice data from prostate cancer, bladder cancer, lung cancer, and this is our GU colleagues being very jealous of our lung cancer colleagues, that in lung cancer we have so many treatment selection biomarkers to choose from. What about in RCC? Not really, and nothing ready for prime time. These are data from Memorial showing actionable genomic mutations in a very large data set. And down here at the bottom is renal cell carcinoma, very few actionable mutations. So of course, we are very keen on sending off somatic NGS panels for all of our patients with advanced solid tumors. We are unlikely to get anything at the moment very actionable in our patients with advanced RCC. So first of all, the question of what to do in patients progressing after adjuvant pembrolizumab. This is one of the key questions that is taxing us at the moment. So in the study, we had around 15% of patients progressing while receiving adjuvant treatment. And obviously this is bad news. Around 10% of patients progressing within 1 year of finishing treatment, and around 15% of patients progressing subsequently. So we can really think about, and this is some slides from my colleague, Dr. Roberto Acobelli, about how to conceptualize this. We have those patients progressing during adjuvant treatment. So this is the same as patients progressing on first-line IO combinations in the metastatic setting. So we can extrapolate the data from CONTACT-03 and the TiNivo-2 studies, really showing, and I'm going to show you those curves, that re-challenging on progression during immunotherapy for advanced kidney cancer is not really very helpful. But then what's the role of time for those patients who progress on stopping their adjuvant immunotherapy? And this is something which is really up for debate at the moment. So these are the studies showing that in patients progressing on immunotherapy in the first line, adding another immunotherapy really has very little value. And we would love this not to be true, but unfortunately it does seem to be true from 3 randomized clinical trials. So no benefit from continuing immunotherapy in those progressing on a previous IO combination therapy, or even potentially single agent pembrolizumab in the adjuvant setting. So what about subsequent therapies? So at the end of adjuvant treatment, some patients will be hopefully cured. Some patients may have a decrease in the tumor cells that are already metastatic and then progress once we stop the treatment. And there are some patients who may just be refractory to this therapy as a single agent. So immunotherapy may have worked well in the adjuvant setting in a subgroup of patients, and we know that it improves overall survival. So we do feel that there is that survival benefit, or we know there's a survival benefit. But what about the patients who progress slowly? And I think this is the point that we're making, that sometimes time is not the best predictor of outcome. So non-responders, if they have a slow tumor growth rate, may then pop up on a scan with disease several months after stopping treatment. So I think we have to be very careful about using these time-based markers for deciding whether to re-challenge with immunotherapy. So again, this is a sort of consensus or a guideline that we can follow without any evidence at the moment. Those patients who are refractory, who progress on adjuvant pembrolizumab, we are then going to be thinking about treating with a TKI. Early recurrence, 3 to 12 months. Perhaps we have some primary refractory disease and some with mixed responses. We may have TKIs or TKI-IO combinations in selected patients. We are sort of using 6 months as a cutoff, which is quite arbitrary. And then for patients with late recurrence, again, we can think about secondary acquired resistance. We can think about all of our normal first-line treatment options. And as well, with our MDT, thinking about metastasis-directed therapy, SBRT, and active surveillance for those progressing extremely slowly. So moving on to future trials, we have now a LIGHTSPARK-033 study looking at the combination of zanzilitinib, belzutifan versus cabozantinib. Again, this is something for patients progressing during or within a short duration of time from adjuvant therapy. So this is, again, a new approach trying to stratify patients into what's going to work after adjuvant immunotherapy. What next? What do we do for those patients who've progressed after their first-line treatment? We know that continuing IO doesn't seem to work. We have the LightSpark-005, which is using a new molecule, which is belzutifan. This is a positive study, but perhaps the activity is not as exciting as we would have wished it. Let's have a look at that data and think about this in a patient context. So this is a 75-year-old patient who presented with this huge renal mass, lymphadenopathy, which is not shown on the scan, in the chest, in the mediastinum, mild anemia. He had sarcomatoid disease and was IMDC intermediate risk. He was treated with ipi-nivo and unfortunately had progression after 14 months. So what do we do now? He's progressed on ipi-nivo, he's been on his maintenance nivolumab. Do we go for an IO-TKI, TKI single agent, mTOR inhibitor, or HIF2 alpha? At the moment, our guidelines are suggesting we go for a TKI-based therapy, and we are now left with whatever we haven't given before. So this particular patient hasn't had a TKI, so we could pick any of them. We may use cabozantinib, we may use axitinib, and third line, our guidelines are saying that we can use an mTOR inhibitor or a HIF2 alpha inhibitor. These are the data for belzutifan versus everolimus in patients with pre-treated advanced RCC. This led to the approval. So these are a heavily pre-treated population. So all had IOs, all had TKIs, and more than 85% are treated in the third or fourth line. So this is something we have to bear in mind when we look at this data. This was a positive study. We have a stable hazard ratio, and we have an improved progression-free survival. If we look at the hazard ratio of 0.75. So this definitely beat everolimus as a subsequent therapy. There is a lot of crossover in the first 6 months, suggesting that we may have a substantial proportion of patients who are early progressors. What about the rate of response rate? That was improved with belzutifan versus everolimus, and time to disease progression. These curves are separating, and we know that belzutifan was a well-tolerated treatment with the quality of life curves separating early. So this is reassuring for our patients in the third and fourth line setting. But the overall survival was not met, and still these data are maturing, but the hazard ratio remains stable, so we are probably unlikely to see a positive overall survival result from these data. We saw a little bit more data at ASCO GU last year, showing that we had clinically relevant improvement in the all these subgroups, including patients with difficult to treat disease, with liver metastasis, and patients with high tumor burden. Remembering these are heavily pre-treated patients. So what about this switching between TKIs? This is what we've traditionally been doing in subsequent lines of therapy. And again, this is a slide from Roberto showing that we can use basically anything we haven't used. And can we get a response? Not so much evidence, but again, depending on the duration of response to prior TKI, we can use other TKIs that we haven't used, including probably the most studied one in the second line is cabozantinib. So what are our guideline-based recommendations? Again, we are probably left with a TKI in the second line, and now we have the option of belzutifan in the third line. We have some new data coming up. So this talk is going to change after GU ASCO this year, and the LightSpark-011 study has been announced as positive. So what is this study? This is advanced or metastatic RCC, disease progression after first line or second line IO or IO plus TKI, or progression within 6 months of adjuvant immunotherapy, and patients have been randomized to either the combination of belzutifan and lenvatinib versus cabozantinib. And this has been announced as positive for PFS, and we're going to be seeing the data in a few weeks. So post-renal, post-checkpoint inhibition for RCC, we now know through 2 randomized studies, no role for IO continuation following progression on immunotherapy. We have no clear guidance on patients progressing after stopping immunotherapy, However, those progressing after 6 to 12 months, we can think about re-challenging potentially. Otherwise, if they're really IO refractory, we will be left with a TKI. We have guideline recommended therapy for IO or IO-TKI progression to switch to the TKI that we haven't used in the first line. And we have this new data from the LightSpark 011 that we're going to be eagerly awaiting, which is positive for PFS from this combination of lenvatinib plus belzutifan. So that's very exciting news, improving PFS over cabozantinib. We have some novel approaches, which we don't have time to go into the early phase data today, but these include CAR T-cell therapies, bispecific antibodies, targeted radionuclides. So I'd be really interested in our colleague from Mount Sinai if they're using anything for kidney cancer, and other targeted therapies for selected subgroups, such as PARP inhibitors in very small selected subgroup populations, even in the setting of advanced RCC. So that's it. And this is a special one for Professor Hussain, since I was very keen on having a photo with our robot. This is me with the robot. I think that oncologists are going to be a dying breed as we're having our jobs taken over by AI. So perhaps we all need to learn some skills, including those multidisciplinary skills. Thank you very much.
Thank you very much, Dr. Mukherjee. So we'll be starting the panel discussion. Let me invite dear colleague and friend, Professor Fariboz Bagheri. He's a consultant urologist and laparoscopic surgeon, an important member of MDT. He's very pertinent in terms of the MDT timings, always on time. This MDT starts, Dr. Fariboz. And please welcome also Dr. Batul Al-Balushi. She's the head of nuclear medicine department and theranostic in Dubai Health. She has brought all the new treatments to our patients in Dubai. And also, I will welcome all my dear esteemed speakers to come to the stage, please, for the discussion. Very much. It was an exciting discussion. Let's start with the bladder cancer. Exciting data, really. What we see, more and more patients may now be eligible for curative surgery, which is exciting. But obviously now we have a number of new treatments available. So moving forward, just for next week in the clinic and then looking at the future. So how we start choosing our patients for these new strategies now? Is there any selection that we have to do, or we just go with what's the available data now, or you can select your patients according to any biomarkers, their frailty, renal functions. So what to do in the clinic on Monday and in the next 2 years?
Thank you very much, Ahmad. This is a really important question because as we move forward in bladder cancer, what we are seeing is that patients who are being selected for cystectomy, so patients who are fit for cystectomy, I think they are very much like candidates for neoadjuvant treatment. That's a debate we have been having for that long. I talked about 6 to 8% survival benefit, which was with platinum-based chemotherapy. I think we have really moved forward now. The steps we have taken has been phenomenal. Niagara, in a randomized trial with over 1,063 patients that were part of the trial, not only showed that actually efficacy in terms of event-free survival primary endpoint, and also overall survival with a hazard ratio of 0.75. I think these are really key landscape-changing data and studies. And very importantly, as I said in my talk, that actually in perioperative setting, it's very important the patients, half of the patients are being cured by surgery alone, by my urology colleagues. So when we, as a multidisciplinary oncology colleagues, are adding on new treatments, whether we are doing for cystectomy or organ preservation, it's very important that that is not delaying your surgery or organ preservation treatment. Similarly, that is not causing significant toxicities. Quality of life remains good. And I think that's what Niagara really proves, that actually with a in terms of overall deaths, if you look at 3 and 4 patients, 0.6%, which is basically really important to look at. Toxicity wise as well, adding durvalumab did not add anything to toxicity. Safety signals were fine. You're not delaying surgery as well. So I think I will say that actually with the guidelines that are available, we should be basically offering our patients chemotherapy plus adjuvant durvalumab. Unless you're looking at trials like in UK, we are doing Gusto trial where we do subtyping of bladder tumor. And based on the subtyping, this is a trial led by Jim Cato, myself, and Simon Crabb. And I think that is selecting patients. So if you're not doing in a trial setting, in a standard of care, I think, and I'm expecting NICE to give a positive outcome as well, gemcitabine cisplatin plus durvalumab should be considered as a standard of care for patients who are going for cystectomy.
So for patients, you talked about toxicity as well, and then length of treatment. So patients in the adjuvant setting. So what to do in the adjuvant setting? So you've shown data for ctDNA from the Ambivigor, and then you're also working on some ctDNA data. So someone who has PET-CR and you do ctDNA and it's negative. So what would be the approach, and what do you see in the future?
I think it is an important question. This definitely should be looked into clinical trials. Invigor 011 does move us forward in terms of a prospective trial with atezolizumab. But I think it's really interesting to see in Niagara trial, whether you had a PATH-CR or no PATH-CR, whether you were ctDNA positive or ctDNA negative, these patients benefited from adjuvant phase of the treatment as well. So unless new trial comes in and more investigations come through that tells us more, I will recommend that we should use adjuvant durvalumab as well. I can tell you that at ASCO GU, there will be some data that we are presenting that is looking at depth of ctDNA. So not just ctDNA positive or ctDNA negative, but depth of ctDNA will also hopefully help us to pick patients who may actually need or may not need adjuvant treatment. So I think watch this space. We are only on the tip of the iceberg when we are looking at ctDNA. So I think investigating and understanding ctDNA more, basically dissecting it within clinical trial settings will give us much more information. So overall, I will say based on safety, toxicity data, I will recommend the use of adjuvant durvalumab, basically both in neoadjuvant with chemotherapy followed by adjuvant settings as well, because that's what the data tells us, and we should follow that in that sense. One thing I will just highlight is that cisplatin ineligible patients, which is 20% of those patients in the Niagara trial were actually GFR 40 to 60. And it is important to remember that Niagara actually increases the spectrum of patients who will be able to receive cisplatin-based neoadjuvant chemotherapy. So that's another big step that we're taking here in bladder cancer.
Thank you very much. So moving on to Dr. Faribo's surgical perspective, really. So we're using more and more systemic therapy pre-op now, and then we're starting to use perhaps now immunotherapy, and then in the future maybe this antibody drug conjugate. So what's your opinion with regards to the outcomes of surgery? Are there any concerns? And what do you think as medical oncology we should do really to get patients to you on time?
Thank you very much, Dr. Said Hamad. Do we have any urologists here in this room? No urologists, so I can't say anything. Minority. So actually, as a surgeon, urologists, we have learned and we love to remove the disease and think that job is done. And this was true, especially at the era of the chemotherapy. And when you had, for example, for the kidney, the tyrosine inhibitors and so on. But with the new immunotherapies, ICI and the ADC, the story is completely changed. We have to learn as urologists, we have to learn that you can help us a lot. Radical cystectomy, believe it or not, can have up to 10% mortality, up to minimum 30% of morbidity, and as also was mentioned by Professor Hussein, almost about 50% of recurrence or metastasis within 5 years. So it's not the best option. And the new immunotherapies or the ADT in future can help us a lot. Of course, there are some challenging during the surgeries. One is that, as I said, as urologists, we always like just to remove it. So it's difficult for us to wait for 3 or 4 months but we have to be more patient and we have to wait. During the surgery, usually because of the fibrosis and adhesions, we will have difficulty. But again, honestly speaking, we had a lot of experience with such surgeries after chemotherapies that we had before. There are a lot of fibrosis adhesions. The operation is more difficult, but in an experienced surgeon, it is doable and the risks doesn't increase significantly. It may delay the treatment, it may delay the hospitalization, but there is no any other issues. In regards to wound management, also there are some challenging issues with the new therapy, but also it is treatable and is not a big concern.
That's quite reassuring, really. So moving to Dr. Jawahir.
Dr. Sayed,
Yes, sure,
just
please.
what about the data on the perioperative keynote trial 905? Can you comment? Do you think that's going to become a standard?
Think at the minute, based on the data we have, yes, the data looks very exciting, hazard ratio 0.4 and 0.5. So that definitely may change the practice as well. I agree with you completely. But I think we need to dissect the data a little bit more. As I said, the mortality was about 8%, 13 deaths in the experimental arm, 9 deaths in the control arm. Similarly, we need to look at a little bit more of follow-up data as well in terms of looking at neuropathies and other toxicities that happen in these cases. There was skin toxicity as well. So a lot of these things that still need to look at a little bit more long-term follow-up. These were cisplatin ineligible patient population, but remember that 40% of the patients actually had GFR above 60 mils per minute. There were patients who declined chemotherapy, hearing impairment, and a lot of debate going on whether more patients will have hearing impairment for the sake of getting EV plus P as well. So a lot of things are in the air at the minute. I think the keynote 904, which is being presented in cisplatin eligible patients at ASCO GU, will be really key. That in fitter patients population, how the treatment was tolerated. 57% PATH CR in cis ineligible is really exciting figures because some of these patients may actually be cured. And there's definitely an appetite for studies with these drugs to see actually some of these patients may actually continue with organ preservation options, surveillance and things. So I think there's a lot to learn and a lot of exciting things that will come out. But I will always say that do follow these patients a bit more to look at toxicity. And as we talked about, 50% already been cured by surgery. Always need to be very careful about when we are adding new treatments into these regimens. What is the cost in terms of toxicity apart from financial toxicity?
Thank you very much. So, Dr. Jawahir, you talked about effective first-line therapy, and recently we had data presented from Prof. Said Hussain as well with regards to limiting the cycles of chemotherapy in Javelin 100 sort of strategy. So how do you see that data? Because after the first line AV Pembro, there's limited options, so we can't really have much to sequence. So are you going all patients AV Pembro, or you think there's no role for maintenance strategy anymore?
In clinical practice, thank you for that question. Nearly all patients I'm considering EV Pembro. Selected group of patients, yes, I am considering chemotherapy followed by avelumab. Currently, I'm not using Nivo plus chemo, but I can still see a subgroup of patients with lymph node only disease. Response rate is almost 80% for lymph node only disease. So you can consider, but as per all the guidelines, EV plus Pembro with the impressive data that we've seen earlier, it is a preferred category 1 recommendation. But for selected patients, either for cost or for access or for other reasons, basically, you can consider chemotherapy followed by avelumab. Majority of the patients you are considering of 4 to 6 cycles really, and as per the discussion earlier, the DISCUSS trial showed that you can restrict the number of cycles up to 3. But when we're giving platinum-based chemotherapy, you want to optimize your response because immunotherapy alone, the response rate is quite poor. So typically when we use platinum-based chemotherapy in practice, you need more than 3 cycles really. So in clinical practice, we are aiming for up to 6, or as far as you can get an optimal therapeutic response or an added response, then you can go for maintenance avelumab. But avelumab is a very easy drug to use, but I have very few patients on maintenance avelumab.
Maybe the same question from Dr. Ashur or Dr. Mukherjee. What's your strategy in sequencing those patients? Is you preferred first line, also EV Pembro?
fantastic presentations and really clear data. So we have very good data for EV Pembro, but it's just not accessible to all of our patients. So I think the guidelines are quite clear. If EV Pembro is not an option, then we go to the second options. And definitely in my practice, we have patients that can't access EV Pembro who have either chemo, Nivo, or start on chemotherapy, and if they do well, continue on maintenance of avelumab. We were just discussing the discus data. I really feel that this is very important data for patients, particularly those who are, having toxicity from chemotherapy, and the psychological benefit of telling the patient, you just do 3 cycles of chemo and then you can have immunotherapy. So that's something that I have adopted in my practice.
As Dr. Gawahir and Bora said about the EV Pembro or chemotherapy, I think all patients should be offered EV Pembro first. But we have in the community now criteria of enfortumab eligibility. Should be fulfilled at first. If the patient is eligible for enfortumab, we can offer them. Otherwise, we can give the chemotherapy. Despite of the real-world data of chemotherapy and avelumab is in favor, the overall survival benefit is not much different between the EV Pembro and the chemotherapy, but all guidelines or respective guidelines offer EV Pembro for the patient. For that, all patients should be have the EV criteria. If it is eligible, we need to offer. Otherwise, if we have any limitation, like Dr. Gawahir said, we can give chemotherapy.
Moving on to radioligand therapy, let me get Dr. Batul in with us. So, Dr. Batul obviously very active in terms of providing all the new treatment for us in Dubai Hospital. So you've seen a lot of data now, radioligand therapy coming early. So how do you see this for our patients in Dubai Hospital? Which patient do you think are the ideal candidates that we should talk to you about, and how to select those patients in the clinic?
Assalamu alaikum and good morning. Thank you, Dr. Said Hamad and team for inviting me to share few concepts of radioligand therapy. This was possible only with oncology and neurology support, and we are doing a range of therapies, not only radioligand therapy for prostate cancer, but also we have included alpha therapy with actinium-225, which is a very good, let's say, game changer and in benefit for patients. For patients who are eligible, there are some criteria from nuclear medicine and molecular imaging as per international standards, and there are some criteria from oncology part. From nuclear medicine point of view, all those patients who are having a positive PSMA PET, that usually means uptake more than the background or liver reference. These are patients who are eligible for radioligand therapy. All patients who underwent androgen receptor inhibitor and multiple line chemotherapy and they did not respond or they were resistant, these are also included. And also, in addition, those patients who are not suitable for chemotherapy from some point of view or other comorbidity, and those patients who are refusing to have chemotherapy, we have treated 2 patients. One patient as first-line therapy. He had a very good response, despite that he didn't have any chemotherapy or hormone therapy previously. And another one that we treated before chemotherapy with Pluvicto. So these are the patients who are eligible for radioligand therapy.
Thank you very much. Dr. Munir, assessing response sometimes can be a challenge, So how many cycles do you do before assessing response? Should we be concerned about PSA not responding yet? And the second question in regards to sometimes there's a dose delay because the myelosuppression is not recovering. So how long should we wait And sometimes you're concerned with this myelosuppression disease progressing, or is it due to the radioligand therapy?
So again, thank you for inviting me to do the presentations as well as join the panel. Yesterday, I gave in the evening a presentation on the treatment response assessment. There are multiple parameters that are already out with evidence-based approaches. The one that is most predictive is the total lesion SUV mean. In other words, you take the SUV mean and then you combine it throughout the body and add that all up. That has become one of the very strong predictors. Unfortunately, as Dr. Batul can tell you, that if you need to do that completely manually, it takes a long time to derive the ROIs over each lesion. Currently, we are using the AI to help us, which reduces the time by about 75%, but it's still cumbersome. There are a lot of efforts going on in making it very effective and very efficient. At that point, it will become very common. Currently, as you heard earlier, uptake greater than liver is a good predictor. There are actually data now maturing quite significantly that if you have the, just looking at the total, instead of total lesion, just look at the SUV mean and SUV max. And if it is more than 10.6 SUV mean, it is a much stronger predictor than SUV mean of less than 6.6. That data has been very well publicized from the group in Australia, and that is very easy to get. It takes only a matter of seconds to get that. In terms of the patient selection, you also need to know their platelet counts, their hemoglobin, and also absolute neutrophil counts to make sure that that's tolerable. Prior treatment and comorbidities are also important predictors. But it's good to know now that there are multiple factors that are maturing to predict which patients will respond best and which patients should not be treated. For example, if you have multiple hepatic lesions that are cold with photopenia on PSMA PET, that's one of the worst predictors of poor outcomes. So you need to select those patients and target them with other forms of therapy rather than radioligand. Fortunately, that's a minority. And I wanted to end with the question that Dr. Deborah Mukherjee had mentioned about the renal cell. We are participating in trials that are looking at carbonic anhydrase 9 targets. There are also other novel targets coming up. Interestingly, a subset of these patients also express PSMA as well. So there are multiple diagnostic and therapeutic targets coming out in renal cell carcinoma as well.
Thank you very much. Dr. Ashok, you talked about PARP inhibitors. So now we have combinations available. So what are you doing in your clinic? Because there's some data suggesting it may be suitable for all patients. So are you selecting your patients based on the molecular profiling? And the challenge obviously is we already use RP for majority of patients in the clinic. So how are you selecting those patients?
Actually, at first we are doing for all patients molecular biology, molecular profiling for all patients, especially in MAC-RPC. And we have the ctDNA and we have the tissue. We are doing subsequently both for all patients. And sometimes we have discordant between both, between the tissue and between the ctDNA. This is happened many times with both. The selection is depend on the molecular biology. In the protocol, we have the post protocol, we have the Talapro protocol, and we have the Propel protocol available in our site. And the selection is depending on actually the real molecular profiling, especially with BRCA. If we have BRCA mutations, we will go directly for combination as a first line. Despite of the patients have previously received ARPIs, we are giving the treatment. Despite also in all the trials not exposed, all patients in the trial not exposed to ARPI in the previous lines, but the data support to give in patients with BRCA mutations a combination regimen. The combination regimen is in patients with BRCA mutation. Other HRR mutations, we are hesitating to start, especially the ATM mutations. So if we have BRCA mutations, we are encouraged to start the first line treatment with combination treatment. Otherwise, we are thinking about the most successful treatment, we can choose other than the ERPs. So the three-marker BRCA and CDK12, and this can be used as the first line for us.
Dr. Jawahar, yes.
Just to add to that, I'm using it for all HRR mutations because I think there's no evidence that some of them doesn't work. We've got many studies to show that some of the rarer HRR mutations actually respond and they can respond for a prolonged period of time. So I cannot say that some HRR mutations PARP inhibitors are not working. I'm using monotherapy and combinations as well. For patients who have done well on one line of ARPI, I'm considering further line of ARPI. Sometimes the less common HRR mutations I'm not using earlier on. We can use it later on, perhaps PARP inhibition. For instance, if you have PSMA avid disease and a less common mutation, I'm using lutetium earlier and using PARP inhibitor later. If you have a BRCA mutations, of course, I'm using PARP inhibition earlier. And combinations, although I was quite reluctant when the initial data came up for the combinations because we had used ARPIs earlier in castration-sensitive disease, the more I see in clinical practice, majority of these patients have only up to 3 treatment options, really. If you look at it realistically, when you're sequencing an MCRPC, there's hardly any treatment options. If you have something effective and you feel that the ARPI may augment the treatment response of a PARP inhibitor, I would encourage using these in combination, particularly if there are patients who've had 2 to 3 years of response to one line of the RPI. So I would encourage combinations because it may augment the response for some patients. Thank you.
Thank you very much. Now, Dr. Deborah showed us the data for first line briefly, which is amazing. But before I go to you, I just want to ask Dr. Fariborz with regards to cytoreductive nephrectomy in patients with metastatic disease, metastatic RCC. Do you still see the role for cytoreductive nephrectomy? And if you, which patient would you select?
Good question. My experience and traditional thinking, yes, but the new studies convinced us better not to. Unless if there is any specific indication like bleeding, pain, local issues, otherwise better not.
Okay. Anybody who wants, Dr. Jawahar wants to say
Sorry.
something? Okay.
So I still use or refer patients for cytoreductive nephrectomy, particularly those with low volume disease and sometimes deferred cytoreductive nephrectomy, patients with excellent response to our immunotherapy drugs. They don't respond as well sometimes in the primary site. TKIs actually have a good response in the primary tumor. So when patients have actually got a good response, we try to debulk them as much as possible, particularly because majority of these treatment options you have to continue indefinitely, and sometimes cost becomes an issue, toxicity becomes an issue. So if you can debulk these patients and target certain sites of metastatic disease, particularly in low volume disease, we are going aggressive for some of these patients, especially now it is becoming quite chronic. So we are quite aggressive. And those with low volume disease, particularly if kidney is the big tumor volume, a few lung mets here and there, we encourage cytoreductive nephrectomy and continuation of systemic therapy up until is required. There are many patients have stopped systemic therapy after cytoreductive nephrectomy and targeting the sites of metastasis.
Just to add on, I completely agree with Jawahir. I mean, in UK as well, although we look for more setting up of trials in this arena, most of the cytoreductive nephrectomy data is based on TKIs. In the era of IO plus IO and IO plus TKI, I think there definitely is really appetite for bigger trials and better trials. But with low volume disease, definitely this should be considered as well.
Very selected patient, obviously, that we bring to the MDT. So maybe ask Dr. Mukherjee with regards to some patients. We have a clinical situation when you have one functioning kidney and you have a tumor in that kidney, and Dr. Fariborz says only treatment is nephrectomy. Have you considered in your MDT thinking downstaging this with excellent treatments and try and do a partial? Because I've seen some cases, case reports. So what should you do in your clinic?
That's always a very tricky MDT discussion. There are some limited phase 2 data about downstaging tumors, particularly with the TKI element. So this is commonly done in clinical practice, but again, it's a case-by-case basis. For the patients who have more advanced disease, tiny lung metastasis, the option of deferred nephrectomy or even deferred partial nephrectomy is definitely an option, and that's something that we've been doing very frequently. So I think all of these patients are to be discussed repeatedly in the MDT, not just at the first diagnosis, because it really depends on the patient characteristics and their response and their predicted outcome. Because we're seeing renal cancer as a chronic disease now, and patients are chronically on therapies, and we have some interest, as in prostate cancer now, on de-escalating therapy. So if these are the patients that may benefit from deferred cytoreduction, and if you can do a partial, why not?
This means we still need urologists and urobots ready for our patients. Yes, Dr. Hassan Ghazal has a question.
Just a couple points. On the belzutifan, do you think we may end up needing some biomarkers for better choosing patients for these drugs?
So biomarkers in kidney cancer are very challenging. So I think that the answer at the moment is no. With belzutifan, our real clinical benefit is going to be in combination. Single agent in patients who have von Hippel-Lindau disease, that the combination treatments are the ones going to give the results in metastatic and the adjuvant treatment. So we're going to have 2 phase 3 studies presented at ASCO GU. One is the 011, the combination in patients who are IO-TKI refractory, that's positive PFS. And we have a new positive adjuvant study of pembro and belzutifan in the adjuvant setting. So we're seeing the data in a few weeks. So I think combination is going to be the key for this drug. Biomarkers, again, we have one biomarker, which is the patients with VHL. Can we have any other biomarkers? There's lots of work going on, but we've had 15 years of biomarker work in advanced RCC and nothing on the table yet. So I wouldn't hold your breath, but let's celebrate the positive phase 3 trials coming up in combination setting.
And then one last point. Nobody spoke about the alpha particle versus beta particle. Where with the P3 data and survival advantage, any role for the alpha particle versus lutetium?
Yeah, so there are several trials using not only alpha versus beta, but they're also looking at Auger electrons as well. So terbium, lead-212, actinium-225, as well as some of the other novel beta, such as copper-67. There is some concept about true theranostic pair. In other words, if you have a chemical labeling to a target on diagnostic scan, how reliably that predicts the treatment. And if you switch between the isotopes, there could be some misregistration of what predicts on the imaging as opposed to what happens in real life. So there are some attempts in developing ideal theranostic pair, for example, copper 64 and 67. So this is still a wide open field. In fact, at Cornell in New York, there's a trial going on combining both alpha and beta. Also, Australia has worked on some of these trials as well. So it's still open field. I think there will be some role of alpha. The question is it going to be sequencing after beta or frontline using alpha first? All of that, I think within the next 5 to 7 years, we'll get the better answers on those.
Thank you very much. This was an excellent discussion. We'll close the session now and we'll start the next session. Thank you very much.
Thank you for the excellent discussion. So we have our next session is a satellite symposium. Dr. Saeed Rafi, he doesn't need any introduction, consultant medical oncologist in City Hospital Mediclinic. So he will be talking about treatment outcomes in advanced renal cell carcinoma across first line and beyond.
Thank you. Thank you. Thank you very much indeed, Dr. Farouk. Highly appreciated. Again, really congratulations to the organizers. There are a few things about this talk. Is that first of all, they asked me to do this one first line and beyond first line in 15 minutes, which is absolutely impossible. And next one is that Dr. Deborah thankfully came to rescue and did a little bit of work on the subsequent line therapy. So thank you so much. And unfortunately, I don't have any pictures with robots to show you. Basically, starting with the case presentation of this 37-year-old gentleman who was diagnosed with a T3 and 0 RCC in 2018 and had a surgery, but unfortunately later on, 2 years later, came with plenty of lung metastases. And, he had a intermediate IMDC prognostic criteria. So what do we recommend for these patients? And if you look at the IMDC criteria, we know that these patients with intermediate risk, they actually do worse than the one with favorable risk. So at 24 months, we can see that nearly half of these patients, unfortunately, they die. And just looking at the historical data, this patient's been treated previously with interferon and then sunitinib. You can see that the differences that we had. And then, interferon was giving us around 5 months of PFS. With sunitinib, it became around 11 months, and the overall survival around less than 2 years. And now we have plenty of data, obviously, and plenty of other options. And Dr. Deborah showed on those very nice in the morning corn boxes. These are the NCCN guidelines they are suggesting to do. Just reviewing the data, obviously, the first one is Keynote 426, and the Keynote 426, these are untreated patient first-line setting. Basically, 800 patients put on two groups, one group to receive pembrolizumab and axitinib, and the other one, the comparator arm, which was sunitinib. They put all patients different IMDC risk groups, including around a third of patients. These are the patients with favorable risks. And of course, the PFS was significantly improved in favor of pembrolizumab and axitinib, around 4 months, hazard ratio 0.69. And later on, we had the overall survival, which was again in favor of pembrolizumab and axitinib. The response rate was certainly better, around twice as much with pembrolizumab as axitinib compared with sunitinib. And then we look at the favorable risk, it is not inferior to axitinib, but didn't actually do much difference, although that the PFS was to a trend, although that not statistical, definitely in favor of pembrolizumab and axitinib, and certainly response rate is better with pembrolizumab axitinib compared with sunitinib. It was certainly different story and much better results, statistically significant difference both in PFS and overall survival in favor of pembrolizumab axitinib compared with sunitinib, and certainly response rate better as well. When you look at the overall survival adjusted for the treatment post-progression, it is definitely improved with axitinib pembrolizumab compared with sunitinib. And then you look at patients with post-progression, the treatment is for 2 years, obviously, and then after treatment for 2 years, you can see there is a significant number of patients, they have not yet progressed, and then overall survival is certainly very, very significant and reasonable. This is the sarcomatoid subtype. They do, unfortunately, much worse all the time. And you can see that although we have a little bit of improvement in the PFS, maybe not much really in terms of the overall survival benefit. And then the adverse events we are all familiar with, certainly very comparable with sunitinib and definitely not worse. We have another data, obviously, with clearer study, which was combination of another TKI, lenvatinib with pembrolizumab, very similar study design, although that it was 3 arms. One arm was lenvatinib pembrolizumab, lenvatinib everolimus, and sunitinib. I'm not going to mention about the middle arm, concentrating more on lenvatinib and pembrolizumab at the moment. So again, it included patients with favorable, intermediate, and poor risk, and majority of patients, they are favorable and intermediate, around like 9 to 10% of patients, they were kind of poor IMDC risk. So when you look at the PFS, you can see that certainly it is improved with lenvatinib and pembrolizumab. In fact, lenvatinib and everolimus was also better than sunitinib as well. All the subgroups, they benefited from lenvatinib and pembrolizumab. Looking at the len pembro arm, again, it is improved. the PFS in the intermediate and favorable risk, certainly improvement in lenvatinib and pembrolizumab. And the final OS analysis, you can see that again, it is in favor of lenvatinib and pembrolizumab. Looking at the subsequent anti-cancer therapy, which was given after the progression of the disease, adjusting for those treatments, again, the overall survival analysis is in favor of lenvatinib and pembrolizumab, which is for almost all of the subgroups benefiting from this combination. Again, looking across different type of subgroups, overall survival is mainly improved in intermediate and poor, and certainly not inferior to sunitinib in patients with favorable IMDC criteria. When you look at the objective response rate, certainly it is again, superior to sunitinib alone. And we probably have one of the best response rated with this combination of lenvatinib and pembrolizumab compared with everything else that is available at the moment as well. It is certainly a combination that makes a little bit of a side effect, so you have to be careful about hypertension, diarrhea, and fatigue, and etc. But these are the side effects that we are certainly very familiar with. We are using this combination in other type of cancers, including uterine cancer. So we are, medical oncologists are fairly well versed how to address those side effects as well. We certainly have other combination, as we have seen in the previous presentation. One is Checkmate 214. This is a design of Checkmate 214, and that is ipi/nivo compared with sunitinib. At ASCO last year, we had 9 years follow-up data presented. Again, this is the PFS, as you can see, certainly in favor of ipi/nivo. One thing here to look at is that we start to have separation of the curve a little bit later on. With majority of the patients, unfortunately, they do progress within the first 18 months of the treatment. There is probably no difference between sunitinib and ipi/nivo until later on, when you can see that the curves start to separate. And again, the OS is more or less the same as well. You have a little bit of a close running of those curves together until around 12 months, when they start to separate and continue to be separate. But it is certainly a very valid option, and certainly is reducing the risk of death by around 29%. The OS is, again, it is beneficial in favor of ipi/nivo in all subgroups as well. Again, looking at the OS in favorable risk, you see that probably not much difference in the favorable risk. PFS is definitely better with, you could argue with sunitinib, and duration of response as well. When it comes to intermediate and poor risk population, certainly there is benefits in favor of ipi/nivo, although again, as we discussed, the curves, they're running very close together until later on and start to separate, but they continue to be separate as well. The overall survival, the objective response rate is definitely better with ipi/nivo, although you could argue that we have better data with pembrolizumab and lenvatinib, as we have seen before. These are the adverse events that you can see with ipi/nivo. Majority of these things, they will settle down after a few months of starting on the treatment. We have another clinical trial with nivolumab and cabozantinib, Checkmate 9ER. Again, this is the design of the trial, again, comparing with sunitinib as a standard of care. And this is the patient characteristic, very similar to what we have from before. A little bit more patients on poor IMDC prognostic criteria, around 20% of the patients. PFS and OS in the ITT population. Here you can see early separation of the curve. Again, it is in favor of nivolumab and cabozantinib. OS the same as well. It is in favor of nivolumab and cabozantinib. in the favorable risk, you can see that still we have very close similarity to the previous treatment, probably not much separation of the curve. The overall survival is definitely non-inferior, but it is not so much superior also to sunitinib. But when it comes to intermediate and poor risk, we have more separation of the curve in those group of patients, as you can see here as well. And these are the response rate and the durations. You can see again, we have more responses compared with sunitinib, with nivolumab and cabozantinib, and the duration of response is definitely also superior as well. And overall survival in the favorable risk, you can see that this is a comparison between different arms of those four clinical trials that we have. Very, very similar and not inferior to sunitinib, not much superior to sunitinib either. So in terms of the overall survival in the favorable risk, we have very, very similar data. When it comes to the poor and intermediate, you can see that actually, again, these trials, they are very, very similar together, and very early separation in clear keynote 426 and also checkmate in 9ER, a little bit later separation with Ipi-Nivo, but again, the tail end of the curve, it is going to continue to separate with checkmate 214, although that, we could argue in the other three trials, they are almost, exactly the same tail end of the curve as well. So really, it is becoming very confusing. That Deborah showed a very, very nice picture, but then again, this is what to do really in this group of patients, and exactly like what the Maktoum said, just pick one and choose it wisely, and then see what happens, and then certainly we continue to the subsequent line of therapy. In fact, it is so confusing that a couple of years ago, ESMO decided that we're going to bring all these experts in RCC and then see whether we can come with algorithm as which one to use. And when they actually asked those experts, these are 11 experts from around the world that they were asked to really give the opinion for patient. This is the favorable risk. You see that each of those A, B, C, D that you see, this is one of the international experts group, and they could not actually agree what to do with this one. The things are, it is even worse with the intermediate subtype. They could not agree with each other, and the same with poor risk factors. So in fact, it was decided that significant inter-expert variation was observed. This shows how data from randomized trial is interpreted differently when transferred to daily clinical practice. So again, this is what we're going to do, is that to basically pick one and choose it wisely. So what to do with the subsequent line of therapy? Deborah did an amazing job in reviewing that. So, whatever I say, it is like, as the English say, carrying coal to Newcastle. But again, you see that we have options with the TKIs, mainly in post-IO section. Axis trial basically tried to look at axitinib versus sorafenib, and then you see that, it was certainly axitinib was better than sorafenib. Meteor started to look at cabozantinib versus everolimus, certainly a superior treatment in the post-progression setting as well. Again, this is the final overall survival analysis, which was certainly in favor of cabozantinib. Lenvatinib and everolimus has been also investigated in this setting as well in post-progression, and certainly it does better than compared with lenvatinib alone in terms of the PFS. So the options there really, we have the, if the patient has been previously targeted with VEGF only or IO after IO, Deborah mentioned that really we have not unfortunately had much luck with IO after using IO, whether we have new targets and other ongoing trials. So Cabo Point basically look at the patients that they receive cabozantinib after progression of the disease, and response rate you can see in different cohorts. Response rate something between 25% and 31%. Breakpoint trial looked at the cabozantinib at a higher dose of 60 milligram And certainly, I think, you see a deeper response. In fact, I have one patient, a similar patient. This patient, I started him in 2020 on axitinib and pembrolizumab, continued for 2 years. After 2 years stopping, he had a progression of disease, started him on cabozantinib at 40 milligram. He progressed. And I saw actually a phase 2 clinical trial at that time. It was a pembrolizumab plus 60 milligram of cabozantinib. And although he had progressed on on pembrolizumab and axitinib, somehow I started him on, or increased the dose of cabozantinib from 40 to 60 and started him back on pembrolizumab. He had 18 months of not progressing. And actually some response initially with combination of pembrolizumab and 60 milligram of cabozantinib. So certainly in some patients, increasing dose of cabozantinib may work, although that I don't advocate to start back on pembrolizumab if you have already progressed on pembrolizumab. Tivozanib, Dr. Deborah mentioned, it's unfortunately a negative trial, as you can see from here. And then looking at real-world data to see how cabozantinib is doing after immuno-oncology clinical trial, response rate roughly around the 37% in those group of patients. I've been certainly with patients with liver metastasis, they do better. IO after IO, we discussed it. It is not working. Contact trial was negative as well. And I'm not going to spend much time. Atezolizumab has been negative in that, so both in terms of OS and the response rate as well. How about new targets? Again, HIF2 inhibitors with belzutifan. It is working very well, as Dr. Deborah also very nicely reviewed. LightSpark 005, basically randomized patient between having belzutifan and everolimus, which was the standard of care at the time of this trial. And it was certainly in favor of belzutifan. My patients on the third line therapy, he progressed with metastatic disease in the myocardial cells, chest wall metastatic disease, rib metastatic disease, a lot of muscle metastatic disease. And although that he does not have any VHL, I started him on belzutifan. He is currently 18 months of belzutifan and is still having an ongoing response with response to the treatment as well. So again, it does work as a single agent on some groups, but we are eagerly waiting to hear from the LightSpark 11 trial as well. And again, you see that the OS, as Dr. Deborah mentioned, was not so positive. So we're just eagerly waiting to see that OS benefit in that group of patients. Certainly a very good response rate, hoping that in a combination it is going to perform better as well. Patient-reported outcome is actually, when you look at compared with everolimus, is actually much better. So, you could argue that hopefully belzutifan will continue to be beneficial in this group of patients as well. So the FDA has approved, obviously, belzutifan as a later line therapy for the patient. We have a Contacta trial, telaglenastat plus cabozantinib, and that has not been so positive, although that you could see a slightly improvement in the PFS, but in the majority of time it is there. So as it stands, really, and this is my my last conclusion, for most patients these days, they are receiving IO-based combination. There is no consensus and certainly no benefits in adding another IO after the IO. After IO TKI, TKI, probably they got the best data at this moment. There is certainly a gap, as we mentioned before, in terms of the biomarkers and everything, mechanism of progression of the disease, both on IO and IO VEGFI. And although that we really want this one to look like this, that we have a clear first line, second line, third line, and so currently I think things are a little bit similar to this at the moment. So we are just eagerly waiting for more data. Thank you so much indeed for that.
Thank you, Dr. Rafi. I think that concludes our first session. So we'll break for 10 minutes for coffee. We'll be back by 11, inshallah. Please try to be on time. Thank you. Assalamu alaikum. I think we're ready to start our next session. If I would like, yeah, I would request all the attendees and speakers to please settle down. So we have quite exciting session. We have 4 speakers. I have Dr. Nouri Banini with me to moderate this session. So let me introduce our first speaker, Dr. Imad Daoud. In fact, he doesn't need any introduction. We know him very well. He's a consultant medical oncologist and head of oncology in Tawam Hospital. So Dr. Imad will be giving a talk about perioperative therapies in early stage non-small cell lung cancer.
So good morning, Assalamu alaikum. Thanks, Dr. Farouk, for this lovely introduction, and another thanks for the PMOC organizers for inviting me for this talk. So good morning, ladies and gentlemen. It's my talk to talk about the preoperative therapies in early stage non-small cell lung cancer. Something which is, I think it changed the treatment paradigm in non-small cell lung cancer. So this is my disclosures. So if you're looking for the non-small cell lung cancer early stage, actually there is unmet needs where stage 2 and stage 3, the 5-year survival, talking about around less than 50% of the patient, they survive 5 years. So there is unmet needs, how to improve the outcome for those patients. There are different strategies, go for surgery followed by adjuvant treatment, or neoadjuvant followed by surgery and no adjuvant treatment, or what we call the perioperative approach, and this is the task has been given to me. So why neoadjuvant treatment? So what we know that from the traditional chemotherapy, the neoadjuvant treatment, it did improve the 5-year survival by 5%. But the response rate is modest, talking about 40 to 50%. Pathological complete response in average less than 10%. And most of the patients in these trials are stage 3, and no doubt that the MDT discussion is the key role here to decide about the treatment for those patients. So what about immunotherapy in the neoadjuvant setting? We have data for immunotherapy as a monotherapy in neoadjuvant setting where the immune checkpoint inhibitors actually showing a promising activity. It did improve the resectability, and we have more than 80% of the patient, the resection rate as a immunotherapy monotherapy response rate, really promising, up to 27% of the patient, they achieved the response, major pathological response, up to 45%, and PCR in some trials as a monotherapy up to 29%. But definitely when you combine immunotherapy with chemotherapy, there is some synergistic efficacy and the outcome is much better. Talking about the objective response rate, crossing the boundary of 75%, major pathological response up to 83%, and PCR, some trials up to 63%. So if you're looking for the resectability in local advanced non-small cell lung cancer, the guidelines telling us if there is no contraindication or if your patient is eligible for immunotherapy, they prefer to go for the neoadjuvant immune chemotherapy followed by surgery, and as an option, adjuvant immunotherapy. So why that? Because it will give like an data about the tumor down staging and improving the post-surgical outcome. Patient, they already have a good tolerance to the immune chemotherapy, and to understand about the biology and to plan what is your adjuvant treatment. But on the other hand, you are delaying the curative treatment for this patient, which is the surgery. There is some risk of toxicity, and some of the patient even will not go for the surgical resection. So in the perioperative or in neoadjuvant, we have 2 strategies. Neoadjuvant chemoimmunotherapy followed by surgery only. We have data from the CheckMate 816. And for the perioperative approach, adding immunotherapy chemotherapy, 3 to 4 cycles, followed by surgery. and 1 year of immune checkpoint inhibitors. We have actually 5 clinical trials: Keynote 671, Asian trial, Checkmate 770, New Torch, and Rational trial. And this is the design of the trial. Probably all these trials are similar when it comes to the design, the adding immunotherapy to chemotherapy followed by surgery. Only one trial did not add adjuvant immunotherapy, which is Checkmate 816. And this table summarizes the differences. It's not comparable or not to compare trial to trial. Although they are pretty similar, but there is some trial such as the Keynote 671. I see it's a little bit different even in the design. It's the only trial which is 100% of the patient receive cisplatin as chemotherapy as a backbone. It's the only trial including patients with driver mutation EGFR and ALK patients, and it's the only trial included OS as a co-primary endpoint. So Keynote 671, it's a phase 3 trial, as I mentioned. It includes patients with stage 2 up to stage 3B. Pneumonectomy was allowed. 43% of the patients are squamous histology. 1/3 of the patient PD-L1 negative, and they allowed EGFR and ALK. 100% cisplatin chemotherapy backbone. That trial is positive. It did improve both event-free survival as well as an overall survival. Pathological complete response 18%, and measured pathological response took about 30%. We have data also from Checkmate 770, which is pretty similar design. By adding nivolumab to the chemotherapy compared to the chemotherapy for 4 cycles followed by surgery and 1 year of adjuvant immunotherapy. Again, it included patients stage 2 and stage 3B into disease, 51% squamous histology, and the PD-L1 a little bit higher here, 41% of the patient PD-L1 negative tumor, no driver mutation allowed, and cisplatin here in this trial only 21%, majority are carboplatin. Surgery was being carried in 78% with R0 section 89%. We have positive events-free survival. Overall survival is still immature. It's again approved indication in the perioperative setting. Moving to the Asian trial, the same design, but here with the durvalumab, adding durvalumab to the chemotherapy compared to the same chemotherapy for 4 cycles, followed by surgery and 1 year of durvalumab. And again, stage 2 and stage 3B into disease. In this trial, probably they have higher patients with stage 3B, only almost 25% of the patients, and more patients with T4. So included a little bit more advanced stages, and surgery has been done in 80% with R0 section and around 95%, PCR 17%, and major pathological response 33%. We have positive events-free survival, but still overall survival immature. So eventually we have improved the pathological complete response and major pathological response. But what about the end-to disease? For many years, we are feeling shy to over surgery for this patient. We go for concurrent chemoradiation. So we have a meta-analysis showing that even for those into disease, whether these single station or multi-station, giving a chemoimmunotherapy, still we can improve the events-free survival in this group of patients. What about the patient with stage 2? Should we go for the perioperative approach or neoadjuvant, or should we go for the chemotherapy, surgery followed by adjuvant immunotherapy? And you can see here in stage 2, also the patient, they have a significant improvement in the events-free survival as stage 3. What about the PD-L1 negative tumors? You can see here, even for the PD-L1 negative tumors, also they drive the same benefit as the PD-L1 positive tumors in this meta-analysis. But still we have an open questions. Should we go for the neoadjuvant or the perioperative approach? If you're looking for the data from the nivo chemotherapy, if you give adjuvant immunotherapy, you have significant improvement in the events-free survival. The same for neoadjuvant, but there is a sharp drop in the curve. Almost 40% of the patient will progress if did not receive adjuvant immunotherapy. The same data from the Asian trial, almost 50% of the patient, they will progress if did not receive adjuvant treatment. So this encouraging the use of adjuvant treatment or the perioperative approach. I addressed the PD-L1 negative subgroup and stage 2, but what about the PCR? do we reach a plateau? Can we improve the PCR for these patients? And what about the patient with other rare driver mutations such as MET and RET, which is usually common in non-smokers? Most of those patients do not benefit from the immunotherapy. So how we can improve the pathological response or measure pathological response? This data with regard for the oculumab, which is a drug targeting the CD73. It's from AstraZeneca in combination with the durvalumab. We don't see major improvement in the PCR or major pathological response, but in the same trial, we have monalizumab, which is a drug with targeting the inhibitory receptor in the NK T cells and CD8 cells. It's actually increasing the PCR as well as the major pathological response. But what is really striking here, adding dato-DXd, which is ADCs, to the chemotherapy and durvalumab, you can see we have an PCR almost 35% and major pathological response of 66%, which is really promising, and probably we'll see this combination in the near future. But how we deal now with the patients, probably personalized approach based on the PCR or major pathological response, it might guide us how to deal with the patient. So if your patient achieve complete pathological response, probably this patient, they have a good prognosis, and you might de-escalate the adjuvant part. Should we use the circulating tumor DNA to guide us? We have data from AGN trial. If ctDNA negative, those patients already will have a good prognosis. It's still an area of research. What about the patient, they achieve partial response? It's still the major pathological response in 1 to 10%. So those patients, they have intermediate prognosis, and probably those patients, we should give adjuvant immunotherapy and preferably the same immunotherapy given in neoadjuvant part. Problem for the patient where the major pathological response does not achieve, no major pathological response, where more than 10% of the viable tumor cells are there. Those patients, by definition, they have poor prognosis, and we need to escalate the treatment here. Should we add double immune checkpoint inhibitors? Should we add ADCs or the bispecific immunotherapy? And I think this is the area of another research. But just to remind you that we have pooled analysis comparing the neoadjuvant to the perioperative from the CheckMate 770 and the CheckMate 618. And this trial showing that perioperative is better than the neoadjuvant alone. And probably patient with no PCR, they have the magnitude benefit. If achieve PCR, probably you can save the adjuvant part. The benefit was mainly driven by PD-L1 negative tumors. With the PD-L1 positive tumor, there was no major benefit. What about the patient with driver mutation? We have data from the new ADORA trial in patients with EGFR mutation positive. And the rationale of this trial, because we have the ADORA trial, but in ADORA trial, after surgery, you have to give adjuvant chemotherapy before osimertinib. So you are delaying the most effective treatment in this group of patients. So why not to include the osimertinib as early as possible? So it's a phase 3 trial comparing adding osimertinib to the chemotherapy compared to chemotherapy or osimertinib monotherapy to the chemotherapy in patients with EGFR mutation. So the primary endpoint, they are looking for the major pathological response. In adjuvant part, the patient, almost 91% of the patient, they achieve osimertinib in adjuvant setting. And if you can see that the major pathological response, it was pretty similar in chemo osimertinib or osimertinib alone, but significantly adding osimertinib, it improved the major pathological response compared to the chemotherapy, which is only 2%. And 91 up to 95% of the patient, they achieve R0 resection in the osimertinib group. But what is more important here, the conversion rate. So patient with N2 disease, when you give neoadjuvant osimertinib, more than 50% of the patient in osimertinib or osimertinib chemotherapy, the N2 disease, they have a significant down staging. Events-free survival also was significant in favor of osimertinib, whether osimertinib chemotherapy or osimertinib as a monotherapy. We have data also from afatinib, this team lung made 004, afatinib for patients with resectable or even potentially resectable tumors. So afatinib showing a response rate of 70% and 56% conversion rate for patients those are potentially resectable, or zero resection almost 88%, major pathological response 9%, and PCR in 3%. Umiluritinib, which is another anti-EGFR in lung made 007, it's showing a very significant conversion rate up to 45% with objective response rate 70%, or zero section 100%, and major pathological response 21%, PCR 13%. So it's also another promising option. What about the patient with ALK positive tumor? We have ALINO trial, which is a phase 2 trial addressing the role of alectinib in patients with resectable non-small cell lung cancer harboring ALK fusion positive. So they give 2 months of alectinib followed by surgery, followed by 2 years of adjuvant alectinib, and showing promising response rate 42%, pathological complete response 12% of this trial, and objective response rate was 67%. Still, we don't have mature data with regard to events-free survival, disease-free survival, or overall survival. But in early stage non-small cell lung cancer, it's not white and black. We have a resectable, non-resectable, but we have a patient with borderline resectability, such as patient into bulky multi-station or T4 invasive tumors. What to do for this patient if they are potentially resectable tumors? So we have the MDT bridge trial, which has been presented in last ESMO, looking for the, it's actually very smart design of the trial. So a patient those, as per the MDT discussion, they are potentially resectable or borderline resectable. They give 2 cycles of chemoimmunotherapy. In this case, they give durvalumab, and then do a reassessment, and again, discussion in the same tumor board. If they feel that becomes resectable, they give another 2 cycles, followed by surgery and adjuvant durvalumab. And after 2 cycles, it's not resectable, they proceed with concurrent chemoradiotherapy, followed by maintenance durvalumab. At the second assessment, after 2 cycles, those patients becomes resectable. They found that the response rate was 60%, and unresectable response rate was only 12%. And what is important here, the major pathological response in resectable tumors was 27%, which is really very significant. But still, the data immature with regard to the events-free survival and overall survival. What about the borderline resectability in EGFR mutation positive tumors? Just to remind you, we have the LAURA trial. In this group of patients, if you give concurrent chemoradiotherapy followed by osimertinib, it did improve progression-free survival, and there is strong signal about, regarding the overall survival, and we don't have any data to support to use osimertinib in this group of patients if they are not resectable. Other driver mutations, we have the cabozantinib for patients with MET amplification or MET exon 14 skipping mutations. Actually, the very smart design of the trial, it's 2 cohort for exon 14 skipping mutation, exon, and the MET amplification. They give cabozantinib for 2 months, followed by surgery, and giving 3 years of adjuvant cabozantinib, and chemotherapy as adjuvant was allowed. This trial is still ongoing, recruiting patients, and we're waiting for the outcome for this trial. So in conclusion, immune checkpoint inhibitors are now being moved earlier in the disease course of non-small cell lung cancer. Perioperative immunotherapy is a preferred approach to improve the outcome in early stage when it comes to events-free survival, pathological complete response, and overall survival. But the best treatment approach, it depends on the discussion in MDT. It's case-by-case discussion since there is no head-to-head comparison. But in general, we prefer the perioperative approach over the new adjuvant approach. Unless the patient achieve complete pathological response, you might able to de-escalate. For the EGFR inhibitors, we have data to support new adjuvant osimertinib and chemotherapy, or osimertinib monotherapy with events-free survival benefit. Alectinib, we have data from phase 2 trial, very promising. We're waiting for the phase 3 trial. And we have ongoing trial for other driver mutation, which was not included in the immunotherapy trials. With that, I would thank you for listening.
Assalamu alaikum. First of all, thank you for the organizing committee for inviting me and give me the opportunity to be part of this meeting. And secondly, thank you, Imad, for the excellent presentation. Our next speaker is Dr. Abdulaziz Al-Jassim, consultant oncologist in the thoracic team in the KCC. So after the early stage, we'll go to the advanced stage and the dynamic of immune checkpoint inhibitor in advanced non-small cell cancer. The floor is yours.
Thank you, Dr. Nouri, and thank you for the organizing committee to invite me today for this great meeting. So I have 15 minutes to talk about the dynamics and all what we know about non-small cell lung cancer, mainly in the advanced stage. So we'll talk about what our current practice is, and after that we'll have maybe some flavor of what's coming in our non-small cell lung cancer advanced stage. This is the cancer statistics from the American Cancer Society that was published 2 weeks ago. It's an annual report of all of the cancer cases around the United States. So a lot of changes. We can see here still breast cancer comes amongst the top 3 names of cancer or types of cancer in terms of incidence in males as well as in females. But we can also see here that in terms of fatality, lung cancer remains the first or the highest type of cancer with fatalities in the United States. And we can see here the percentage of fatalities in the male percent, which is almost equivalent to the sum of the prostate and colorectal cancer, the second and third in terms of mortality incidences. That's in the males as well as in the females. And we can see here that lung cancer in terms of fatalities also surpassed breast cancer. And this is something that maybe not very good and we need to improve. But also a very good fact that we saw from the American Cancer Society statistics that all cancer combined relative 5-year overall survival improved to approximately 70% for those people who were diagnosed with cancer during 2015 up to 2021. So that's another good and positive point we got from this report. And we can also see here there is a good and very meaningful drop in terms of fatalities, mainly in the lung cancer. And we can see here the curve has been shifting downwards and steadily going downwards after the 1990s and the year 2000. Also, that was in males and females. So what happened? And where do we come from? This is mainly the reason that those patients had actually a lot of numbers of fatalities, mainly with lung cancer, because that were only the options that we have for patients with stage 4 lung cancer, just like chemotherapy option with a 1-year overall survival of 33%. But for the past 20 years, we have a lot of breakthroughs. These breakthroughs have been, emerging and starting after the year of 2000, early 2000, 2005, when we started to have the target treatments, all of these changes, and understanding the driver mutations as well as the oncogene drivers for lung cancer. And after the year of 2015, we have, the discovery of immunotherapy and how it changed the landscape of treatments as well as how it changed the output for our patients. So what do we do in order to choose our patients? So which patient would benefit from what type of immunotherapy and what strategy of immunotherapy? So where do we go, with monotherapy or with a combination? This is another, recently published trial or recently published review about the use of immunotherapy, whether in squamous or non-squamous non-small cell lung cancer. So in very simple terms, those patients with PD-L1 high, which means that more than 50% and above can benefit from IO monotherapy or a combination of IO and chemotherapy, or those patients who are PD-L1 less than that, what we call them PD-L1 positive, also can benefit mainly from the combination of immunotherapy plus chemotherapy. But in some certain population, we can start these patients on IO monotherapy, especially elderly patients with comorbidities. But those patients with PD-L1 low, we would also like to go with a strategy of immunotherapy plus chemotherapy, or mainly a combination of two systemic treatments. So these are basically what we can tell, what are our current strategies in tackling patients with driver-negative lung cancer. So we go with monotherapy of immunotherapy, plus chemo, plus anti-CTLA-4 inhibitor, plus anti-CTLA-4 inhibitor and chemotherapy, and what new combinations we are having, and that will come through our way in the next few years. So again, this is the current standard that we give for patients with driver-negative lung cancer. So once we exclude that this is an oncogen-driven lung cancer, we look at the PD-L1 status. Based on the PD-L1 status, we will start our patients and go through treatments, whether with a combination of chemo versus monotherapy in those with PD-L1 high, or and this is actually what has reflected in the most recent guidelines, whether in ESMO, NCCN, or ASCO guidelines. So I will start with the IO monotherapy strategies. We have a lot of famous landmark trials. Keynote-24 is one of the early and landmark trials that showed that those patients with PD-L1 high might benefit from pembrolizumab or IO monotherapy in the PFS, as well as in the overall survival, with, as we can see here, an obvious and clear benefit in both endpoints. And that was also reflected in multiple other types of immunotherapy. So those patients with PD-L1 high may benefit with immunotherapy. So do we have any data to say that PD-L1 as a monotherapy is safe to be given for PD-L1 positive or PD-L1 high lung cancer? This is another meta-analysis or systematic review that looked at chemotherapy might not be needed for those patients with PD-L1 high, which means that's more than 50%. And we can see here those patients, whether they had or they did not have brain metastases, liver metastases, actually benefited from PD-L1 or inhibitor as a monotherapy. But we should always be careful for those patients with non-smoking history, as we can see there are signals that those patients might not benefit from IO alone. So we can either give those patients a combination of IO plus chemotherapy, or a combination of chemotherapy plus IO monotherapy. And this has also reflected in other real-world evidence. So this is, evidence from Europe for those patients who were treated with non-small cell lung cancer with pembro monotherapy that was published in August last year, showing that in the real-world data, again, giving those patients with PD-L1 high pembro monotherapy was also reflected in our real-world data, showing that those patients, whether they were in the trial or in the real world, they did not have a lot of difference. So that also confirms the benefit of pembro monotherapy in those patients, or IO monotherapy in those patients with PD-L1 high. Now, moving to the other strategies, which is the combination of IO plus chemotherapy, we have a lot and very well-known data in this setting. So those patients, whether to go with pembrolizumab, durva, or atezolizumab, or other types of immunotherapy that we don't have in our region, sunitinib or pembrolizumab or tislelizumab, also benefited from the combination in the chemotherapy plus immunotherapy, whether that was in the non-squamous non-small cell lung cancer or in the squamous non-small cell lung cancer, as we can see here in this data that, as I mentioned, has reflected in different and many multiple trials. Now, when do we think that those patients might benefit from an addition of CTLA-4 inhibitor? So now we're talking or shifting gear to those patients with PD-L1 negative, possibly, or those patients who have other types of mutation that may be affect the patient's response to immunotherapy. So this is like a very famous trial. It's called the Poseidon trial, looking at those patients who have, been given the chance to add a CTLA-4 to the immunotherapy with chemotherapy and see who exactly would benefit from this combination. So we can see that those patients actually, whether they have PD-L1 or PD-L1 low, they showed a good benefit, but mainly those patients with PD-L1 low status, this is something that we can think about. And actually, this is another, two very, very recent updates, whether in Nature 2024 or in JAMA, that was published about months ago, looking at those patients with KEAP1 mutation or STK11 mutation. And those patients, those patients with those mutations, we know that unfortunately they will not have a good response to chemotherapy or plus monotherapy immunotherapy. And from here we get another evidence or signal of evidence that those patients might benefit more from a combination of CTLA4 plus PD-L1 inhibitor plus chemotherapy. And this has actually what we can see here from these graphs. So those patients, whether they have STK11 or KEAP, when they had a better hazard ratio, whether in the progression-free survival or in the overall survival. So this is another thing that we need to look at and carefully read about our patients before choosing what strategy we're going on. So another strategy other than the monotherapy, other than the chemo plus IO, this is a dual immunotherapy plus chemotherapy. Now shifting gears about all of the advances that we had in the lung cancer. So as I mentioned, and Dr. As I just mentioned about stage 4, but Dr. Imad gave us a very nice review about early stage. So this also have shifted our patients' overall survival and outcome in the lung cancer in the last 5 or 10 years. So we have been shifting the use of immunotherapy mainly on or solely in the stage 4, and we have shifted that to earlier stage. So these are all the indications that we have, whether in the neoadjuvant approach, which showed overall survival, perioperative approach, which also showed an overall survival, and adjuvant approach, which has showed some survival in some category of patients. So these are the current FDA-approved lung immunotherapy in the early stage, whether in the neoadjuvant, adjuvant, or perioperative. And this is also, we have this debate, every lung meeting. So whether we go with neoadjuvant only or follow the neoadjuvant with a year of adjuvant treatment. So this is basically where this debate comes from. So the advantages of neoadjuvant immunotherapy is that to eliminate early the microstatic disease, as well as give an improved chance of resectability by downgrading and downstaging the tumor, while the adjuvant chemotherapy, there is, they go with the surgery directly and then follow that with immunotherapy. But we can see most of the data are showing that the perioperative strategies and the neoadjuvant strategies, I think it's better than the adjuvant strategies. And we have some negative adjuvant trials that also led to give this conclusion to go with neoadjuvant plus minus perioperative. Now, what other updates we have in the immunotherapy? This is a very interesting data from ASCO last year, that those patients have a better, when they had immunotherapy earlier in the day, have a better overall survival. So this is patients, let's look at, we're talking about dynamics of immunotherapy. This is actually a very suggestive and interesting data that using immunotherapy earlier in the day will reflect in the overall survival in the non-small cell lung cancer. So what are maybe the theory beyond that is that T cells maybe are more active in the morning and drug metabolism is circadian regulated. This might give a better, response for those patients who had immunotherapy given earlier in the day, meaning that before 11:30 p.m. This has also not been seen in non-small cell lung cancer only. It was also, this is a very recent data from the Chinese group, that when they used to give immunotherapy also for patients with small cell lung cancer, they had a better overall survival. So this is something to think about in the dynamics of immunotherapy. Another thing not to forget about the side effects of immunotherapy. This is also a very interesting data that was published in Nature, looking at the kinetics of immunotherapy-related adverse events. So we can see here, or we can conclude from this data, that then the PD-L1, PD-1 inhibitor skin toxicity appears early, with hepatitis risk around 6 to 12 weeks after a treatment. But with the combination therapy, we should always be careful and look at toxicity earlier, because we can see here from the data, from also those figures that we can see here on, especially figure C, that the one below, that toxicity start earlier and maybe can overlap with more than one type of toxicity and will remain for a longer period and the duration. So again, what data are emerging nowadays? We are talking about immunotherapy resistance. So tumor interesting mechanisms could be something that might lead to early resistance or immunotherapy. So this is why we have patients who can remain of immunotherapy for some months or years, but some patients actually might get resistance or they did not give the benefit with immunotherapy. So why is that? The theories that we have is that there are some what we call the tumor intrinsic mechanisms or the primary resistance mechanism, mainly looking at the low tumor immunogenicity, which we call or reflect as cold tumors or tumors with low mutation burden. There is also another theory is that the defective antigen presentation, mainly the antigen depletion with HLA downregulation. Another, interesting data that I just talked to you about is this STK11 as well as KEAP1, LKB1 as well as P10 loss. These are called sometimes can happen as a secondary or a primary resistance way for the tumor in order to adapt and resist the immunotherapy. And there is also adaptive immune resistance, such as the LAG3 TIGIT resistance. 2 slides to go. So this is another very, interesting data and review about what are the mechanisms of resistance of immunotherapy that was published by Rec and his group. I advise you to look at this data that actually just summarize what I just, or have, sorry, a better and more deeper information about what I just summarized. And this is a new theory about why do immunotherapy fail in some patients with non-small cell lung cancer, mainly looking at that as the patient go with treatment of immunotherapy mainly, they will get some lactate exposure. And this lactate exposure will upregulate different and other ways of checkpoint pathways. So we know the checkpoint pathway that we always deal with is the PD-L1, CTLA-4, but there are different multiple pathways of checkpoint that we still do not have a lot of information in order to inhibit. The last slide. So in order to overcome IO resistance and understand the dynamic of immunotherapy, optimize patient selection, avoid use of immunotherapy for those patients with driver mutated lung cancer, always look for STK11 KEAP1 mutation and maybe think about dual IO strategy, overcoming acquired resistance by always rebiopsy and molecular reassessment. Maybe look at the types of resistance. Is this multiple areas of resistance or oligoprogression, and you can just adjust that with some local treatment, and always keep an eye open for the emerging pathways such as the anti-LAG3. We have some early data phase 1 about anti-TIGIT trial that was published and discussed in ESMO, looking at an agent called rilvegostomig in the Artemide trial. We have an Artemide 02 and Artemide 03 coming on the way. Looking at the anti-TIM3 with sabestigimig, bispecific antibody, also a very interesting approach with anti-PD-L1 and anti-VEGF, as well as the peptide vaccine. With that, I conclude my talk today. Thank you.
Thank you, Dr. Abdulaziz and Jassim, for excellent overview. Our next speaker is Dr. Haider Abbas. He's currently working as a consultant medical oncologist in King Fahd Specialist Hospital in Dammam. He completed his medical oncology training in Queen Elizabeth Hospital, Birmingham, and he also holds a PhD in receptor pharmacology. So Dr. Haider will be talking about updates in the management of EGFR mutant advanced non-small cell lung cancer.
Good morning, everyone, and thank you very much for the introduction. And I would like to thank the organizing committee for inviting me to do this talk. So I'll try to finish my talk in the next 10 to 15 minutes and try to be focused. So I've just broken down my talk in a small section just to give it a bit of a clarity. So I'll just talk a little bit about the background of EGFR mutation lung cancer, and then try to look at the role of osimertinib and amivantamab in common mutations and some rare mutations. And finally, some really nice piece of work which was presented in ESMO this year, which was just looking at progression beyond osimertinib and how to deal with it. Now, first of all, this paper, which I tried to put in most of my lung talks, is a paper published in 1999, where we just initially looking at the role of palliative chemotherapy in non-small cell lung cancer. And if you look at it, it's published in 1999, which is only 25, 26 years ago. So the concept of palliative systemic treatment in non-small cell lung cancer is fairly new. And if you look at it, I think we have achieved significant milestones over a period of 25 years, and we have done quite a lot of progress in this field. And mutational landscape of lung cancer is quite complex. We have managed to identify quite a lot of mutations. And what is very interesting is not only identification, we are also able to treat most of this, which is slightly different from a lot of tumor sites where you're able to identify these mutations, but you cannot target them. Now, EGFR mutation, which constitutes about 15 to 20%, or essentially 25% of the mutations, depending on which part of the world you are, it's broken down into common and some rare mutations. So common mutations, which constitutes about more than 90% of them, are L858R, which is 41%, and exon 19 deletions, which is slightly more at 47%. And out of these rare mutations, the one which is worthy of mentioning is exon 20 insertion, which we all know about, and is a resistant mutation, which is very difficult to treat, and I'll just talk about it later during my presentation. Now, if you look at EGFR gene, all these activating mutations are in the tyrosine kinase domain. I've also already mentioned about exon 19, exon 21 mutations, but there are also some mutations on exon 18 which are sensitizing, not as much as so as exon 19 and 21. They are sensitive, but the responses are not great. Now, as we started treating non-small cell lung cancer in metastatic settings, soon we realized that some group of these patients are not behaving as smokers' lung cancer. They had EGFR mutations more common in never smoker, female adenocarcinomas, and they were quite resistant to chemotherapy. So therefore, and they were more sensitive to EGFR TKIs. So along with lots of other publications, this paper published in JCO just established the role of EGFR TKI first and second generation in first-line settings. So clearly there was the PFS improvement from 6.9 months to 11.1 months for EGFR TKIs compared to chemotherapy, and hence we started treating these patients completely different. Now, this is a slide which is comparing various generation of oral TKIs and their outcomes. There are a couple of things I want to emphasize on. First of all, if you look at overall survival, as you go from first to second and third generation, you'll see that the overall survival has improved. So starting out with 26.3 months, now with third generation, we have 38.6 months of overall survival overall survival. And secondly, out of these two common mutations, deletion 19 and L858R, L858R seems to have slightly bad prognosis. So L858R has bad prognosis as compared to the other common mutation, deletion 19. So what happens to these patients whom we treat with first and second generation oral TKI? And if you look at it, they start developing resistance and the treatment stops working. And one of the most common reasons that we found was about 40 to 50% of these patients will develop resistant mutation called T790M. Now, this was not sensitive to first and second generation. However, it was sensitive to third generation oral TKI, osimertinib. And after showing its efficacy in second line, it was moved to first line, and the trial called FLORA, which was published in 2018, established the role of third generation oral TKI osimertinib in first line setting, improving progression-free survival from 10.2 to 18.9 months, which was quite a big leap, moving from 11 to essentially 19 months now. Could we improve more on single agent osimertinib? Yes. What about adding chemotherapy? And therefore, a FLORA-2 trial was designed. It was essentially looking at the role of chemotherapy, what happens if you add it along with osimertinib. So inclusion criteria was patients with metastatic non-small cell lung cancer harboring common EGFR mutations who were treatment naive. So patients were randomized to either osimertinib versus osimertinib along with chemotherapy, 4 cycles of carboplatin pemetrexate, and then to continue maintenance pemetrexate. And again, if you look at the baseline demographics, very typical of EGFR mutated positive lung cancer patients, very common in female patients, more adenocarcinoma, and a good proportion of these patients had brain metastasis outside, about 40 to 45%, which is our common practice. Sort of patient that you see in your common practice, and the characteristics were balanced across both arms very nicely. Now, it was a positive study. By adding chemotherapy to osimertinib, PFS improved from 16.7 to 25.5 months, an addition of another 9 months. So we are gradually making improvement. Single agent, the first generation TKI is 11 months, went on to osimertinib to 19 months, and by adding chemotherapy, it goes to 25.5 months. So overall survival, which was recently presented. So overall survival improved from 37 months to 47.5 months, which is really remarkable. So a plus of 11 months by adding chemotherapy to osimertinib. And if you look at the efficacy, it's across all the subgroups. Everyone benefits by adding chemotherapy to osimertinib. So what about poor subgroups of patients? So we know that these patients with EGFR mutation are very likely to have CNS metastasis, and they tend to have bad outcome. To give you reference, so patients in intention to treat population, their PFS was around 17 months. Here you see patients who have just CNS metastasis is about 13.8 months. And even this group of patient has a plus of 11 months if you add chemotherapy. Clearly, response rates go up as well. Single agent osimertinib 69% versus 73% with addition of chemotherapy. Again, I mentioned this earlier, that patients with L858R mutation, they are bad prognostic group, and they behave like patients with brain metastasis with a PFS of 13.9 months, and here exactly 11 months of addition with the help of adding chemotherapy to osimertinib. So we're all very well aware of side effects of oral TKIs. Usually we have mucositis, diarrhea. They're very well managed, doesn't cause a lot of problems, but when you add chemotherapy, toxicities are going to be slightly worse, mainly related to cytopenias. And they tend to be more in first 3 to 4 months when you're having chemotherapy combination, but as you proceed and you're on maintenance pemetrexed and osimertinib, they tend to reduce. So what about patients who progress on osimertinib? If you look at it, there are different resistant mechanisms that we look at. One of the very common one is MET amplification. Can you make the outcomes any better? So what about amivantamab and lazertinib? Now, amivantamab is a different drug, is a monoclonal antibody bispecific. It targets both the EGFR and the MET, and lazertinib is a third generation oral TKI. In order to see if it was better to prevent the resistance from coming up early, what about adding amivantamab and lazertinib together? And that's why Mariposa trial was designed. So the inclusion criteria was pretty much similar as in FLORA-2. Patients with harboring common EGFR mutations, treatment naive, randomized to either amivantamab along with lazertinib or osimertinib on its own. So third randomization was for lazertinib, but that was essentially to see if lazertinib was performing as good as osimertinib or not. And clearly it was a positive trial. The PFS improved from 16.6 to 23.7 months. And again, it was across all subgroups, everyone benefited from it. Now, if you look at patients with bad prognostic signs, history of brain metastasis, liver metastasis, TP53 co-mutations, and detectable baseline EGFR ctDNA, they're all bad subgroups, and all of them benefited with lazertinib and amivantamab combination. Oral survival, this was presented in European Lung Conference last year, is still not mature. Osimertinib oral survival was 36.7. Whereas amivantamab lazertinib is still not reached maturity, but it looks like it will add at least a 12-month, and hopefully we'll have the readout either this year or early next year. There is a concern about side effects of this combination of Mariposa trial. Even if you look at EGFR, related EGFR inhibition, the toxicities is far more as compared to osimertinib. The mucositis, the diarrhea and rash, they're all quite concerning, and one has to be very watchful. Then we have a MET inhibition as well, and a very well-known MET inhibition side effect of hypoalbuminemia and peripheral edema is there as well. On top of that, two other very important things to watch out is infusion-related reaction, which is in about more than 50% of patients, and VTE, thromboembolism, which is in about 40% of patients. So two very important side effects to watch out for. And once again, these toxicities are more in first 4 months, and once patients have passed beyond 4 months, these toxicities tend to be not as common as in the later phase. Now, different regimens have been developed to address these side effects that I've talked about. For thromboembolism, prophylactic anticoagulation is recommended. Skipper regimen, which is dexamethasone, just like we give for Taxol, pre-treatment to reduce the infusion-related reaction, and also some topical emollients to reduce the skin toxicity, which is the three very common affecting quality of life of these patients. These regimens can be used to reduce the toxicities. Now, this is a summary of first-line treatment options. Apologies, this is not updated, but what we have is got single-agent osimertinib, we have osimertinib and chemotherapy, and we have the Mariposa protocol. What's really interesting is that you can see that osimertinib in all these trials have pretty much similar overall survival, which is very encouraging and just gives you a bit of more reassurance. We have FLORA-2 overall survival of 47 months as well, which is published. We are waiting for Mariposa overall survival, which then will decide which is in terms of overall survival the best of these regimens. So finally, exon 20 insertion. So I did mention about it. It's one of the rare exon mutations, one of the rare EGFR mutations. It is also in the tyrosine kinase domain of the EGFR gene. Now, what actually it does is causes a conformational change within the ATP binding site, and hence the drug cannot bind. Because of this reason, none of the oral TKIs has any activity about regarding this mutation. It has got a very poor prognosis. Real-world data suggests that the PFS in exon 20 insertion is somewhere in the range of 2.9 months as compared to 10.5 in common mutations. Similarly, overall survival is really bad, 16.2 months versus 25.5 months. So all in all, a bad prognostic group, difficult to treat subgroup of patients. We have Papillion trial, which was basically amivantamab and chemotherapy combination to look and see if we can address this subgroup of patients. Patients who were, the inclusion criteria was treatment naive exon 20 insertion patients. They were randomized to amivantamab and chemotherapy versus chemotherapy till progression. And it was a positive study. PFS improved from 6.7 to 11.4 months. In the last section, I just wanted to show this phase 2 trial, which was really interesting. So basically, it is looking at patients who have progressed beyond first-line osimertinib. And if you look at it, there's quite a few different mechanisms of resistance. One very common being MET amplification, about which we have talked earlier, C797S. And interestingly, these patients become sensitive back to first-generation oral TKI. So what actually this Orchard trial is a biomarker-directed platform study. What they're doing is they're looking at patients who progress in first-line osimertinib, and then looking at the resistant mechanism, and then assigning a drug based on that particular mechanism of resistance. For example, if patients develop MET alteration, they were given savolitinib, which is an oral TKI against MET inhibitor. Patients who develop C797X mutation, they added first-generation oral TKI, gefitinib, and so on and so forth. So I'll just quickly mention a couple of them, which I thought was a bit interesting. So the first one was to look at MET amplification. Now, this is one of the most common resistant mechanisms, osimertinib, quite a complex protocol, but what essentially it was looking at, depending on the extent of amplification, they treated patients with either savolitinib, the MET inhibitor savolitinib, along with osimertinib, or just savolitinib. And what the early studies have shown that the PFS with patients who are on combination is somewhere in the range of 7.4 months. Yes, it's a single arm study, but we know that these patients' PFS is somewhere in the range of 3 to 4 months. So clearly there is some improvement here. Response rates 56 to 55%. Again, is quite impressive for these patients who've already become resistant to osimertinib. And side effect, we don't have a full publication as yet, but clearly grade 3 toxicities were seen in about 50% of patients, and most of the side effects were attributed to the MET inhibitor rather than osimertinib. And the second arm, which I want to sort of briefly present here, is the one which have no genomic alteration. And here they were trying to look at the role of ADCs. So patients who have progressed on osimertinib with no with no targetable mutation, they were randomized to either osimertinib or its osimertinib along with DXd, and exploring the two doses, 4 milligrams and 6 milligram. These are baseline characteristics, very typical of patients who progressed. So PFS, clearly patients who were on 6 milligram of DXd did much better. PFS was 11.7 months, which is really impressive, to be honest. We don't see this sort of degree of PFS in patients beyond osimertinib single agent. Response rates of about around 40%, again, very good. And duration of response was impressively 20 months in the 6 milligram dose. Side effects, clearly, when you combine two drugs, your side effects are going to be more. About 1/3 of patients had grade 3 toxicity in 6 milligram dose of DXd. And again, dose reduction, interruptions, and discontinuations were more with a higher dose of DXd. Now, in conclusion, we have multiple lines of options in EGFR mutated non-small cell lung cancer, ranging from osimertinib single agent to osimertinib with chemotherapy and amivantamab lazertinib. It's not going to be a straightforward decision. It will all depend on patient characteristic, side effect profile, their fitness, their preferences, and also whether they have got what type of mutation they have and whether there's CNS involvement or not. And I think what is really important is that the future will be independent, looking at the genomic alterations, sorry, what mutations they have and how to address them, just like the trial I've shown you earlier. And with this, I conclude my talk. Thank you.
Thank you, Dr. Haidar, for the excellent presentation. Our next speaker is Dr. Abdulrahman Zahar. He's a consultant oncologist in Qatar with expertise in GU and lung. And he'll be talking about the treatment of extensive small cell lung cancer through treatment innovation.
Assalamu alaikum. Good morning. Thank you very much for this kind introduction, and thank you for the organizing committee and Dr. Hamad especially to give me this opportunity. I think nobody usually talk about small cell lung cancer, so this is another interesting topic. Small cell lung cancer, actually, this is particularly, I'm talking about the extensive stage. We have two stages. So it's a neuroendocrine transformation. It's unlike non-small cell lung cancer. And there is 5% they have incidence per 100,000. And neuroendocrine tumor generally, 5 to 15%, majority of the cases are non-small cell lung cancer. And then we have also highly expression of the TTF, and then they have on immunohistochemical staining, they have synoptocene and chromogranin usually positive in these cells, and pretty aggressive tumor actually with a very short half-life and very high correlation with the smoking history, and they have some alteration like in P53 and RB1 inactivation also. So in the past couple of years, there was a lot of research to look how we can manage in better way the small cell lung cancer. So they have classified they look for different transcription factor, and they divide it into different subsets, which of them is like N, A, P, and I, depending on type of these neurogenic transcription factors like NeuroDO1, SCL1, PO253. So they are high in the A and N and P, and particularly the interest is in the small cell lung cancer I, which is more inflammable, and it had shown also that it has some correlation, and these patients, they get better more with the immunotherapy because they have inflamed mesenchymal subtype, predict benefit with the immune checkpoint inhibitor. So over the last 4 decades, I think what was the debate is to give carbo with atiposide or cisplatin with atiposide, and to give prophylactic cranial irradiation or to give to symptomatic patient. So that was fortunately in 2019 when the new molecule immune checkpoint inhibitor came, and it is incorporated with chemoimmunotherapy, and this has become standard of care. And then recently also lurbinectedin and other bispecific antibody engager has came into the play like tarlatamab. So I will speak some of the evidence behind this treatment. This is the NCCN guideline looking for extensive small cell lung cancer, small cell lung cancer. So you can see you can give carbo, atiposide, cis-atiposide with either atezolizumab, durvalumab, which has been approved by FDA, and maintenance, maintaining them with durva or atezolizumab until progression. And then recently, lurbinectedin has been added in the maintenance where combined with atezolizumab. So we can see here what are the rationale for combination of immune checkpoint inhibitor with chemotherapy in small cell lung cancer. To have chemo-induced tumor cell killing may induce tumor antigen release and exposure to immune system, and PD-L1 overexpression leads to immune cell evasion and T cell inhibition, and then PD-L1 inhibition restore tumor-specific T cell immunity, and reversal of this immunosuppression lead to deeper and more durable systemic anti-tumor responses. These are Empower 133 and Caspian trial where they look for first-line phase 3 trial checkpoint inhibitor. They give 4 cycles of chemoimmunotherapy and then maintain them with either atezolizumab in Empower 133 and Caspian durvalumab every 4 weeks. They look also for triple therapy where they add tremelimumab and extensive stage small cell lung cancer in Caspian trial, and they were looking for the primary endpoint of overall survival and overall responses. So here the result, actually it showed definitely there was improvement with combining immunotherapy or maintaining after a 4 cycle and maintaining them with overall survival of 12.3 months versus 10.3 months in Empower 133, and Caspian 12.9 and 10.5 months, which was significant. And here you can see that FDA approval for first line came from this trial, and it showed the median follow-up in Empower 1.3 was 22.9 months and 39.4 months in Caspian trial, with a hazard ratio 0.76 and 0.79. And the chemotherapy backbone was used carboplatin and Empower, while Caspian you can use cis and carbo both. So here, most of these other immunotherapy trial, they look also other PD-1 inhibitor. Nivo was negative, Pembro was positive for progression-free survival, but didn't meet the overall survival. And there are Chinese immunotherapy also was promising, like Astram, Capstone, and Rational trial. So the second thing is lurbinectedin, which is a synthetic marine derivative tetrahydro isoquinoline alkylide, which is analog of DNA damaging agent trabectedin. And what it do is that it inhibit these oncogenic transcriptions and prevent the inhibition of cells and inflammatory markers, and improve the toxicity, monocyte and macrophages attack on the tumor cells and tumor lysis. So the M4 trial, which looked for the adding lurbinectedin to atezolizumab as a first-line maintenance therapy. So what they did, like Caspian and Empower, they give 4 cycles with immunotherapy, and followed by those patients who are stable, not progress. They kept them on maintenance, either lurbinectedin versus atezolizumab, which was the standard of care, and they look for PFS and overall survival with some other key secondary endpoints. And it was a positive trial, and it showed that there was improvement in lurbinectedin atezolizumab group 5.4 months versus 2.1, with overall survival 13.2 months versus 10.6, with hazard ratio of 0. Where is the hazard ratio? Run away. Okay. So 0.73, yes, reducing the risk of death, I think by more than 27%. And here again, you can see in M4 trial, overall responses and duration of responses during maintenance phase was with atezo 19-month and 19% and 34 in the combination arm, and had median duration of response 9 versus 5.6 months. So this led to the approval, but again, as the toxicity were a bit higher, more GI toxicity, and plus with no immunosuppression was anemia and myelosuppression was also a bit higher with atezolizumab, which makes sense that these are toxic drugs. The next thing which is coming, the delta like ligand 3 is expressed on these surface of small cell lung cancer. Usually these cells, these receptors are there on the Golgi apparatus intracellular, but in small cell tumor, these neuroendocrine, they are expressed on the surface. And this is one of the target. More than 84 to 94% of these cases have this expression. And DLL3 is a tumor-associated antigen and a potential target for T-cell engager. So one of that T-cell, bispecific T-cell engager is tarlitamab, which is bispecific T-cell engager immune therapy that binds with the DLL3 and CD3, which lead to T-cell mediated tumor lysis. And Delpha 303 is a maintenance study, still not yet approved, but they look, one of these cohort look for toxicity related, drug-related toxicity and treatment-related. And what they did actually, after 4 cycles of chemoimmunotherapy, they added tarlitamab to atezo and durvalumab until disease progression. And it have shown that actually significant median progression-free survival with 5.6 months with atezo and 5.3 months with the durva combination. And also time from first randomization, it has shown that there was improvement of overall survival with the 0.71, reducing the risk of death by more than 29%. So this led to investigated conclusion that first-line maintenance with tarlitamab plus PD-L1 inhibitor offer tolerable safety and unprecedented overall survival outcome and durable disease control for patients with extensive stage small cell lung cancer after first-line treatment with the platinum-based chemoimmunotherapy. What about subsequent line of treatment? Patient have those progress after first line. If it is chemotherapy-free interval, more than 6 months, probably still clinical trial. This was the version of NCCN guideline, 4th version of 2025. And you have other recommendations like lurbinectedin and tarlitamab, topotecan, irinotecan. This is what we were using. And then if it is chemotherapy-free interval is less than 6 months, probably again, lurbinectedin, topotecan, irinotecan, tarlitamab is the option. But recently in NCCN guideline, the latest version of 2026, the preferred regimen for subsequent line of treatment is tarlitamab, which is category 1 recommendation. Here is some evidence behind that, Delphi 301, which they look for the doses of tarlitamab. They give 10 milligram and they also compare it with 100 milligram and they look for overall responses. So they found that the progression-free survival and overall survival is comparable at subsequent line of treatment, whether 10 milligram or 100, but definitely toxicity is more with 100 milligram and the overall responses was 40, even better than tarlitamab 100 milligram. So here you can see that median time to response was 1.4 months and median duration of response was 9.7 months. Tumor shrinkage was 72% and median duration of disease control was 6.9 months. So phase 2 Delphi 301 extended follow-up have shown that progression-free survival 4.3 months and median overall survival was 15.2 months with tarlitamab 10 milligram. And subgroup analysis also showed that probably compared to the 100 milligram, the overall responses were great, 52%, and median duration of response was not yet reached. And this tarlitamab demonstrated durable responses with promising survival, regardless of the presence of treated stable brain metastasis at baseline. And this was Delphi 300 long-term follow-up overall survival, again positive at 6 months, 78.1%, and 12 months, 57.9% with 10 milligram. The median overall survival reached to 20.3 months. So this is a phase 3 trial, which is international multicenter oval label, and they look for tarlatamab. They give 1 milligram on cycle 1 day 1, and then they give cycle 1 day 8 10 milligram, and then 15 milligram, and it is repeated every 2 weeks, 28-day cycle. They look for overall survival and primary endpoint and secondary endpoint, PFS and duration of response. This is after progression of 1 or 2 line of treatment. Here we can see the baseline characteristic, well balanced. Majority of the patient were actually more than 90 days or more than 120 days. You can see here 33 month and 24 month after the treatment with chemoimmunotherapy. And progression-free survival, the primary endpoint was positive for PFS with a hazard ratio of 0.71, and overall survival was 0.60, reducing risk of death by more than 40%. And if you see the subgroup analysis, all were in favor of tarlatamab subgroup. And you can see tarlatamab improved symptoms of dyspnea, cough after 18 weeks from baseline compared to the chemotherapy arm. And here, if you see toxicity profile was also better compared to the chemotherapy. Grade 3 toxicity was just 27 versus 62% in the chemo, and other treatment-related adverse event leading to dose interruption was just 19% versus 55% in chemotherapy arm. If you see this treatment emerging adverse event, so most of the treatment-related adverse event was related to the cytokine release syndrome, CRC, and ICANS, which is dysgeusia and pyrexia was higher, but otherwise myelosuppression, other side effects were more common with the chemotherapy. So this is lerbenectedin as a second-line treatment, also single-arm open-label phase 2 trial. 3.2 milligram was given after progression patient on first-line treatment. And here you can see that chemotherapy, if free interval, if less than 90 days, was 22% overall response, 45% with chemotherapy interval more than 90 days. And it has shown also duration of response 0.7 months versus 2 months, progression-free survival 0.6 versus 4.6, and 5-month overall survival versus 11.9 in a group who have chemotherapy-free interval more than 90 days. And this is, you can see all comers 9.9-month median overall, 9.3-month median overall survival, while chemotherapy-free interval more than 90 days show 11.9 months. This is ongoing trial for the lerbenectedin phase 3 trial, Lagoon trial, which is a combination of the second line plus lerbenectedin versus lerbenectedin plus irinotecan, and they are looking for overall survival. Just summary for this data for release of extensive stage small cell lung cancer subsequent, you can see the median duration compared to topotecan, lerbenectedin and tarlatamab is much better, 5.3 months and 9.7 in tarlatamab, while median overall survival was 5.4 in topotecan, while in lerbenectedin 9.3, and further improvement 15.2 months in bispecific T-cell engager tarlatamab. So these are ongoing trials like looking for targeted therapies, DLL3, ADCs, and one of the molecules MK607 phase 1/2 trial. Again, this is another molecule which confirmed the overall responses and disease control rate in the dose optimization cohort with small cell lung cancer was 39% and 71% respectively. These are the different molecules. One of them already approved tarlatamab, the other is ongoing trial. And we have, apart from DLL3 biomarkers, we have B7H3, which is a member of B7 family of immune checkpoint protein, highly expressed in cancer cells. Approximately two-thirds of them is on small cell lung cancer. And we have ifinatamab deruxtecan, B7H3 targeted antibody drug conjugate, has permeable with a short systemic half-life optimizing. This was a stable linker payload, tumor-selected cleavable linker, and bystander killing effect, and it showed that median follow-up 11.7 months, with median time to response 1.2 months, and median duration of treatment was 5.9 months. Again, the TROP2 inhibitor, sacituzumab govitecan, also has been promising, looking for overall response and duration of response. Again, it has 77% of patients had any tumor reduction, 43% of patients had more than 30% of reduction. And then we have emerging therapies like ABBV01 and C6 targeted antibody drug conjugate. CIS is a scissor surface protein, which is also highly expressed on the small cell lung cancer. This is present in the brain cells, neuronal cells, but in small cell also they have this high expression, and now they are combining with the antibody drug conjugate, and it has shown again promising benefit with overall responses of 25%. And these are the different ADCs, which is targeting DLL3, B7H3, TROP2, C6, and different molecule. Hopefully in the coming future, we will see more and better understanding of small cell lung cancer, how to manage these. These are the different targeted areas where clinical trials is going on. And by that, thank you very much.
Thank you, Dr. Zahar, for the excellent presentation. So may I invite all the speakers to please come to the stage. I would also like to invite Dr. Dina Hamza, Consultant Medical Oncologist in Dubai Hospital, Dubai Health, and Dr. Nadir Guran, Consultant Respiratory Physician in Rashid Hospital, Dubai Health.
Okay, quite impressive panel we have. My first question to Dr. Imad for the early stage. We've seen that in the perioperative approach, both stage 2 and stage 3 have been now approved for perioperative treatment, but the outcome is slightly different. The hazard ratio is slightly different. For the stage 2 is around just above 0.71 or 72 and 0.54 for the stage 3. So is there any patient that doesn't really deserve to have immunotherapy with chemotherapy in stage 2, for example?
Thank you, Dr. Benini. So in general, it's positive. Regardless the hazard ratio, it's still positive. Yes, some group, they may have more benefit than others. But on the other hand, if you do surgery, those patients still fit for adjuvant immunotherapy, where the data of adjuvant immunotherapy, it's really conflicting. So we have 3 phase 3 trials. 2 are positive and 1 are negative for durvalumab, the P31. It's a negative trial. And when it comes to the 2 positive, 1 only for PD-L1 positive and mainly driven by high PD-L1 expression for the ATIZO trial. And the other one for the keynote 091, where the pembrolizumab improved the events-free survival, but mainly for PD-L1 negative and low expression, while the PD-L1 more than 50 did not drive the same benefit. So I see the adjuvant approach is more confusing, conflicting, and so I would be in favor to offer the patients the neoadjuvant or perioperative. But in case you have small tumors, you can go directly for surgery, no doubt for that. Especially 20% of the patients, they will not go for surgery in the neoadjuvant setting.
How often, I mean, perioperatively, the duration of this preoperative treatment, because patient might not respond also to treatment. So do you advise an early, after 2 cycles, 3 cycles, or how for the assessment prior to surgery, to go to surgery in case of patients who are not responding or progressing, early progress or resistant?
The number of cycles of neoadjuvant chemoimmunotherapy, you have 3 cycles from checkmate, it's 681. They allowed for 3 cycles going then for surgery. The others, they give 4 cycles of chemoimmunotherapy. In general, we do assessment after the completed the planned cycles before going to the surgery, unless clinically patient is progressing. But even if they are progressing, that means they have a very bad biology, and doesn't matter if you do assessment after 2 cycles or after 3 cycles or after 4 cycles. If patient not symptomatic. In the all clinical trials, 5 to 6% of the patient did not go for surgery because they progressed, not for surgery. They have disease progress. So it's small number of patients.
Can I add on the same topic? So if the chairman allows me.
Yes, of course.
So in the NEVO trial, you know, the first one, which just gave 3 cycles without any adjuvant treatment, we have survival advantage as well now. So are you going to offer adjuvant treatment in the perioperative setting to all patients, or can you save some patients from the rest of the year immunotherapy? Any role for ctDNA or maybe the CR patients? What do you think?
I highlighted this during my talk. So first of all, we have 2 trials improve overall survival. And surprising that these 2 trials may use cisplatin-based chemotherapy. So in KEYNOTE 671, 100% cisplatin. In CheckMate 618, it was almost 80% or 75% cisplatin. So if you would like to stake the trial to give cisplatin, however, the FDA allowed to give carboplatin instead of cisplatin. It's not matter one is better than the other. I believe the perioperative is better than the just to give one approach in neoadjuvant. But if you have a patient who achieve complete pathological response, they have a good prognosis. So I can de-escalate for those patients. With regard to the ctDNA, we have the exploratory analysis from Asian trial looking for the role of ctDNA and the prognosis for this patient. If ctDNA negative, they have very good prognosis compared to the ctDNA positive. But it's not standard of care. So I believe if I have a complete pathological response, those patients, I might de-escalate, I might offer them just stop the treatment because not everyone will tolerate even the adjuvant part of the treatment.
If I can, Dr. Haider, thank you for the excellent presentation. So we have now FLORA2 and Mariposa in the first line setting. So how would you select out patients for either approach? Is there any biomarker you look at, or what are the criteria?
I think thanks. It's a very relevant and important question. I think it's been discussed in every meeting now. I think it's just down to, because the 2 drugs are very different. I think the mainly differentiated by side effect profile. First of all, efficacy, I think we have a very reasonable overall survival with the FLORA2 study coming around 47 months. Although we don't have a mature data for Mariposa, but it says about 12 months plus single agent. So coming around 50 months, I don't know. I don't want to guess, but it would depend where the OS stands. I think then it comes to choice of agent, I think is going to be very depending on the patient's performance status. You know, you can't give a borderline performance status 1 Mariposa. It's quite toxic treatment. You have to be very careful. Yes, your survival might be slightly better, but you are going to compromise someone completely going off big time on you. As you can see, the toxicities are quite significant, so you have to choose your patient. So for any patient who is fit, so we don't have any biomarker to tell us which one to choose which one. If you have a very fit PS1 patient, clearly then you can go for which has got the best overall survival, which we might know in next few months. Other than that, I think both of them are very comparable, less side effect with FLORA2 and quite reasonable quality of life.
Dr. Dina, we have this discussion in our tumor boards. How do you select out patients in this situation in the first line?
Same EGFR mutant? Yeah, actually, Dr. Haider mentioned it all. I might add, we have, for example, in our tumor board, we have the applicability of doing not only the selected gene panel, but we have a full NGS analysis. We have the OS data for the FLORA2 so far, and we have the exposure to the chemotherapy, which is around, from the trial, it was around exposure to the platinum was around 2.8 months. And for the Pemetrix, it was around an average of 9 cycles. So we know quite well that these patients did very well on the FLORA2. On the other side, with the Mariposa, so far we have a good PFS data. The OS is not yet, so far is not yet mature. The only point which I might consider is with the presence of other MET amplifications or MET mutations within the primary NGS analysis. because this might be the little bit of the edge for the amivantamab, that it has some activity with this different mutations in addition to the regular mutations or the common mutations that we have. This might be the responsible for a later resistance or an earlier resistance than what we have seen from the long PFS data from the FLAURA2. So this might be considered, of course, with the presence of a very fit patient and to consider all the side effect toxicity, because if you look at the other subgroup analysis of the CNS or the point 21 mutation or the other, we can see that the FLAURA2 has been there quite well. But this is the only thing where I would consider a mariposa.
Just a small when it comes to CNS, I think the data from Mariposa is more strong than the FLAURA2 because the FLAURA2 was designed not to show CNS activity because none of the primary or secondary endpoint looking for the CNS activity of the FLAURA2. While in Mariposa, it was a secondary endpoint, the CNS activity comes CNS response rate, CNS BFS. So we have more prospective data for the CNS activity from Mariposa rather than in FLAURA2. But in the same time, we don't have superiority in the response rate.
It's the trial design other than the superiority to response. It was in the trial design itself that they were doing the MRI and for all the patients, regardless they were having a baseline CNS metastasis or no. So the trial design, but efficacy-wise, you did not see a superiority in the efficacy-wise the Mariposa versus the FLAURA2 for the CNS metastasis by itself.
But we have in a prospective way from the phase 3 trial looking for the CNS progression-free survival from Mariposa, which was in FLAURA was not designed to show this activity. So whatever we have from FLAURA2, it's an exploratory analysis. But I agree with you that I don't see that there is more benefit from Mariposa when compared to the FLAURA. So what is I would say this patient should go for Mariposa rather than FLAURA2, and the fact that we don't have any biomarker. You can go for either one of both. But there is a drug which is a little bit toxic, little bit more cost.
Just to conclude this question of comparing Mariposa and FLAURA2, does the sequencing of the treatment itself comes as a criteria of selection of which way you will go, because the treatment is quite different when you go to second line, whether you go for FLAURA2 or Mariposa. So does the choice affected by your plan of second line already?
Yes, I think there's quite a few studies which show that patients who've been on FLAURA or single agent osimertinib, most of them go on to second line of treatment. I think that's probably because of attrition rate is slightly less on this side as compared to other because of toxicities and all this. And now that we have very, very potent MET inhibitors coming in, and that's why in the last part of my talk there was some this biomarker-driven basket trials where you see patients once they develop resistance, then and that I agree that initially there is not, it's very less, I think 3 to 4% of patients would have MET issues, but later on when they develop, so when you have potent TKI MET inhibitors, then I think you can easily overcome this problem, and second line treatment remains an option with maintaining good quality of life.
Dr. Jassim, excellent presentation. In the presentation, I noticed in the last couple of slides, you mentioned about IO resistance. The question is, how can you overcome IO resistance in primary and secondary setting?
Yeah, thank you, Dr. Farouk, for the question. So this is like an area that we're trying to understand more and more, because all of us think that PD-L1 is still not the best, like marker to look for in order for those patients to know who would benefit from immunotherapy or who did not. Because we understood that there is like something that we call primary resistance. There is other thing called secondary resistance. The primary resistance is what we mean by cold tumors or tumors with low tumor mutation burden, and those patients usually would not respond very well to immunotherapy. But then we also understand there are some mutations that also lead to resistance of immunotherapy, such as STK11 and KEAP1. So those, like this understanding, we're also looking at what other PD-L1 or sorry, what other checkpoints we have in the cell and trying to target those, as we mentioned, like with the anti-TIGIT, the anti-LAG3. So a lot of, information updates, I would say, would be coming in the next, let's say 1 or 2 years, and that will very likely change our way to look at our patients who would benefit from which type of immunotherapy, depending on what mechanism of resistance would those patients, likely to develop.
I think one strategy, if I can interject, is the anti-VEGF. You mentioned briefly, but certainly we have 2 studies. We have studied just adding anti-VEGF to IO in second line, or using the bispecific evonesimab, which has impressive data even in the later lines. So that may be one easy strategy to use with less toxicity in general.
Yeah.
And if I can ask you about the morning versus afternoon, we know these drugs have long half-life, and we're even giving some of them every 6 weeks now. So how do you think this is really explainable? If you have such a drug with a long half-life, why would the administration morning or evening would matter?
Yeah, this is still an area of, of a lot of debates. Like I mentioned that when on that trial, I mean, there was like the poster and ASCO, and then there was the trial that came after, and the authors suggested that this should be something related to the circadian regulation of our metabolism. So those patients, maybe they have a better metabolism, better T cell exposure and new antigen presentation, all of that when this treatment is given in the morning. So from that, what we think, it's still an area of, yes, but, and the good thing that I also showed that it also worked in the small cell, patients. So not only the non-small cell, it also showed in also patients with melanomas and other types of cancer. So this is a very interesting thing to watch for.
Okay, we'll get to the last question because we are already delayed on schedule. So to Dr. Zahar, so in the era of chemoimmunotherapy for small cell lung cancer advanced cases, do you still see an impact of radiation therapy, consolidative radiation therapy for residual disease or?
Yeah, thank you very much. Very excellent question, because extensive stage, definitely these patients need to start systemic treatment. Previously, we used to give chemotherapy, and then we had good response. So you look for the prophylactic cranial irradiation, and then if there was a distant metastasis, disappear because sensitive tumor and you have residual chest tumor lung, they used to give them thoracic, radiation. But these trials, when they combine Caspin and Power 133, actually they didn't look for adding radiation to these residual tumors. And that is an area of debate whether if they will receive, because there are trials, I mean, they look for the thoracic radiation, have residual tumor, their survival improved actually, So in the era of immunotherapy, giving radiation is because there was a worry about the pneumonitis. That was the reason. Probably could be the trials not designed to consider radiation. But that is the area of probably further exploration, and in the future trial, whether these patients who have very durable response, we know this aggressive tumor, should we consider for these residual tumor thoracic radiation or not? So it's not yet clear.
Yeah, we have a core member of MDT pulmonologist with us, so I can't really let him go without asking a question. So we do come across situation where you have a scan with a higher lymph nodes, and radiologist raises the suspicion of malignancy. So CT guided biopsy is not possible, and we refer patient to yourself. We have this discussion. So obviously nowadays, cytology is not enough. We need enough tissue for molecular analysis. So I just want to ask you, what sort of challenges do you face in this situation?
Thank you, Dr. Farouk. And first of all, thank you very much, Dr. Hamad and Dr. Farouk, for this invitation. Nice to be as only pulmonologist, I think, in this hall to be with you today. So there is multiple challenges. The most important, actually, it's multifactorial. The operator skills. First of all, to do a good EBUS in the bronchial ultrasound, and to have a deep experience in the anatomical landmarks in the sonography, landmarks to distinguish between the, especially the stations. Borders, for example, between station 4 are right lower paratracheal, left lower paratracheal, and the hilar lymph nodes, station 10L. It's very close to you. Just move little of the scope. You can maybe mix between them, upstage or downstage depression. It's very, very important to be done. The selection of the right needle to have it, for example, not such a small needle. And it's also depending because sometimes you're using 22G needle. It's a small needle we have. You have also 25. Maybe it's not enough for the pathologist to see enough representative material. Choose something between, not a big one. And 21G we are using, we get good material. We have good experience with that. The other thing is also sometimes the lesions locating or the lymph nodes is small, locating very close in proximity to the big vessels. Here again, a good operator and to use the right tools, balloon to reach to and localize and have a good angle to hit the lesion in a good way. Central lesions, we know that it's very difficult for the interventional radiologist to reach it because very close to them. And here our role is very important as interventional pulmonologists. The other thing is also to have a good team around you, technicians and like that. We have new technology now. We are introduced to our biopsies. Actually, we are doing also EBUS guided cryobiopsy with 1.1 millimeter cryo prop. After we are puncturing with, for example, 21G or 19G needle 3 times. Just to mention that you at least you have 3 passings you should do it to get a good material, and not just to concentrate on the necrotic part, but also to navigate sometimes also to the peripheral to reach to the vital part. Number 1. Number 2, after that, when you are finished, sometimes if you need good material, you can do it also EBUS guided cryobiopsy. You get very, very nice samples. Regarding the AI in the field of radiology, we know that there is a lot of softwares in this field, deep machine learnings. Our experience with the lung cancer screening, it's very important to have it because it's also compensates sometimes if in the rural area, in the area, peripheral area, if you don't have an experienced radiologist to use it to get a good answer or report. But there is no any validated software for the use. We try in the Rashid Hospital actually with Dr. Usama al-Bastaki to work on that also on the long term. But in this area, we don't have it. Hopefully, the future will be much better. Regarding the pathology, I know that one of my colleagues in Amsterdam, Professor Jouke Enema, he's running right now a PhD study for the inside the suite to run AI machine, to give an impression or rapid interpretation of the material we are getting, this malignant, not malignant, like a ROSE rapid on-site evaluation. But I don't have experience with that we have something clear already for that right now. Another thing, many centers, they are using rapid on-site evaluation, but it's also resource demanding. Not every pathology department, they have pathologists ready to be available. It will reduce the number of passings, but studies not showing that it will change in the diagnostic yield or accuracy to have ROSE or not ROSE, again, depending on the experience of the operator.
Thank you, Dr. Karan, and thank you for the panel. That will end the panel discussion. If you can please take your seats in the audience. And now I will invite Dr. Dina Hamza. This is a satellite symposium. She's a consultant medical oncologist. She doesn't need any introduction. So she will be talking about redefining survival outcomes in advanced EGFR mutant non-small cell lung cancer.
Thank you, Dr. Farouk, for the nice introduction. Thanks, our lung team. It was an amazing discussion, actually, and quite interesting. And in order to wrap it up with the most important data, which was presented this year at the WCLC 2025, I'm going to present the data for the OS in the FLORA-2, which is osimertinib with or without chemotherapy in EGFR mutated advanced non-small cell lung cancer. This meeting is being, this presentation is being sponsored by AstraZeneca, and I don't have any other disclosures to present. So the question here, for whom we shall give them a single agent osimertinib, and do we really need an intensification of therapy? Do we need really to go back to the chemotherapy and add chemotherapy in a first line patient with an EGFR mutant? We know quite well that osimertinib has been there as a standard. The original was the first line FLORA trial. Then we have the FLORA 2 with the addition of a platinum doublet. And we have, of course, the trial for the Mariposa, which is the amivantamab and lazertinib. So coming to the study design of the FLORA we had just spoken about. So we know quite well that these patients are untreated locally advanced metastatic EGFR mutant, either exon 19 or exon 21. And these patients were randomized to either the standard of care, which has been there for years, which is the osimertinib 80 milligram, or with the addition of 4 cycles of platinum-based, they use carbo or cis platinum, and then followed by maintenance pemetrexed and osimertinib. So the primary endpoint here was progression-free survival, and the secondary endpoint was OS. We have just spoken about the CNS metastasis. So they allowed patients with CNS metastasis who were asymptomatic here that they did not require steroids. They have stable neurological status. This is the patients who were followed up by imaging every 3 months. So the primary endpoint was quite amazing that we have a 9.5 months increment in the progression-free survival. So we have a median progression-free survival was 29 months versus the osimertinib single agent, which was 19 months as a ratio of 0.62. And let me tell you, this is the largest progression-free survival in a randomized phase 3 trial in the first line EGFR mutant non-small cell lung cancer. So how important is this 9.5 months? It's not only a numerical, but how deep is this? And this being translated to a survival benefit? Yes, a big yes here. Yes, it was translated to a survival benefit. And we have an OS data, which was just presented at the WCLC. And as you can see here, at 4 years, we have 49% versus 41% with a hazard ratio of 0.7. We have a median OS of 47.5 months versus 37.6 months. Who benefited from that? As you can see in the baseline prognostic factors, all the subgroup analysis had benefited from the addition of this chemotherapy to the osimertinib versus the osimertinib. So the question the patient will come, are we going back to the chemotherapy? How am I going to be supposed to receive chemotherapy? So the question here, if you look at the exposure, you find out that with the FLORA 2, the median exposure to chemotherapy, the platinum base was 2.8 months. Pemetrexed was 8.3 months. And if you compare the exposure to the osimertinib, you find with the FLORA 2, the exposure exceeded 30 months versus the original trial of the FLORA, where the exposure was actually less than 2 years. It was 21 months. So they looked at the subgroup analysis, and they looked at the major subgroup analysis we all know, which is number 1, the CNS metastasis at baseline, and whether the patient had CNS metastasis or did not have CNS metastasis. We can see here that with the CNS metastasis, they benefited with a hazard ratio of 0.72. The second one, which is almost the same as the CNS metastasis as a bad prognostic factor or poor prognostic factor, is the L858R point mutation, which is exon 21. And we can see it almost did the same with a hazard ratio of 0.72. 0.76. What about the trendy ctDNA, which is the presence of a baseline ctDNA plasma positive and being detected. And again, they benefited with the addition of the chemotherapy with a hazard ratio of 0.79. Visceral metastasis will always be a poor prognostic factor, and we can see here a quite good addition of the FLAURA2 in comparison to the FLAURA with a hazard ratio significant of 0.6. Bone metastasis as a baseline also benefited with the hazard ratio of 0.76. Molecularly and histologically, the presence of a TP53 mutation altered is being a worse prognostic factor. And we can see here the benefit was almost the same 0.7, whether it's being altered or being a wild type. So if you look at these were not stratification factors, but these are subgroup analysis. We know quite well from our practice that these are the worst prognostic factor in when we treat a patient with an EGFR mutation in the first-line setting. So whether they have a baseline CNS metastasis, liver metastasis, bone metastasis, TP53 mutation, ctDNA positive at the baseline, all of them had benefited from the addition of 4 cycles of platinum-based chemotherapy versus osimertinib. What about the adverse events? The adverse events mainly were related to hematological toxicity related to the chemotherapy. And as you can see, anemia, diarrhea, nausea, neutropenia. The timing of this usually happened at the beginning, but gradually reduced over time because the median, again, exposure to the platinum was 3 months, and the median exposure to the pemetrexed, we were talking about 9 cycles, and you can see the side effect toxicity had reduced significantly with time. And this is the updated FLAURA2 toxicity, which was presented again. So what did the patient say? Because again, we have to have this discussion with the patient because they know quite well that we have an osimertinib alone, and now we are giving them chemotherapy. So this was a survey about the quality of life with the patient's family members and physician. And we can see here that they were more likely to express preference versus than chemotherapy combination, but actually the health-related quality of life was quite maintained in the trial. So in the patient, we see the patient because, again, how can we weigh our first-line options? We have the discussion just a few minutes ago. Whether still there is a monotherapy or every single patient can go for intensification. Definitely, we have seen the data is better with an intensification over a single agent osimertinib, but still, some patients we might favor a monotherapy, for example, having a low volume disease. If we are going to integrate a baseline ctDNA and we found it negative, exon 19 deletion, and definitely the most important, I see them that they were the patient factors, for example, poor functional status, medical comorbidities, and difficulty in developing the platinum-based therapy. So what about the first subsequent treatment? We have been discussing what is next if we push the chemotherapy to the first-line setting. So we can see that, again, the chemotherapy was the common treatment after osimertinib and chemotherapy. They, again, were re-challenged with the platinum-based. There were, or the most common was the chemotherapy. And definitely this was the standard of care, actually, with the osimertinib as a first-line setting. This is considered like a philosophy slide. I stood in front of it and think about it a little bit. So this was presented by Professor Daniel Tan at the WCNC 2025, just a few months ago. So this is a philosophy other than a data. So he thought when we look at the patient, we look at the baseline factors. So definitely this patient is an EGFR mutant, whether they have a brain metastasis or no. And that this was what we think about at the beginning, and that was only factors we put into consideration. Then the emerging data we have to look at, whether these patients, as I mentioned, having, for example, CMAT, have, for example, a TP53 alteration, have TME, whether we have, for example, a HER2 positivity, so he might develop later benefit from the addition of specific ADCs. And then the disease itself is quite dynamic. The alteration is not stagnant, and it's not now and that's it. Actually, the disease by itself, we're dealing with a very dynamic disease where alterations and mutations can pop up. And that's why when we discuss in our meetings, usually the idea of having another biopsy is usually very thoughtful. So, for example, if the patient starts with an osimertinib, we can see that the development of alteration will happen quite early. But if we look at the osimertinib, pemetrexed, and carbo, we can see that the clinical progression over time, the longest PFS ever, which was almost reached 30 months, it happens later. So this is just a thoughtful thinking about how we deal with our patients and how to deliver to them why we add chemotherapy to the osimertinib in a first-line setting. So to sum it up, the FLORA2 is the longest in global phase 3 trial that showed an OS benefit in patients with EGFR mutated advanced non-small cell lung cancer, and the hazard ratio for the OS favored the combination arm regardless of the baseline prognostic factors, including a 3-year OS rate. Yes, there is increased toxicity related to the chemotherapy, but this happens quite early and it's limited, and we know quite well how to deal with it. There are patients who might still go for a monotherapy. This has to be discussed with them, why we don't want to give them the salvage therapy started from the beginning. Mostly they are going to be related patient factors other than having a disease. Definitely the FLORA2 currently is a first-line standard of care in this setting. Thank you so much. And by me ending this session, would love to invite you to the lunch, which is going to be in Kitchen 6. Thank you.
Thank you very much for everyone to be staying this late on the last day of the conference. I'd like to thank the organizing committee, Dr. Syed Hamad Ramzi, Dr. Farooq Latif, and Dr. Dina Hamza to organize such a fantastic and a very exciting educational and scientific conference. With this, we would like to start the final session, last but not the least, on the gynecological cancers. And it gives me immense pleasure to introduce our first speaker, Dr. Angelica Nogueira Rodriguez. She is an eminent oncologist from Brazil. She got her oncology training from esteemed Brazilian National Cancer Institute. She holds a PhD in oncology and completed postdoctoral fellowship in global oncology at esteemed Harvard University. And she's got multiple roles there, founder and strategy director of the Brazilian Gynecological Oncology Group, chair of gynecology at LACOG, and professor and researcher at an esteemed university there. And her key interests are gynecological and hereditary cancers. And with this, without taking further time, I would like to welcome Dr. Angelica. Thank you very much for being here. She'll be talking about tailoring first-line therapy in endometrial cancer according to the molecular classification, a very, very interesting topic.
Thank you very much for the introduction. I'd like to congratulate the organizing committee for this important regional meeting, and thank you very much for the honorable invitation. So the idea is to discuss the first-line treatment in endometrial cancer. There are so many advances for patients currently. And to start this discussion, I'd like to ask your attention for my potential conflicts of interest. Endometrial cancer incidence is increasing globally because we are getting older, the global population is getting older, and also because we are getting obese. I hope that the GLP-1 blockers can help us here, but the reality is that obesity is increasing. But not only the incidence of endometrial cancer, also the severity of the disease. This data has just been released by this year, and as you can see, uterine corpus mortality in the US is higher than ovarian cancer. It has a higher incidence, and also the severity of the disease is increasing because obesity-related endometrial cancer is more severe than the other subtypes. The molecular landscape has changed significantly in the recent years. For over 30 years, we've divided endometrial cancer according to the Buckman model in two subtypes. Type 1, hormonal dependent disease, and we would treat patients based on hormonal therapy. And type 2 disease, more aggressive disease, and here we would favor chemotherapy. But we knew that behind this simplistic concept, there is a very complex disease with many pathways involved. And it was about time we had the Buckman Redux, and we had this better comprehension when the TCGA was published, but over a decade ago, that you know very well that the disease is now subdivided in at least 4 subtypes. Poly, very good prognosis. MSI with several options to treat patients, copy number low and copy number high. Very different prognosis, different subtypes of disease. And this comprehension brought a prompt change in the paradigm of the disease. In 2018, the immune checkpoint inhibitors came for second-line patients, mismatch repair deficient patients only. In 2021, we had the presentation of the combination of immunotherapy, pembrolizumab combined to lenvatinib, increasing overall survival for patients here regardless of mismatch repair, both for mismatch repair deficient and proficient status. And in 2023, 2-3 years ago, the paradigm has shifted for patients in first line. After over 20 years without any incorporation for endometrial cancer patients in first line. In the same year, 4 trials were presented showing a significant benefit for patients in progression-free survival for all comers, and in overall survival for mismatch repair deficient patients. As you can see here, and I know that you know this data very well, the gain for mismatch repair deficient patient in endometrial cancer by adding immunotherapy was huge. The hazard ratio in all the trials were around 0.3, a reduction in the risk of progression or death of 70%, regardless of the drug, just focusing on the biomarker mismatch repair deficiency. And we have OS data for 2 trials, and they are positive. The gain for the proficient cohort was smaller. There was a benefit. The hazard ratio in this population, by adding immunotherapy, the hazard ratio is around 0.7 in all the trials. At the first analysis, the NRG, the pembrolizumab trial, had a hazard ratio of 0.5, but further analysis, now every trial has the same hazard ratio around 0.7. The atezolizumab data was negative, and Roche decided not to progress with the submission of the drug globally. So we are going to focus the discussion on the 3 trials, the RUBY with dostarlimab, NRG with pembrolizumab, and the DUO trial with durvalumab. So we are not going to discuss atezolizumab data. And after this impressive data, there was a trend to consider immunotherapy and chemotherapy for all endometrial cancer patients in first line. And so despite this different prognosis, we know that there are patients who benefit more, patients who are mismatch repair deficient, patients who do well regardless of the treatment, the POE, very severe disease patients with P53 mutant. So it's a simplistic decision, and we shouldn't treat all the patients the same. For example, if we focus on patients who are mismatch repair deficient, they have a very good prognosis with immunotherapy and chemotherapy. But there is one question. Do those patients need chemotherapy, or IO alone would be an option for these patients, as immunotherapy is very efficient here? And furthermore, 20% of the patients, if you pay attention to the red circle, 20% of the patients, mismatch repair deficient, they progress regardless of the combination, despite the combination of chemo and IO. There is a subgroup of mismatch repair deficient patients who need more treatment, so we cannot stop our discussion here, even for mismatch repair deficient patients. And if you move for the proficient cohort, the prognosis is still very bad. 70% of the patients will progress on chemo and IO. We need to escalate treatment for those patients. Based on trying to mirror the scenario that we have in mismatch repair deficiency with high tumor mutation burden, there was this proposal of including PARP inhibitors. 2 trials, the RUBY Part 2 and the DUO, we have explored the use of PARP inhibitors to induce DNA damage, increasing TMB and new antigen presentation. PARP inhibitors also activate cGAS STING pathway, stimulating the interferon signaling and an immune permissive microenvironment. 2 trials have been presented so far with the combination of PARP inhibitor and immunotherapy in endometrial cancer in first line. First, the RUBY Part 2, after the combination with chemotherapy and dostarlimab, patients were randomized to be submitted to dostarlimab and niraparib or placebo, and the study was positive in the mismatch repair proficient population for its primary endpoint, progression-free survival, a hazard ratio of 0.63, a reduction of approximately 40% in the risk of progression or death. So the combination of PARP inhibitor with IO improving in this very difficult to treat population, the progression-free survival. Similar results in the DUO trial. Patients with advanced disease first line, patients could have been submitted to chemo 1 year before in the adjuvant setting. Over 700 patients randomized among 3 arms: chemo alone, chemo IO, and PARP inhibitor here, olaparib combined to durvalumab on the maintenance phase. As you can see here, the gain for patients who are mismatch repair deficient, they are the same for patients who receive or not the PARP inhibitor. So the benefit comes from immunotherapy, hazard ratio 0.3, a reduction in the risk of death of 70%. And when we focus on the more difficult to treat population of mismatch repair proficient patients, the combination brings higher response rate, not only, but a significant increase in the progression-free survival from 9 to 15 months. So this is the best progression-free survival in the proficient mismatch repair proficient cohort we have when we compare all the trials. We need to emphasize that there are significant differences in inclusion criteria, and we should be careful, but this is the best progression-free survival, the combination of PARP inhibitor, olaparib, and durvalumab, 15 months of progression-free survival in the proficient cohort. Okay, so we've discussed that the deficient cohort goes very well with immunotherapy, that we need more for the proficient cohort in mismatch repair, and that dividing type 1 and type 2 as mismatch repair deficient and proficient would be another mistake again, and we should be careful, and we need to continue to look for more biomarkers. And which are biomarkers of special interest at this moment in endometrial cancer? According to the SGO, mismatch repair deficiency, MSI, TMB, P53, HER2, and hormone receptor are predictive of response to agents. And L1 CAM, CT, NNB1, POL, PD-L1, R8, and PI3K, AKT, mTOR are prognostic and exploratory biomarkers. The PORTEC-4A in the adjuvant setting has just been published last week, and it has divided patients according to CTNNB1, patients who are proficient, only the proficient cohort, and the benefit was seen for more treatment when the patient has a mutation in CTNNB1. Probably this biomarker will be updated as a predictive of response, not only prognostic. And P53, this is a very important biomarker in endometrial cancer. The first analysis of the RUBY, exploring the biomarkers in the RUBY trial, the mismatch repair deficient cohort seemed to benefit a lot from immunotherapy, and also the TP53 mutant cohort. But the DuoE group has further explored the biomarkers. This data was presented at the IGCS Congress in Dublin last year. And as you can see, 84% of the patients were positive for one or more biomarkers. Here, we are just focusing on the mismatch repair proficient cohort. PD-L1 positivity is the most common, and TP53 mutation. As you can see, there is a significant overlap between biomarkers, and trying to identify patients who benefit more differently from the RUBY analysis. Here, both TP53 mutant and wild type have presented benefit from the addition of immunotherapy. So according to this biomarker analysis, only focusing mismatch repair proficient cohort, there isn't a single biomarker to select patients for the use of immunotherapy. There is a clear trend for benefit for immunotherapy. This was the UTOLA trial, a phase 2 trial testing the addition of PARP inhibitor on maintenance in endometrial cancer patients after the treatment of platinum-based chemotherapy. The study was negative for the use of PARP inhibitor alone, but there was a trend for benefit for the PARP inhibitor in the subgroup of patients, P53 mutant. So probably here in the P53 mutant cohort, there is a group of patients, a higher percentage of homologous recombination deficiency. It may be a surrogate biomarker for greater benefit of platinum and also from PARP inhibitors. And there is this very interesting drug, selinexor, which is a selective inhibitor of nuclear export, the protein exportina, and this is in patients who are wild for P53 mutation, not non-mutated patients. There was a huge benefit with this simple and oral drug for, so in this wild type cohort, a significant benefit in endometrial cancer for patients who are TP53 wild type. So a tendency to escalate treatment for patients who are mutated and de-escalate. The phase 3 trial just for wild type patients are ongoing, so we don't have the results, but this is a very promising data maybe to de-escalate treatment for these patients who are P53 wild type. And focusing on the biomarkers to select patients for the mismatch repair proficient patients for the use of PARP inhibitor and immunotherapy. So far, based on the Shannon Westin analysis that I've just presented to you, there isn't a clear biomarker to select patients. There was a clear benefit for the combination of chemotherapy, of the triple combination of chemo, IO, and PARP inhibitor, a clear shift for your left, the benefit for the PARP inhibitor combined to IO, but there was not a clear biomarker to select patients who do not benefit from the triple combination. PD-L1 unexpectedly was predictive of benefit, and TP53, again, patients mutated seemed to have a little bit bigger benefit compared to wild type. But again, these are exploratory analysis, and according to this analysis, homologous recombination status, BRCA mutated very few patients, and histology could not select patients who should receive the combination. We've been trying to use hormone receptor blockers. The benefit seems to be better when we combine it to cyclin inhibitor. This is a promising combination for first line. HER2 is also, now we have data for the second line, but there is a trial, the Destiny is open in the first line to submit patients. ctDNA, there are exploratory analyses showing that patients who have positive ctDNA at the beginning of the maintenance phase, they have a higher clearance of ctDNA, and they also have the patients who are negative with maintenance treatment, they have less rebound of the combination. So let's follow the data on ctDNA, very interesting data. And very important when analyzing biomarkers in endometrial cancer, we need to know that there are patients who are multiple classifier. For example, as you can see in this analysis, patients who are mismatch repair deficient and P53 abnormal. These patients behave like mismatch repair deficient, so the prognosis follow mismatch repair deficiency. Also, patients who are polymutated and P53 mutant, the behavior is for pol mutated, very good prognosis. So be careful with the multiple classifiers. The usual P53 mutant here is not as important as when this biomarker comes along. And besides biomarker, we need to know where is the patient. For example, was the patient treated before in the adjuvant setting? Patients who were previously exposed to platinum in the adjuvant setting, they do better, for example, with the combination of IO and lenvatinib. This was the LEAP trial, and we are waiting for the data in the mismatch repair deficient cohort of pembrolizumab compared to chemo, dostarlimab compared to chemo, to try to avoid chemotherapy in first line for mismatch repair deficient patients. Biomarkers and clinical context, adjuvant setting before or not, are very important to define the sequence of treatment in endometrial cancer. And also very important to treat endometrial cancer, you need to know that the attrition rate, the percentage of patients who are not going to be submitted to further lines is very high in endometrial cancer. This is Dr. Robert Coleman data. and published last year, showing that only 53% of the patients treated in first line will be submitted to second line. So don't keep your tools for second line, because half of the patients will not have the opportunity to be treated in endometrial cancer. So wrap up, this is a very heterogeneous disease. Molecular subgroups are prognostic and predictive. There is ongoing need to refine molecular subgroup. In first line today, we are going to treat patients mismatch repair deficient with combination of chemo and IO. Proficient patients, if they have good performance status, they have a very bad prognosis, and they should be treated with chemo, IO, and PARP inhibitor. But if you have access to Destiny, maybe this patient should be tested for HER2 and included in a clinical trial, because HER2 is a very important biomarker in endometrial cancer, and we need to consider previous treatment, hormone receptor, clinical conditions, and previous treatments I've said. So endometrial cancer, if we need to think about the sequencing of treatment, and it's not a binary decision any longer. So thank you very much for your attention.
Thank you, Dr. Angelica, and thank you, everybody. It was a nice presentation. I would like to introduce our second speaker for today. He is a well-known figure in UAE, Dr. Hassan Jaffa. So he is a medical oncologist consultant. He is now working at Burjeel Medical City. He completed his fellowship in hematology oncology and certified as a medical oncologist, hematologist in the American University in Beirut. And he is now working with us in the UAE, and he's the author of co-author of more than 50 peer reviews, abstracts, and he's involved in a lot of medical research. He's now ongoing 6 phase 2 and phase 3 trials in the region and international. He's also a member of the Gulf Oncology Group that is conducting phase 2 trials here. Welcome.
Good afternoon, dear colleague. Thank you, Dr. Zahdi, for this kind introduction. Thank you for Dubai Hospital and the scientific committee for giving me the opportunity to be here today with you. I will try to finish my presentation within the next 15 minutes. So my task is just to show you the role of PARP inhibitors in ovarian cancer. Now, just as a background, we know that ovarian cancer is the 5th most common cause of death in female. And although we know that the incidence is very low, it is 1.1 for the whole cancer, but even it is rank 5. So the 5-year survival overall, it is almost 50%. The vast majority of those patients are diagnosed in stage 3 and 4 disease. And this is the problem with ovarian cancer. Usually, in 2023, reported 20,000 cases. So again, when we treat patients with the stage 3 disease, we know that eventually they relapse. Within 70 to 90% of those, they will relapse even with the very effective treatment. And stage 4 disease, almost 90 to 95%, they relapse. Now, we know the vast majority of ovarian cancer are epithelial, and we know that high serous forming around 70%, and also high endometrioid. Those are the most frequent carrier for HRD positive and BRCA positive, while the other histopathology is less likely to have this pathway. And we know that the other diseases have a different pathway than those lesions. So if we see the high-grade serous and high-grade tumors of the ovarian cancer, we see that germ cell BRCA mutation form around 12 to 13% of those. If you add the somatic as well as the germ, it can reach around 22%. If we look into the HRD forming around 50%, we left with almost 50% who have HR proficient tumors. And these are the more details about each mutation that make the HRD deficient versus the others which have a different mutation. Now, we know the landscape of management when we see patients. Either we start with upfront surgery, or we give neoadjuvant chemotherapy, interval debulking surgery. Then we give adjuvant treatment, and then there is a maintenance phase with bevacizumab, or just follow up all of those patients, and then they relapse. When they relapse, even the duration of secondary relapse will be even shorter. So why we need genetic testing? We need genetic testing because we know that this is the first line treatment. When we give it without really an effective treatment that can differ that line, 20% we left with platinum resistant, 20% with partial platinum sensitivity, and around 30-35% they have a sensitive relapse, which they relapse between 1 to 5 years. And almost around 20 to 30% those patients, they may have a very long relapse-free disease. But we have that majority of patients, as we mentioned, 70 to 80% relapse. So how we can do better and push that curve later so we can have a sensitive relapses where we have a better treatment for those patients. And this is why HRD identifying and incorporating the PARP inhibitors in the maintenance phase to delay that relapse and probably to cure some of those patients. If we look into almost all the guidelines, we see that they strongly suggest doing these germline and somatic anti-HRD for all those patients with ovarian cancer because it impacts the management of those patients and even for germline, the family and the screening for those family, even in the absence of a history of ovarian or breast cancer. Now, if we look into the PARP inhibitors approval in ovarian cancer, we see the first drug approved was olaparib, and this based mainly on the solo data for BRCA mutated population. Then we have the niraparib in 2022, and those for all comers. If we see the olaparib with bevacizumab for HRD positive, and this is on Paula, and then we have in 22 the approval for rucaparib, and again for all comers. Now these are the clinical trials which address the maintenance in the first maintenance treatment, and we will come trial by trial. If we look into the solo trial, those patients with the stage 3 and 4 disease who have a BRCA mutated population 2-to-1 randomization to either olaparib or placebo. If they had the surgery and they have partial or complete response to platinum, they were randomized. And if you look into the outcome of those, were very significant improvement in the progression-free survival. So the hazard ratio was 0.38. Yes, 0.38, and there was almost 1 year gain in the progression-free survival. And if you look into the tail of the curve, it's almost double those patient progression-free survival. And if you look into the overall survival, this was also translated into an overall survival gain for those patients. And again, the hazard ratio 0.55. If you look that 44% of patients were crossed to PARP inhibitors upon progression, and even with this, those patients, they have this significant improvement in overall survival. If you look at 84 months, 7 years follow-up, we see that still there is 67% alive versus 45% without the PARP inhibitors, or they didn't receive it in the first maintenance. So this is an important and impressive advances in the management of ovarian cancer. Then we came to the PRIMA, and here they address the role of niraparib. And those patients, again, stage 3 and 4 ovarian cancer, they had surgery, they had 6 to 9 cycles of chemotherapy. Neoadjuvant were allowed in those population. Again, 2-to-1 randomization, and they address it for all comers. So they have HRD positive, HR proficient population, and BRCA. And we know that with rucaparib, there was the different doses, so dose adjustment according to the weight and the platelet count. So they started with 200 if the weight is less than 77, or the platelet less than 150, while those they have the full dose of 300 if they are higher. And we see that if the dose adjusted or the standard dose, they have a similar outcome, and it was better. And we see it in the HRD population as well as for the overall population. If we look into the differences between the HRD and the HRP, we see still the hazard ratio in the HRP population was positive. But if we look into the longer follow-up at 7 years, there was no differences between the two arms, 6 versus 7% for both population. But in HRD population, the hazard ratio 0.5. Now, if we look into the overall survival for all comers, this was not achieved. The hazard ratio was almost 1, so there was no benefit from that treatment. Again, if we look into splitting HRD versus HRP, again, we didn't see any overall survival for those patients. But again, most probably justification for that is confounded by the longer follow-up, as well as many of those patients has been crossed over to PARP inhibitors. Again, you see almost 50% of those patients in the HRD, they crossed over to PARP inhibitors. Here you see the population with HRD, 57%, they have PARP inhibitors in subsequent maintenance treatment when they progress. Then we have the PAULA study. We know that bevacizumab, one of the best maintenance treatment for those who have really advanced disease, whether stage 4 or suboptimally debulk. We were using it as a standard of care. So they use for those patients who use bevacizumab to add on top of this olaparib and for all comers. And they were randomized olaparib plus bevacizumab versus bevacizumab. And you see the subset of those patients, whether they are HRP or HRD or BRCA mutated. And again, we see a very significant improvement in HRD positive. There was a significant improvement in progression-free survival. You see the differences at 60 months, 19% in the control arm versus 46%. So this was a very significant improvement. If you look into the intention to treat population, there is some improvement in the overall survival, but if you look into it split it for HRD positive, it is very significant improvement in overall survival for those patients with a hazard ratio of 0.62. So it has been approved for HRD positive population for PAULA study. Then we have the last one, the rucaparib, and this is 4 arms incorporating immunotherapy, but these data are based on rucaparib maintenance, single agent versus placebo, and Athena mono. And again, the same inclusion criteria. Patient, they have partial sensitive response or complete response to chemotherapy and then maintain to rucaparib. And we see that, again, in the intention to treat population and the HRD population, the data for progression-free survival were positive. And again, if we look into the progression-free survival, even with the HRD proficient, there was a statistical significant improvement in delaying progression. This is the subgroup analysis, and we see it across all subgroup analysis, there was benefit. So if we look into the guidelines, so those patients with germline or somatic BRCA mutation, we have the 3 drugs approved. If we have HRD positive population, we see those patients, again, either can go for niraparib or the combination of olaparib plus bevacizumab or rucaparib. For HRD proficient, we have only approved niraparib and rucaparib, but again, the magnitude of benefit is not as we saw it with the HRD positive and the BRCA. What about if that patient missed the first maintenance treatment? We know that in the second maintenance, so platinum sensitive relapse, those patients after responding to platinum, they tried the olaparib in solo 2 and study 19. In study 19, there was the BRCA mutated as well as those with non-tested population, so all comers. We see it was positive. Again, it's much higher in those with carrying BRCA positivity, but most of those patients, so BRCA sensitivity can predict response to a second maintenance PARP inhibitor if they didn't use it in the first line. And this was also in the NOVA for niraparib and also for rucaparib, the area 3. So all of those are also approved in the second line if they second line maintenance if they did not use it in the first line. Now, what about reintroduction of PARP inhibitors after using PARP inhibitors in a previous maintenance treatment? And this is again maintenance treatment, and this is the OREO trials, phase 3 trials included 220 patients. Also, they saw in a platinum-sensitive population after a response of platinum, they still have a better progression-free survival if you maintain those patients on olaparib. You see that the differences is almost double the progression-free survival from 2.8 to 5.3 in BRCA wild and as well as in BRCA mutated population. So the label indication, PARP inhibitors has been approved in the first maintenance, second maintenance, or even sometimes in selected cases for rechallenge. But as a treatment, this has been withdrawn approval because of detrimental effect. Using PARP inhibitors as a treatment in relapses compared with chemotherapy was inferior. So this was in rucaparib and olaparib trials. So they withdraw the approval, as well as the niraparib has been withdrawn the approval. Now, there are different combinations. The future is trying to combine the immunotherapy. We know there are some data was negative in platinum-sensitive tumors. We have data positive in platinum-refractory tumors. We know the ovarian cancer is a cold tumor, so the combination in the future can probably answer some result or some questions. We know also different drugs with the WEE1, PIK3 kinase inhibitors, and even chemotherapy, incorporating these PARP inhibitors with different target treatment probably can potentiate the effect of those patients, especially in those HR proficient tumors. So these drugs, there are differences between them. We know the doses are different. We know that the duration of the treatment in the first maintenance, 2 years for olaparib and rucaparib, but 3 years for niraparib. And we know that there are different drug-to-drug interaction. We know the hematological toxicity is much higher in niraparib, and this is why we try to tailor the treatment according to the weight and platelet and the threshold to drop it, because if you see grade 3 and 4 toxicity, hematological toxicity is a little bit higher in niraparib versus olaparib and rucaparib. Also, we know that those drugs are associated with MDS and secondary leukemia. It's between 1 to 2%. And again, limitation, the duration, and taking consideration of the blood tests are important for those patients. We know that also there is a common toxicity. You see that nausea and vomiting is similar between these drugs. It is of moderate. Rarely we see grade 3 and 4. So also taking treatment for the nausea, vomiting, fatigue, all this has to improve the compliance of those patients. We know there are specific also side effects for each of these drugs, and sometimes a transient elevation of creatinine. This is mainly because of a blockade of certain enzymes in the reabsorption tubules. So it's not a real deterioration in renal function, but it needs to be carefully observed. If we look into the progress in ovarian cancer, we see a lot of drugs are happening and improving the outcome. And we have to make use of all these advances, because if you look into the recent data, we see that we are improving the mortality rate, decreasing the mortality rate. And if you look at the prevalence of those patients who are living with ovarian cancer, are getting much, much higher. So we are trying to treat those as a chronic disease and living more with ovarian cancer. By this, I finish my presentation. Thank you very much.
Thank you very much, Dr. Hassan Jafar, for a very elaborate overview of a very challenging and very interesting topic. Now with this, I would like to introduce our next speaker, Dr. Faisal Azam, who's very well known regionally and very much a local figure now. He's been here giving us, in the meetings here very regularly. Even hotel staff recognizes him very well. So Dr. Faisal is an eminent medical oncology consultant from King Fahd, the specialist hospital in Dammam, Saudi Arabia. And he has extensive experience in medical oncology, number of peer-reviewed publications under his belt, and been involved in a number of regional and international studies as an investigator. He has enlightened us with his talk on updates in management of advanced cervical cancer with focus on the first line. Dr. Faisal Azam.
Thank you. Bismillah ar-Rahman ar-Rahim. Thank you very much, Yasser. Thank you, Hamad, Farouk, Dina, and the organizing committee for inviting me and asking me to talk about the management of advanced cervical carcinoma. This one, yeah. All right, so these are my disclosures. So cervical cancer, as you probably all know, that is almost exclusively due to the human papilloma virus. And most of the cases are in the low or middle income countries, and mortality is also common in those countries. But the good thing is it is 100% curative or preventable if we do mass vaccination for the HPV in the population. And we have a screening program in different countries around the world, which is helping or preventing the cervical cancer. Even if we find the cervical cancer in early stages, we can still cure it. This is a world map of the incidence for cervical cancer, and as you can see, mostly in the low income or middle income countries, and this is the mortality. Similarly, again, more common in those countries which have low income or middle income countries. The general treatment is for initial stage, it's surgery. More advanced stages or locally advanced is concomitant chemoradiotherapy. And for metastatic disease, we give systemic therapy. The guidelines recommend if we are giving concomitant chemoradiotherapy is platinum-based chemotherapy mainly, and now recently pembrolizumab has also been approved for that. And also induction chemotherapy with carbotaxol followed by concomitant chemoradiotherapy is recommended. For metastatic disease, if patient have PD-L1 positive, then we add immunotherapy, which is pembrolizumab to chemotherapy plus minus bevacizumab, and atezolizumab is also approved to be added to chemotherapy and bevacizumab. So I'll discuss first the locally advanced cervical cancer management. So this is the phase 1 study called NRGGY017, where they use neoadjuvant atezolizumab for 3 cycles followed by concomitant chemoradiotherapy, and atezolizumab was added to it. The control arm was atezolizumab plus concomitant chemoradiotherapy. The idea was if we give immunotherapy before the concomitant chemoradiotherapy, will it increase the immunogenicity and will it be more effective or not? And it has shown that those patients who have neoadjuvant atezolizumab, they have stronger expansion of tumor-associated T cells, 2-year disease-free survival was better, although statistically not significant, but that was not the primary aim of the study, and pathological responses were much higher. So that means if we are giving immunotherapy in neoadjuvant setting, it should work better. Then we have phase 3 study called CALA study, where they use durvalumab plus concomitant chemoradiotherapy, and durvalumab was then used for 24 extra doses, and the control arm was concomitant chemoradiotherapy. Idea here is if you add immunotherapy, will it improve the outcome for patients with advanced cervical cancer? The study was negative. So if you give a neoadjuvant setting, it works, but when you add it to concomitant chemoradiotherapy, the progression-free survival benefit was not seen. Then came the Interlace. Interlace is a phase 3 study where they give 6 weeks of weekly carbo and Taxol chemotherapy as an induction, followed by concomitant chemoradiotherapy, and the control arm was concomitant chemoradiotherapy alone. And this study was positive in terms of progression-free survival, as you can see, significantly better with induction chemotherapy, and overall survival benefit was also seen in those patients who have induction chemotherapy, hazard ratio of 0.61. So we have seen that if we are giving new adjuvant chemotherapy or new adjuvant immunotherapy, it works very well. But when you add the immunotherapy to concomitant chemotherapy, CALA study showed it does not work till we had this study, Keynote A18, which led to approval of pembrolizumab. And this is a study, a phase 3 randomized double-blinded study where they included patients with 1B2 to 2B with node positive or stage 3 and stage 4 disease. Patients were randomized to receive pembrolizumab with concomitant chemotherapies, 5 cycles followed by 6 weekly pembrolizumab for 15 extra cycles, and control arm was only concomitant chemoradiotherapy. Now this study was positive with 24-month progression-free survival rate where the delta was 10%, so favoring using pembrolizumab along with the chemotherapy. Hazard ratio of 0.70. Overall survival benefit was also significantly better when we added pembrolizumab to a concomitant chemoradiotherapy, and the benefit was 7%, in the arm where they used pembrolizumab along with concomitant chemoradiotherapy. Objective response rate, delta was 3.4, favoring using pembrolizumab as compared to not using pembrolizumab. So then in the standard of care now is to use either induction chemotherapy for 6 cycles, weekly carbotaxol, then concomitant chemoradiotherapy, or if you are not using induction chemotherapy, then we can use pembrolizumab along with concomitant radiotherapy, and pembrolizumab can then be used for extra 15 cycles. Moving on to metastatic disease for first-line treatment for metastatic disease. This is one of my patients which I have treated. So I'll just briefly share her story. 44-year-old lady who had advanced cervical cancer 1B2 was the stage, grade 2. She underwent surgery and pathology confirmed that to be moderately differentiated squamous cell carcinoma, no lymph node metastases. She underwent pelvic radiotherapy and post-hoc follow-up showed no abnormalities for nearly four years. She was under the gynae team for 4 years. And after 4 years, she presented with shortness of breath for a few weeks, dysphagia, hoarseness, chest tightness, coughing, and bloody sputum. The gynae team did the gynecological examination. It was normal, and CT scan showed extensive mediastinal and hilar lymph nodes, which were compressing on the esophagus and also on the bronchi. Pulmonologists saw the patient, did bronchoscopy, and they reported narrowing of the lumen of the left main bronchus, and there was a bleeding mucosa. Endoscopy by GI team reported stenosis due to external compression, and PET scan also confirmed enlarged hilar lymph nodes, mediastinal lymph nodes, and periaortic lymph nodes. We biopsied the mediastinal lymph node, and that confirmed it to be metastatic squamous cell carcinoma from the cervix. PD-L1 CPS score was more than 10. So this is her CT scan. As you can see, extensive mediastinal and hilar disease, and it's pressing on the bronchi and esophagus, causing all these symptoms. So she was started on cisplatin, Taxol, bevacizumab, and pembrolizumab because her PD-L1 was high. And after 3 cycles, significant improvement in her symptoms. PET scan after 6 cycles reported nearly complete response. And she's currently on bevacizumab and pembrolizumab 12 months after completion of chemotherapy, and she is disease-free. She was seen only 3 weeks ago when she had a PET scan, and she is doing very well, performance status of 1, disease-free, and we are continuing with bevacizumab and pembrolizumab. So carboplatin and Taxol has been care, or platinum-based chemotherapy plus Taxol has been a standard of care for many years. GOG 204 study compared different regimens like paclitaxel with cisplatin, vinorelbine with cisplatin, gemcitabine with cisplatin, and topotecan with cisplatin, and they've reported the responses are higher with cisplatin and Taxol, but comparable toxicity. So, and that is why most of the oncologists would prefer to give cisplatin with the paclitaxel. And then how about bevacizumab? Is bevacizumab adding anything to chemotherapy? So GOG 240 study looked at the adding bevacizumab to 2 different regimens, paclitaxel plus cisplatin and paclitaxel plus topotecan. And they have reported that if you add bevacizumab to any regimen of chemotherapy, it improves the overall survival significantly. And this survival benefit is even more in patients who were not irradiated. So we know now if you are adding bevacizumab, it improved the survival. So then came the immunotherapy era, and BEAT-CC was a phase 3 study where they tested atezolizumab to chemotherapy, and bevacizumab was the mandatory part of the study because previous study showed improvement in overall survival. The study was positive, as you can see, progression-free survival, overall survival, favoring adding atezolizumab to chemotherapy and bevacizumab, and the benefit is significantly favoring atezolizumab. Objective response rate of 12% benefit, more than the chemotherapy plus bevacizumab when you add atezolizumab. So these are the final results from BEAT-CC study when you add atezolizumab to chemotherapy plus bevacizumab. Median progression-free survival benefit was seen for more than 3 months. Median overall survival benefit of 10 months. Objective response rate 12% benefit. Complete responses 12% benefit. Median duration of response is also nearly doubled, or 4-5 months benefit. Time to first subsequent therapy and progression-free survival to all favoring atezolizumab plus chemotherapy plus bevacizumab. Then the keynote 826 study came, which is a phase 3 study, and that led to approval of pembrolizumab along with chemotherapy. So the difference between the atezolizumab study and pembrolizumab study is in the atezolizumab study, bevacizumab was mandatory part of the protocol. Here, they let the physician to choose if bevacizumab is needed or not. Anyhow, first-line study for metastatic cervical cancer, they randomized patient to pembrolizumab plus chemotherapy plus minus bevacizumab. Control arm was chemotherapy plus minus bevacizumab. So there were patients, around 40% of the patients who did not receive Avastin, and there were around 30 or more than 30% patients who had de novo metastatic disease, which are more aggressive. So looking at the results, progression-free survival in patients who have PD-L1 CPS score of more than 1 or more than 10, progression-free survival was favoring giving pembrolizumab to chemotherapy as compared to chemotherapy alone. And the results are similar if the PD-L1 positive is either 1% or 10%. So regardless of the expression, if you give pembrolizumab, the benefit is seen. So this is what you are seeing here. In all comers also, the hazard ratio was 0.65. The subgroup analysis, the benefit is in favor of pembrolizumab for all groups except those patients who have PD-L1 negative disease. And that is why it is only recommended for PD-L1 positive disease. The updated analysis in 2023 reported the results are similar as the interim or initial analysis. Overall survival benefit was also significantly better, favoring pembrolizumab, adding to chemotherapy plus minus bevacizumab, and that is either the expression is very high or low, but it should be positive. The results are similar. You look at the hazard ratio of 0.64 or 0.61 for PD-L1 of more than 1%, more than 10%. So more or less similar if they are positive. All comers, hazard ratio of 0.67 for overall survival. Similar to progression-free survival, overall survival subgroup analysis reported similarly. All groups of patients favored adding pembrolizumab to chemotherapy, except those patients who had PD-L1 negative disease. And so, as I mentioned to you, it is only recommended for patients who have PD-L1 positive disease. Updated analysis reported similarly, regardless of the PD-L1 expression, if they are positive, they will favor pembrolizumab adding to chemotherapy. Similarly, objective response rate, either in PD-L1 of 1% or 10%, favoring pembrolizumab adding to chemotherapy as compared to chemotherapy alone. And adding pembrolizumab, as we know, does not add much of the adverse event. They are more or less similar to like the chemotherapy group. And these are the common side effects. Mostly grade 1 and grade 2, grade 3 and grade 4 were pretty much rare. So it is now a standard of care to give pembrolizumab along with chemotherapy as overall survival and progression-free survival has been seen in patients with PD-L1 positive disease. In previous study, we have seen that the adding bevacizumab improved the overall survival. So in this study, some of the patients received bevacizumab while others did not. So they wanted to prove it's not the bevacizumab. In fact, it's the pembrolizumab which has shown to improve the survival. In a atezolizumab study, bevacizumab was the mandatory part of the protocol, so we don't know either was immunotherapy or Avastin improving the survival. But here they wanted to do subgroup analysis to confirm this. So there are around 40% patients, as I mentioned to you, who did not receive bevacizumab, and 60% did receive, and they compared those groups in patients with PD-L1 CPS score of more than 1, progression-free survival in patients who had bevacizumab and who did not have bevacizumab was exactly similar. As you can see, has a ratio of 0.56 with bevacizumab and 0.61 without bevacizumab. The benefit is because of pembrolizumab and not because of the Avastin. Then in all comers, progression-free survival benefit with bevacizumab on the left side and on the right side without bevacizumab has a ratio of 0.57 and 0.69. It is with pembrolizumab and not Avastin. How about overall survival? the PD-L1 CPS score of more than 1 with bevacizumab or without bevacizumab, the hazard ratio was exactly the same. So it's not the bevacizumab, in fact, the pembrolizumab, which is improving the overall survival. Similarly, in all comers, it was seen. But here, where the difference is, if you look at the two sides, here, this is with bevacizumab, and the objective response rate is 77%, while here, without bevacizumab, objective response rate is 53%. So 25% difference in objective response rate when you add bevacizumab to immunochemotherapy. In all comers, again, 25% difference is seen. So any patient with extensive disease where you want, or high bulky disease, you want to achieve higher response rate, maybe adding Avastin to chemotherapy is needed. And adding Avastin increased hypertension and proteinuria slightly, but generally the side effects were more or less similar. So just my last slide, advanced cervical cancer is challenging medical disease with poor prognosis. Advances in immunotherapy have improved survival. Pembrolizumab plus chemotherapy with or without bevacizumab in PD-L1 positive disease is a new standard of care in the first-line treatment. Adding bevacizumab to pembrolizumab plus chemotherapy improved overall objective response rate, but no impact on progression-free survival and overall survival. So these patients where you want to achieve higher objective response rate, adding Avastin is probably recommended, but overall survival, progression-free survival benefit is not seen by adding Avastin. Thank you very much. You remove this picture, I took it just outside my office actually, so I wanted to show you that, the view from my office.
Thank you, Dr. Faisal, for this very nice updated presentation. Dr. Dalia, she is a highly experienced consultant medical oncologist. She was with us in DHA, and then now she abandoned us and she went to SSFT, which is fine. So she had a vast experience, and she is also an assistant professor in Egypt in the Clinical Oncology University Hospital. She has to talk about today about the case presentations and endometrial cancer. Please.
Assalamu alaikum, everyone. Thank you, Dr. Zohdi, for the introduction. Thank you, Dr. Hamad, Dr. Farouk, Dr. Dina, and all Dubai Hospital team for the invitation. So I will present one of my patients. She's an endometrial cancer patient. So she is a 36, very young lady. She's working as a maid. Her history back to Jan 2024. So she presented to a private hospital, an outside facility, not in our hospital, with abdominal pain, and she had some investigation done there. So first, she had ultrasound abdomen in January 2024 and showed enlarged uterus, lipulated outline, variable size in masses, suggestive of fibroids. So it was the biggest mass lesion was about 8 by 8 centimeters, huge mass. And this is her scans. MRI of the pelvis, so huge mass, 14 by 9 by 8 centimeter, a few lesions noted in other areas, and they suggested it as a fibroids. So the patient actually was taken in January 2024 in the same hospital and had hysterectomy and right oophorectomy. They preserved the left ovary. And then the post-operative pathology unfortunately showed it as a carcinosarcoma T3 and XMX. She didn't receive any adjuvant treatment at this point of time. 6 months later, she came to our hospital, presented to us with abdominal pain, slight vaginal bleeding, and had MRI done at this point. And this MRI image, it showed likely residual clump of hydrosalpinx with left ovarian tissue with a focal, well-defined hemorrhagic cystic focus. So the gynae team decided to have a medical management, and the case presented in the MDT, gynae MDT. And this is her PET CT scan at this point in August 2024. Again, didn't show a lot of disease, nothing, just post-operative changes. So we decided to follow up the patient. Because the PET scan showed thyroid uptake, we had a biopsy and it came as negative, no malignancy. And then 6 months later, the patient presented, had another PET CT scan, as you can see here. There is disease, as you can see, mesenteric, omental, middle, also lung lesions, abdominal peritoneal deposits, as well as the thyroid nodule that was FDG avid. So the patient attended as a walk-in, complaining of pelvic abdominal mass. You can feel it and you can palpate it. And as you can see here from this CT scan in December 2024, huge pelvic abdominal mass. And if you look to this mass, what will be your first impression? Yeah, it is a clear recurrence, but honestly speaking, we thought it could be another pathology. However, we did a histology pathology review in our hospital, and it showed the same carcinosarcoma. So HER2 positive, 3 out of 3. PMMR or non-DMMR, I prefer to pronounce it like this or to call it non-DMMR. And estrogen receptor and progesterone receptor, I guess it was negative as well. So we discussed the case in the tumor board, and she was seen by the gynae team as well, and they decided it's not for any operation. And after reviewing the pathology, the decision was to start on systemic therapy. So the patient started on concurrent, chemo and immune checkpoint inhibitor, and by March 2025, clinically the patient improved in the form of less bleeding, less abdominal pain, less pain medication. You can feel the mass itself is less in size when you examine the patient. So, and radiologically, you can see there is some difference. It's not significant difference, but there is some reduction in the size of the pelvic abdominal mass. I took the patient back to the MDT for possibility of debulking of this mass, but the gynae oncology team said no, it's the same. So keep on systemic therapy. So this is her further scan in May 2025 with further reduction after 6 cycles of chemotherapy, and currently the patient is on immune checkpoint inhibitor. So persistent reduction in October 2025, you can see here significant reduction in comparison to the initial one. When it comes to the tumor marker, I know it is a carcinosarcoma uterine related, but you can see there is a difference in the CE125 that's significantly reduced. When it comes to tolerance-wise, immune checkpoint inhibitor related side effect, we didn't observe a lot of significant endocrinopathy, for example, or the liver enzyme raised only one time in September 2025. With that, I finish my case, and thank you so much for your
Thank you very much. I would like to have all the speakers to the panel here for discussions and questions. Please, Dr. Faisal. Dr. Adalia, please. Yes. Hassan? Oh, yes. Yes, please. Yes, Dr. Angelica, please. So, any questions from the audience? Yes, please. Can we bring a microphone for the doctor, please? Questions? Thank you.
So I have a question on the uterine endometrial cancer. So obviously you presented a complex map of biomarkers and all that, these 3 studies that leave us in the private practice, you know, wondering who do we really gonna give a triplet therapy versus just chemotherapy? Maybe is there a role for chemo alone, or in the proficient, let's say MMR, or are you giving IO at least to all comers? That's a common question. And leaving the second line, perhaps space open.
Very good question. I think that there is no room for chemo alone. If you are considering chemo, this patient has an aggressive disease. So I think that we can divide patients now who are mismatch repair deficient. And this patient, at this moment, the best data is the combination of chemo and IO. Maybe in the future, we are going to treat some patients without chemo in this group. We have 2 trials ongoing focused on this population. LEAP was negative, but it was for all comers, not only for mismatch repair deficient. And in this subgroup, it was positive in the mismatch repair deficient. So maybe we're going to treat patients with IO alone, focusing on this subgroup. And to close the discussion on mismatch repair deficient patients, 20% of those patients have aggressive disease. We need to know more about this subgroup. Moving for those patients who are not deficient, I will simplify saying proficient, but it's a very heterogeneous group of patients. This subgroup of patients, not deficient, have a very bad prognosis. And if the patient has a good performance status to be treated, the triple combination should be considered. In this subgroup of patients, there are the NSMP, no specified molecular profile. In this subgroup, there is the patient who is the elderly patient, very bad performance status, hormone receptor positive. For this patient, maybe I would go with hormone therapy. But for the other patients who have a good performance status to tolerate chemo, they have a bad prognosis, I would go with the triple combination, chemo, IO, and PARP inhibitor, because 70 to 80% of the patients are going to be dead after 2 to 3 years. So this is a very bad prognosis. And if we can test for HER2, and if Destiny is open, I think that it's not open in the region, I would consider for the first line, this is a good discussion for your case, which is a very interesting case. So consider the triple combination if the patient is not mismatch repair deficient.
I think just to complete for the follow-up sequence of therapy, there are other ADCs on the horizon. What do you think the future of them will be, like the TROP2 or other ADCs?
Yes, there are many ADCs and quite similar results. I think that with Sasi Chirumutecan, Sasi Govi, the benefit is not huge. I think that we saw a huge benefit with trastuzumab deruxtecan because the ADC is very good for HER2/3+, and in endometrial cancer also for HER2/2+. But I don't expect the same benefit with almost all I've taken part in some of the trials. They have good results, better than chemo probably based on phase 2, but I do not expect at this moment a huge revolution with other ADCs. I do expect good results with Destiny in the first line because this is a very selected population, a few percentage of patients, and this drug works very well. For the other ADCs, I think that we are going to have more options, but not a revolution. And this is my opinion at this moment.
Any comment on the folate also receptor? We've seen some data.
Very good data on ovarian cancer, but here in ovarian cancer, amazing data, and the data in ovarian cancer is moving from the platinum-resistant setting to earlier lines. For example, the Gloriosa has just finished the inclusion, and maybe we're gonna bring it to the first recurrence, and maybe to the first line when patients are diagnosed. But in endometrial cancer, this biomarker doesn't have the same strength. It's being tested, probably another option, but again, I think that we are going to have several similar options, and we need to know more about biomarkers. We need to further stratify patients just like we do with lung cancer. There is probably there will be small subgroups of patients who will benefit more for a specific ADCs.
Thank you very much, Dr. Ghazal, for a very enlightening question. Just a very quick one. In terms of the biomarkers we look at in the endometrial cancer, do you consider histological subtype as to help decide about the most optimal treatment, like carcinosarcoma or clear cell, or you look at the molecular classification and molecular
Yeah,
subgroups
this
mainly?
is this is very interesting data. All the guidelines had proposed that we should consider zeros, for example, as always as an aggressive and high risk disease. But just to go deeper on this discussion, for example, if we read the molecular analysis of the Portex-3, for example, the zero subtype, P53 wild type, had a better prognosis compared to the P53 mutated. So the driver was the P53 mutation. I must say to you that I'm not comfortable not to give chemotherapy if the patient is zeros, but I think that in the near future, we are going to stratify patients more based on P53 mutation in carcinosarcoma patients, in clear cell, than the subtype itself. And the PROTECT3 analysis in the adjuvant setting has shown it to us that P53 is more important than zero subtype. And in carcinosarcoma patients, this is a very important subgroup of patients. Did you consider to escalate to give IO and PARP inhibitor? What was the discussion at the board? Just going to her case because
Actually, this one of our um, early cases that we used immune checkpoint inhibitors. So honestly speaking, we were learning about the immune checkpoint inhibitor adding to the chemotherapy at this time point. So this was one of the first cases. So I decided to give, honestly speaking, the understanding of the molecular analysis and which is for like when to add the PARP inhibitor. Still till now we don't have that clear marker to which patient we have to add the PARP inhibitor. Yes, I agree with you about the B53 mutant. They are aggressive in general. The estrogen receptor negative status also should be considered. I guess also the high risk pathology like the carcinosarcoma, like also I have another patient with mesonephric subtype. So very aggressive subtype, but yeah, I agree with you. This group of patients, I think we should consider the triplet therapy with PARP inhibitor. Yeah.
Have a question from any
Anyone
question
from the audience? Any other question? Otherwise, me and him will take the lead.
Well,
No,
if
no,
we
not
can-
you, not you. Of course, of course.
Dr. Faisal.
Yes, yes, of course. Go ahead, go ahead.
Dr. Faisal, so you presented data on different combinations. Um, I think looking at the curves, however, I still think bevacizumab addition did improve, although the hazard ratios are similar. But you see better curves when you are adding bevacizumab, and the response rate was much higher. So why not in real life? I mean, we are giving the triplets now. Correct me if I'm wrong.
I agree with you actually. So the numbers are more or less similar, as you're saying, or slightly better with bevacizumab. I personally, if you're asking me, I do use. I do all the 4 drugs, so carbo, taxol, bevacizumab with pembrolizumab if they are PD-L1 positive. The objective response rate, of course, is one of the things which we are looking for. What they would try to see in the trial is that it's the pembrolizumab which is improving the survival, progression-free survival, overall survival, because the controversy was previously it was chemotherapy when they added Avastin, it improved the overall survival and not chemotherapy by itself. So this was the question, and then the first trial, Beat CC of atezolizumab, they made it mandated because of this reason. They thought that's the reason, and here they wanted to differentiate between it. So that's the reason. But if you're asking me in real world, I always use Avastin if there are no contraindication.
So I have a case just quickly.
I just have a comment because I mean, this was a clarification point because you said it is only improving the response rate. If you look into the 2 graphs, whether the control arm or the investigational arm, it's almost doubled. So I mean, there is a significant role for improving progression-free survival, overall survival for beva, as well as for immunotherapy. So if there is no contraindication for bevacizumab, always it's better to use it in combination.
Absolutely. So I have a current patient who had HIPEC even in France, and then she came to Dubai. But 6 months later, she has significant colitis, and we did the workup. It seems to be immune mediated. So how do you approach these patients now? She's on maintenance, Bev Pembro. Now we're developing immune-related colitis, grade 3.
Yeah, so I usually stop and treat. I have few patients of colitis is usually the common one. So we treat it like as we do any colitis. It takes around 2 to 3 months to go back to completely normal. Now, I do re-challenge also actually. So even if it is grade 3, if they recover quickly, re-challenging is okay as far as it's not a grade 4. Now regarding the Avastin, would you re-challenge Avastin or not? Again, if there's no...
Would you keep it going?
Yeah, exactly. So if there is no fistulation or no problem in bowel perforation or anything like that, I think it is safe to give as far as they have completely recovered. So it should be okay. I have re-challenged after grade 3 and they're usually okay.
So I have a question because this is, I think, we are facing in the practice now for cervical cancer as well, because we have now applied the Keynote 018 trial, that concurrent chemoimmunotherapy followed by immune checkpoint inhibitor Pembro. And I have a patient who completed this therapy and she's on follow-up and now she has metastasis. So, and she's PD-L1 positive. What do you choose for her?
Okay, this patient was not included in the trials in the metastatic setting. I have a question for you. Did the patient progress on pembrolizumab or did she stop and she had a relapse? I think this is important.
3 months, 4 months.
Probably she's not sensitive to immunotherapy any longer. I think that we don't have too many options here. So in cervical cancer advanced patient progressing on immunotherapy, this patient could go for the GOG 240, the chemotherapy combined to bevacizumab. This is the best data we have here, improving overall survival. It was just presented. If access is not a problem, if you want to continue with pembrolizumab, I think that we don't have data for that. It's an expensive drug and the patient progressed almost on the drug. I wouldn't defend pembro here. And again, we'll test the only biomarker that we have here for a further line is HER2 based on Destiny P01. If the patient is positive, maybe we are going to have a better option for the second line. So very bad prognosis for this patient, unfortunately. And this I would treat with chemo and bev. And you, Faisal, what would you do here?
I completely agree, actually. Giving immunotherapy is not the choice here. So giving bevacizumab along with chemotherapy is the choice, but they don't do very well, actually. Unfortunately, no matter what you do, they will progress.
What about tissue factor, ADC? We have a tissue factor related drug conjugate.
Yes, for second line, you have it approved here. Tisotumab vedotin. This is the best option for second line for those who have it approved. I think that if the patient is HER2 3+, this is a very good competitor. Response rate is very high. I don't have it in Latin America approved, so this is why my brain was not working for tisotumab, but this is the best option.
We have very experienced Dr. Diatrad as well. I was hoping to, just from your experience and the recent data, in terms of selecting which patients are going to be suitable for concurrent immunoradiotherapy or the induction chemotherapy followed by radiotherapy, what are your thoughts based on the data we have? How would you select,
I mean, the way to go is to give usually the concurrent chemo radiotherapy. However, you may have some patients who might not be, let's say, fit for the immune therapy. In such a case, you may go for the induction chemotherapy if they have quite advanced disease, very symptomatic, and to be followed by concurrent chemo radiation therapy. But usually the way to go is the concurrent chemoradiotherapy with the addition of the immunotherapy as well.
Just maybe one last question from Dr. Noreen as well. I mean, any biomarker here in this situation to select whether concurrent chemoimmunoradiotherapy is going to be better than the induction chemo followed by chemoradiotherapy?
Actually, not a biomarker for this, but we can conclude from both trials that the interlace was more effective in small tumors and limited effect with a nodal positive, while the keynote A18 was having a more benefit in larger tumors with nodal positive. But we cannot compare both trials, of course. They're complementary as well, so we cannot compare them, as well as the brachytherapy which was used in the trials was different. In A118, it was a mandate that they use an image-guided brachytherapy, while in the interlace, it was not a mandate, so 2D. So the comparison for them, it's not obvious.
Just maybe one last question from Dr. Hassan Jaffer. Any role for combining these therapies or any studies looking at, like giving induction chemo followed by concurrent chemoimmunoradiotherapy?
I mean, there is an ongoing clinical trials led by INH combining the induction chemotherapy followed by immunotherapy, concurrent chemoradiotherapy with immunotherapy. Again, there are some discrepancy between them. The data for immunotherapy is the preferred regimen because it's recent and this is practicing the standard of care for radiation, while the interlace was over a long period of time old approach for radiation, and but it is an option if the patient does not have an access to immunotherapy, and this is one of the option level 2A.
So it's not still the standard of care for now?
No, it is an option of treatment.
Option,
it is level 2A in the guidelines,
yes.
because, but for the immunotherapy, it is the preferred regimen if it is feasible.
I have some patients, especially, being, as you said, real life situations. I diagnose them as a cervical cancer, and then it is stage 2B, but it's large disease. I mean, I don't see these numbers, 8, 9, 11 centimeter cervical mass, okay, with lymph nodes. And of course, this is typically should go for concurrent chemotherapy with radiation therapy. And unfortunately, because of the limitation of having the funds and the coverage and the insurance and all these things, these patients sometimes they go several months before they get approved for something to start with. In these cases, do you think also they are also eligible to get into induction chemotherapy?
I mean, especially those who do not have an access for this, and you need a long time for charity, probably weekly carboplatin paclitaxel as an induction on weekly. This will probably at least delay the progression and save you the 6 weeks before starting the definitive concurrent chemoradiation.
Thank you. With this, I would like to thank all the eminent speakers and our panelists as well for a very informative discussion. Thanks for all of the audience to be here till this late. And thank you and congratulations to the organizing committee, Dr. Farooq Latif, Dr. Syed Hamad Trimzi, and Dr. Dina Hamza. So I believe this was the last session, and this one more after. Really, Gynae is the last one, so I thought.
Thank you. This is the end of Gynae session. So for the interest of time, we'll skip the coffee break, and I will invite my friend and colleague, Dr. Arif Chahal, to come and moderate the next session. Thank you.
Thank you, Dr. Muhammad. So the meeting did not finish yet. So we'll start the head and neck and melanoma session. And just a note, because our international speaker, he has to catch up the flight. So he will present, and then we'll have the discussion immediately after his presentation. So it's honor and a privilege to introduce Professor Robert Haddad. He's the Chief of the Division of Head and Neck Oncology and holds the McGraw Chair in Head and Neck Oncology at the Dana-Farber Cancer Institute in Boston. He is also an institute physician and a professor of medicine at Harvard Medical School. Dr. Haddad trained in internal medicine at St. Luke Roosevelt Medical Center and completed hematology oncology fellowship at University of Maryland Cancer Center. He specialized in head and neck cancer, has led multidisciplinary clinical care research published in peer-reviewed journal, and he will go or take us through incorporating checkpoint inhibitor into the curative treatment in head and neck cancer. Professor Haddad.
Good afternoon. Great to be back with you today. I will review the recent updates in neoadjuvant immunotherapy in head and neck cancer. As some of you know, by now we have a new standard of care for treating patients with resectable head and neck cancer with neoadjuvant pembrolizumab based on the Keynote 689 study that we have just published. I'm going to review that data with you today, with also some other new data that we've seen in 2025. So this is the name of the talk, Incorporating Checkpoint Inhibitors into the Curative Treatment of Head and Neck Cancer. So where do we stand in 2025 in head and neck cancer, or now 2026? You know, for many patients with oropharynx cancer, HPV is the main cause of oropharynx cancer. It's actually the #1 cause of oropharynx cancer in the US today. For those patients with HPV oropharynx cancer, treatment de-escalation approaches are evolving and are of great interest. Because these patients do so well, we're often looking for treatment de-escalation for those patients. For the other patients, the HPV unrelated head and neck cancers, the smoking related head and neck cancer, larynx, hypopharynx, oral cavity, those patients have very aggressive disease and the treatment options have been limited for them. Remember, we also have a new staging system for HPV positive and for HPV negative. And surgery, chemotherapy, and radiation have been the standard of care for many, many years. This has changed as of last year with the addition of checkpoint inhibition to the neoadjuvant treatment of oral cavity squamous cell carcinoma. And this is really what I'm going to share with you. So the FDA in the US approved Pembro in June 12 of 2025. So it's a new indication and a new standard of care for resectable oral cavity head and neck cancer. So how did we get here? You know, the past decade, there have been a number of negative trials that have looked at adding a checkpoint inhibitor to chemoradiation. This is one of the first studies I was involved in with the addition of avelumab, a checkpoint inhibitor, to chemoradiation. So these are patients who are going to get with chemoradiation randomized to chemo-RT or chemo-RT avelumab. This is not a surgical patient population. This is a patient population being treated with chemoradiation. This was a negative study, and essentially adding avelumab to chemoradiation did not improve outcome. The other study that also looked at the addition of pembrolizumab with chemoradiation is this one, Keynote 412. Here, similar to the prior study I just showed you, patients being treated with chemoradiation randomized to either chemoradiation or chemoradiation pembrolizumab. So also a non-resectable patient population, and here also a negative trial. So adding a checkpoint inhibitor to chemoradiation did not improve outcome in these two large phase 3 studies in head and neck cancer patients. The other study that also I was involved in that we just published in the JAMA was a pure adjuvant study where we took patients who were treated with any modality, surgery, chemoradiation, induction chemo, and then as an adjuvant strategy, we randomized them at the end of their curative intent treatment to either atezo or placebo. Atezo is a PD-L1 inhibitor. Also a negative phase 3 study. No benefit of giving adjuvant atezo in this study. So here essentially I showed you in 4 minutes 3 large randomized phase 3 trials with almost 2,000 patients accrued, showing no benefit of using a checkpoint inhibitor during chemoradiation or as an adjuvant strategy for head and neck cancer patients. So why neoadjuvant immunotherapy? Again, as I mentioned in the beginning, because we need to improve outcome for patients with high-risk head and neck cancer, in particular resectable head and neck cancer oral cavity. We know that these drugs work in the recurrent metastatic setting. We actually have indications for both pembrolizumab and nivolumab in recurrent metastatic head and neck cancer. So a neoadjuvant approach also does induce an immune response early on, that we had hoped will deliver durable benefit. And the neoadjuvant setting is ideal because you have not touched the patient yet. The immune system is intact. And that would be an ideal setting, like we have seen with lung cancer and other cancers, breast cancer, be an ideal setting to test immunotherapy. And again, a thought that maybe by giving neoadjuvant immunotherapy, we actually could de-escalate the treatment because of the response that we might see to neoadjuvant PD-1. So these are the two mechanisms we think of here. Essentially, this notion of immune system priming that we've been hearing about all day today, where if giving a checkpoint inhibitor early on in the process, you will actually induce an early immune response, yet you hope would last through the disease process and beyond. So this is the phase 3 trial. Again, this is from 2025. Initially, we presented at AACR, then published in the New England Journal of Medicine. And it's a complete approach where we added a checkpoint inhibitor as a neoadjuvant approach, and then concurrent and adjuvant. So this is a publication that came immediately after AACR that I encourage all of you, if you have not read it yet, to look at this because it is a practice-changing trial. So who entered this trial? This was a trial that was targeting patients who are gonna be treated with surgery. So rule number one, these are patients who have resectable head and neck cancer. They have stage 3 or stage 4. They could be any site, larynx, hypopharynx, oropharynx, or oral cavity. But most of the patients enrolled were oral cavity, as you typically would do with resectable head and neck cancer. They needed to have a good performance status, and they needed tissue for PD-L1 testing. The neoadjuvant phase was 2 cycles of pembro every 3 weeks. So day 1 and day 22 pembro. Then the control arm was proceed immediately to surgery. Then you have the surgery, and then based on the pathology, patients will be treated with radiation or radiation chemotherapy and pembrolizumab. So if you had high-risk features, the randomization is chemo-RT versus chemo-RT pembro. If you have no high-risk features, it's RT alone versus RT pembro. So that's the randomization. And there was a maintenance pembrolizumab for 12 cycles in the pembro arm. These are the stratification factors shown here. And the primary endpoint of this trial is event-free survival. And the secondary endpoint is overall survival, but also we were interested in looking at what we call the major pathological response, which was defined as 10% or less of residual invasive squamous cell carcinoma in the resected surgical specimen. Now let's look at the treatment detail. The radiation treatment on this trial was a standard treatment, post-op dose of 60, 66 gray, 70 gray. Cisplatin was used as bolus cis, 100 milligram every 3 weeks. So the chemotherapy and the radiation therapy treatment were standard of care on this trial. Patients' characteristics are shown here. This is close to 700, more than 700 patients enrolled between the 2 treatment arms. These are mostly men, as you would see with head and neck cancer. As I mentioned, the most common primary site is oral cavity. These are the patients we often would operate on. Remember, for larynx, hypopharynx, most of the time we don't operate on these patients. We give chemoradiation because we're trying to achieve organ preservation, larynx preservation. But in some parts of the world, larynx cancer is treated surgically. So those patients were allowed to enter the trial. The HPV status was very low, 3%. So this is primarily an HPV unrelated patient population. And the CPS more than 1 was 95%. So the vast majority of patients enrolled on this trial had CPS positive disease, which is what you would see in head and neck cancer. Oropharynx numbers were low. So when we look at the treatment disposition, again, 363 randomized to the pembro standard of care, 351, and this is the neoadjuvant treatment shown here. The vast majority of patients were able to receive the planned pembrolizumab treatment. Now, this is an important slide. When you look at the number of patients who underwent surgery on both arms, it was 88.7% on the pembro standard of care and 87% on the standard of care. So you had patients who did not proceed to surgery for a number of reasons. They changed their mind. They might have disease progression. So real life experience with head and neck cancer stage 3 and stage 4. Now, one important feature that we actually found on this trial, when you look at what happened after surgery, there were more patients who received chemoradiation on the standard of care arm than on the experimental arm. And we assume that what has happened here is patients who receive neoadjuvant immunotherapy had less likely to have positive margin extranodal extension, which will be the indications for chemoradiation in head and neck cancer. So you see the number here with the high-risk features being 32% on the pembro arm and 44% on the standard of care arm. So more than 10% reduction in the number of patients with high-risk features in that neoadjuvant approach. The rest of the treatment arms were balanced, as you can see here. Treatment exposures is shown here. Again, I pointed that a lot of this was standard of care as it comes to the chemotherapy and radiation. If you had high-risk features, you had high-dose cisplatin with radiation. If you had no high-risk features, which were defined as the positive margin, extranodal extension, then you had radiation alone with pembrolizumab. Primary endpoint, and this is really what led to the FDA approval. Look at the event-free survival for the CPS 10 or more population. You see massive differences in the numbers, 59.7 versus 26.9. Early separation of the curves that persists throughout with a hazard ratio of 0.66. So starting with a neoadjuvant immunotherapy approach, as you see here, has a profound impact on the event-free survival. This is the CPS more than 10. This is the CPS more than 1, which is where the FDA label is. So the FDA label for pembrolizumab in this indication is for CPS 1 or more. So as of now, the FDA did not approve this for CPS 0 patients. Remember, that was only 4% of the patients that had a CPS 0. So the vast majority of patients you will see in your clinic will have CPS 1 or more, and you see the benefit in event-free survival here between these two treatment arms. You don't often see these differences in head and neck cancer patients in a curative intent trial. When you look at the all participants, again, you see the same benefit of the pembro arm as compared to the standard of care arm. Merck has not shared with us yet the data from the CPS 0 group. Again, that's a 4% of the patients. But at some point, we will have access to the data to share it with you. EFS across the subgroups, consistent and durable benefit with the pembrolizumab arm. Again, this is now a standard of care for resectable head and neck cancer, stage 3 and stage 4 disease. This is an important slide because many will ask, okay, what happens during surgery? What did you find during surgery? The rate of what we call the major pathological response, which is less than 10% of invasive SCC, is actually low. You can see it around 13%, 9%, 9%. So remember, with this intervention, if you're looking for debulking, if you're looking for disease shrinkage, you're not going to achieve this with single agent pembro. The benefit of this really is immune system priming. And as you see with the EFS benefit, and hopefully down the road with the OS, which we will be reporting this year. But the rate of a major pathological response is shown here on this slide. Again, this is the pathological outcome post-surgery, and you can see that the complete resection rate was 89% on the pembro standard of care, 84%. You see the R1, R2 attempted unknown is shown there. And then we discussed the high-risk features before, but what happened during surgery? What did the pathology specimen show? And again, there was some downstaging where there were less patients with a positive margin and extranodal extension in the pembrolizumab arm. A key secondary endpoint of this trial is overall survival. And what you see on this slide is that the trends are favoring pembrolizumab. The follow-up is ongoing for the OS because we have not really reached the number of events necessary to test the overall survival. This has been submitted to ASCO 2026, so we hope to have the final OS analysis for you in ASCO of 2026. But what was important for the FDA is to see here that the curves are actually going in the right direction, that for the overall survival, the pembrolizumab arm is performing better with a hazard ratio of 0.72. So as I mentioned, I don't have to go through all of these. This is a new standard of care for patients with resectable head and neck cancer, stage 3 and stage 4, with CPS 1 or more. This is important. You need to have the tissue. You need to test CPS because the label currently is CPS 1 or more. Again, new standard of care for our patients. Now also, if you went to ASCO last year, there was a plenary session looking at a different way of adding a checkpoint inhibitor to the treatment paradigm. It's called Nivo post-op. And this is a different trial because in this trial, patients were operated on first. And if they had high-risk features defined as positive margin extranodal extension, then they were randomized to either Nivo chemoradiation or chemoradiation. So a different treatment model, adding nivolumab only in a patient population with high-risk features, positive margin extranodal extension, so there is no intermediate risk patient population without these risk features. This was a positive trial. The patient population is seen here, mostly oral cavity patients, because those are the ones that get surgery. These are the high-risk features. Again, this is bad head and neck cancer, positive margin, extranodal extension, again, randomized to Nivo chemo-RT or chemo-RT alone. The primary endpoint, just like our trial, is also event-free survival. And for that endpoint, it's a positive trial, as you can see here. This actually has just been published in the Lancet. This is the ASCO plenary, and it was just published in the Lancet Oncology, in the Lancet actually 2 weeks ago. And this is the data for the 3-year disease-free survival shown here. So a positive trial, and just like our trial, they have not hit the number of events necessary to declare the final overall survival. So that is ongoing. The incidence of local regional control is seen here. So Nivo plus chemo-RT impact was primarily on local regional control. With the Keynote 689, the impact was primarily on distant control. So really interesting dichotomy with these two trials. So the overall survival analysis is ongoing for this trial, expected also later this year. There are 2 trials now asking a question of pure adjuvant. This is one, EVOLVE head and neck cancer, which is a trial that's essentially giving a bispecific antibody. It's a CTL4 PD-1 antibody. This is a pure non-surgical population. So chemo-RT population, we're randomizing 1,000 patients to receive or not receive this antibody. It's an ongoing study. And JSK has another study called JADE, using their PD-1 inhibitor, again, after chemo-RT, so non-surgical population receiving PD-1 antibody or placebo. So 2 ongoing adjuvant phase 3 trial. So as I mentioned, standard of care has not evolved in head and neck cancer up until 2025. Checkpoint blockade trial in curatively treated head and neck cancer have been negative up until now, maybe because of poor patient selection. We did not select for CPS. The patient's population were heterogeneous. 2025 introduced a fundamental change in how we treat surgically treated head and neck cancer patients based on the Keynote 689. Multi-D care now becomes extremely important because the surgeons now really are required not to operate on the patient immediately, but rather have a multi-D evaluation and discussion with their medical oncology colleagues about neoadjuvant immunotherapy. This is before the patient is treated, not after. The sequence is important. You should not wait too long between neoadjuvant and surgery. Again, this is a surgical group. It's not the chemo-RT group. And also, if we think long-term, this will have a great impact on metastatic disease where we give pembrolizumab and nivolumab. Because if you are giving neoadjuvant immunotherapy, then you're not likely to use it in the recurrent metastatic, but you might be looking for other treatment options. And this is our multi-D group. Thank you very much for the invitation. We'll take some questions.
Thank you. Thank you, Professor Haddad. If you can stay with us on the stage. May I invite the panelists, Dr. Farouk and Dr. Abdul Qayyum Malik, if you come to the stage, please.
Maybe I can.
So no, I will start. I have the privilege to be chairing this session. So, Professor Haddad, very excellent data. Now with the incorporation of immune checkpoint inhibitor in the neoadjuvant and probably coming in the adjuvant setting. So I have 2 questions here. We know that head and neck cancers are highly mutagenic and oncogenic, but we know with use of chemotherapy, with killing of more cancer cells, you might prime the immune system more to be responding to immunotherapy. So do you think like if there is an additional arm for chemoimmuno before surgery might be better? I don't know. The other questions on Monday clinic tomorrow, if I have a patient, how do we select my patient to go for keynote 689, or probably this patient will need an adjuvant therapy later? Thank you.
Yeah, two great questions. So the first question is about giving chemotherapy before surgery instead of just immunotherapy. And this is really, keynote 689 did not have a chemotherapy arm. And if you are designing a trial today, you would have chemoimmunotherapy as one of the arms. You have to do that. Remember, when you give chemoimmunotherapy, you will have a much greater degree of debulking, of disease shrinkage. But you could lose on side effects. You could have more delay in surgery. The bottom line is if you have a patient, for example, we're actually talking about this outside before we came in with one of our surgeons, Roger here. If you have a patient, number one, where you're worried about the patient tipping into unresectable disease very quickly, you might make a decision to operate, go to the OR, get the surgery done. Or you could make a decision because you do want to shrink that disease to actually give chemoimmunotherapy for that patient. I know some centers in the US are doing this. Now, most head and neck cancer patients will not be in that situation and will be in a situation where you would give neoadjuvant pembro per 689. So I'm not advocating for chemoimmunotherapy for the patients, except to say that this is a complex disease. And in some situations, you'd have to use your judgment and decide, I'm worried that this patient is gonna tip into unresectable. I'm gonna take them to the OR tomorrow and get done with it. Or you could say this patient has a T4 tongue cancer. His surgery is gonna be massive. I'm gonna give chemoimmunotherapy to debulk the tumor. First question. Second question you asked, tomorrow in the clinic, you're seeing a patient with a T2 and 2 oral tongue cancer, right? Bread and butter head and neck cancer. This is most of what we see in the clinic. Somebody walks in with a T1, T2, T3 lateral tongue tumor, N1, N2 disease. They're gonna need a partial glossectomy or a hemiglossectomy neck dissection. For that patient, I would encourage you to talk to your medical oncology colleague and introduce immunotherapy for that patient. Remember, even at our center, and we are a high volume center, it takes our surgeons 4 to 6 weeks to get the patient to the OR because you need a reconstructive surgeon on top of your ablatives. You need 2 surgeons to do these surgeries. I know Roger does everything on his own, but in general, for most of these surgeries, these are 10 to 12-hour surgery. It takes 4 to 6 weeks to get patients to the OR. So I would give that patient 2 cycles of pembrolizumab while the surgical team is being assembled and getting ready to do the surgery. So that's the bread and butter, I would say, head and neck cancer patients you'll see in the clinic tomorrow.
I have a question.
Okay, that was one of my first questions, so thank you. There was a recent, here, in JCO, there was a recent publication where they looked at almost 10,000 patients. I'm sure you're aware of it. And it's not an obviously prospective trial, but their conclusion was giving single agent immunotherapy was a better group than there was like 5% who received chemoimmunotherapy. Any comment on that?
Yeah, so there's a huge patient selection. When you make a decision to give chemoimmunotherapy, you have decided that you are, number one, very worried about that patient, and number two, that patient has very bad disease.
Not resectable even.
Correct. We're talking about resectable disease. So these, these retrospective or meta-analysis, they're inherently biased that way. I think what I would say in 2026 is that if you have a resectable head and neck cancer patients per the 689 protocol, the standard of care is neoadjuvant pembrolizumab for that. But it's not for everybody. So I hear the reservation from my colleagues in the US about, for some patients, they like to give chemoimmunotherapy. And I respect that for the patients who needs an immediate response and where you're worried about tipping them into unresectable.
Then the Nivo post-op, one of the critique, again, what we know from other tumors, especially melanoma, that giving immunotherapy when the tumor is still in place is a better strategy.
Right.
Any comment?
But also remember, Nivo post-op population is included in 689, because in 689, if you do the surgery and you have high-risk features, you're going to get chemoimmunotherapy, chemo radiation plus immunotherapy.
Thank you so much, Dr. Haddad, for the presentation. Honestly, we are facing difficulty with the surgeon to understand that or to accept the idea of giving 2 cycles of immunotherapy before surgery. Most of them, they believe that this should be given to the patient with locally advanced, not resectable disease.
Yeah.
This is number one. Number two, I'm not sure about the NIVO-STOP trial. Is it approved or not yet?
No. So Nivo-Postop is not approved yet, and it's not on the NCCN guidelines. So that's an easy one. Your first question, yes, you are correct. I mean, obviously, I've been dealing with this now the past 6 months. There is 2 schools. You have resistance in some places of the world among our surgical colleagues, and you have other places that have really had rapid adoption of this model. I would say that the feedback mostly has been positive from the surgeons, primarily because for many surgeons, this gives them time to prepare for the surgery. Now, the surgeons that or people that advocate for neoadjuvant immunotherapy before chemoradiation, there's no data to support that right now. So for there, the data is if you're going to give induction, I give induction TPF. We have an approved regimen for induction chemotherapy. I mostly use it for larynx, hypopharynx patients, and that's cisplatin, Taxotere, 5-FU, the Tax 324 regimen that actually we ran out of Dana-Farber also. So that's my standard if I need to give induction chemotherapy for larynx, hypopharynx patients, for example. For the resectable patients, the 689 for me is the new standard of care. Yes, Roger.
Thank you, Robert. That was a great presentation. I have 2 questions. First, would the age impact your decision making? And second, I see that the number of major response was not high, but it was labeled as 90%. Did they look, should they have like labeled major response as a different number?
Yeah.
Because 90 is quite
yes,
high.
Yes, yes.
Would that have changed?
We are looking at this right now. So the bar was set very high on the study of 90% shrinkage, meaning only 10% residual cancer. So we are now looking, and that will be another presentation, at 50% or 60%. We're going to look at the continuum of the MPR because for the trial, we defined it, we were very, very ambitious by essentially expecting 90%. So that's a great question. It is being looked at right now. And then your first question, I'm sorry. Oh, age. Yeah, no, I don't. Age is like anything else, right? So for you as a surgeon, if you're making a decision that that the patient is fit for surgery, because this is a major surgery, head and neck surgery, then they're definitely fit for neoadjuvant immunotherapy. And also remember, you might actually be able to omit cisplatin if you end up with no positive margin and no ENE. So it could actually work well in somebody who's a 70 or a 75-year-old who is going to end up requiring radiation or chemoradiation. Maybe they'll just need radiation. So if you as a surgeon determine that the patient is surgical, meaning you've made the decision it's a good performance patient, they're fit enough to go to the OR, then I would proceed with the neoadjuvant pembro for that patient.
Any other questions for Professor Haddad?
Yes, the other
Last
question,
one,
pembro's duration. I mean, do you need it in all 3 phases?
It's a very common question we hear, and you know, we have the data that we have, and what I tell my patients, they tell me I'm going on vacation for 4 weeks. I tell them go on vacation. We'll skip 1 dose of pembro. That's okay. So there's nothing magic about how the study was done. This is what we elected to do, and this is what we have right now. It might be that you actually do not need this whole treatment. Sorry, I have to run to the airport. Otherwise, I'd have loved to stay. Thank you so much.
Thank you very much.
Good evening. Now I would like to invite our last speaker, Dr. Abdul Rahman Aga, who has trained in the American Hospital of Beirut and MD Anderson, currently working as an adjunct professor in the Sharjah University, who will give us talk about the melanoma. Welcome to the...
Thank you, Chairman. Thank you. Thank you for the kind invitation, and really it is a pleasure to be among you here again. And for my friends who ask where I have been, I just tell them I'm back, so don't worry, I'm here again.
So the topic is about the progression after frontline therapy with immunotherapy PD-1 inhibitors. And as we all know that the immunotherapy has been revolutionary in the therapy of melanoma from actually a median survival of less than 1 year. Now we have patients who responded very well to PD-1 therapy inhibitors, checkpoint inhibitors, that they are surviving for 6 and 7 years since the data that we have. Now, despite all that, we still have patients who have primary resistance or acquired resistance. And from the information that we have, if you go for a monotherapy from first line, we have about 33 to 50% response. And if you go with the combination with the CTLA-4 inhibitors, reaching with nivolumab, ipilimumab, about 60%. And many as thus of your patients who would require a second line one time in their life. Now, as looking for the strategy, how you think about it, as all immunotherapy, we still look into if this is a true progression versus a pseudo progression. And whenever we need to look for to switch for a targeted therapy, and we encourage all of us, because of the data that we're going to present right now, clinical trials, if available, will be always advised. Always look into the addition, if you use a single monotherapy, probably to adding another immunotherapeutic agent, as CTLA-4, or a local therapy whenever you have oligometastasis, and possibly with the data that we have, sometimes we can re-challenge with the therapy. As all we know that melanoma, as all therapies, we have to look for the NGS, we have to look for the genetic profiling, and mainly to look into the BRAF. Around 40% of your patients would have a BRAF V600 mutant, and this will help you and guide you later on directly when you decide for your therapy. And just to guide you again, that the PD-L1 status did not really affect the response on the immunotherapy, so it is really not needed whenever you assess your patient at the beginning. But how you develop your strategy whenever you have patients who have already progressed on your frontline anti-PD-1 therapy. So the first thing is you look into what therapies has been received before, and now we have the data about the adjuvant, which is actually complicating things. So you have the adjuvant therapy versus the palliative therapy. Time of the progression, less than 6 months or more than 6 months, is very important. As what you know, if there's a primary resistance to the immunotherapy. The biomarkers, as I said initially, the BRAF mutation, the presence of CNS metastasis, symptomatic or not, the comorbidities, and lately with the data, you see that also the patient-related, such as elevation of LDH or the performance status, would also help you to decide on your second line. Now, just for the sake of discussion, I try to divide this into 2 categories: BRAF mutant patients versus non-BRAF mutant wild type. Now, some data did not even divide these patients, but we have significant information for patients who have BRAF V600 mutant. And this goes for the 2 trials. The first one is the Beat, where they looked initially on the sequential therapy to start either with a targeted therapy with anti-MEK and anti-BRAF with incredifanib, abinibulin, followed by the immunotherapy with nivolumab and ipilimumab, or vice versa, to start with the immunotherapy followed by targeted therapy. This is a phase 2 trial, and it was including patients definitely with BRAF, and the primary outcome was overall survival. The secondary outcome was progression-free and the overall and duration of response. Now, interesting, if you look at the arm B, the arm B is the one that is started with immunotherapy followed by targeted therapy, showed that these patients have a 2-year overall survival, about 73% higher than starting with targeted therapy. And this is one answer that we're looking for, and this is very interesting. We always thought that possibly going for the biomarker, targeting the biomarker that's causing the changes would be beneficial, but actually in this category of patients, starting with immunotherapy did well. And if you look at the other trial, which is a phase 3 trial, the DreamSec, looked the same as anti-MEK, anti-BRAF at the beginning versus immunotherapy later on. And it is an arm A, B, C, D, and they looked into the patients with no CNS active disease. The endpoint was 2-year overall survival, secondary endpoint progression-free survival. And as you can see at progression, you see that the patients also who started with immunotherapy, followed by target therapy with anti-BRAF, anti-MEK, did better at 2-year overall survivals. And interesting, you look at 71%, very similar to 2 trials, different in the similar in the immunotherapy agents, but different in the anti-MEK, anti-BRAF, did the same at 2-year overall survival of 71, 73%. And this was also translated previously with the progression-free survival, 41 versus 19 months if you start with targeted. So these two trials would solve the issue of when you have a patient with a BRAF mutant, you're always better to start with the combination of immunotherapy, nivolumab, ipilimumab, to be followed by anti-MEK, anti-BRAF therapy. So this is the first answer we get in patients who have progressed on frontline immunotherapy. Now, if you look into the patients who have mutation absent, as I said, some of these trials did not divide, did not segregate according to the BRAF mutation. There were also some trials they combined both of them. But as we all know that whenever you have a patient who have only received a monotherapy anti-PD-1, adding STL4 as ipilimumab, like this walk 1616, showed improvement and doubling in the progression-free survival. And this is initially one of the strategies that we used whenever we had patients directly progressing on single agent. But looking more further for the agent that we're having, this is the now more agents coming forward to see how we can manipulate the immune system. This is the using of a lymphocyte aggregate gene 3 inhibitors, delatinib, in addition to nivolumab. Now, this is a phase 1, phase 2 trial. They looked into the response rate, and you can see that significant response with a significant duration compared whenever they use this addition. So this is an option. Again, this is a phase 1, phase 2 trial, not a phase 3, so I cannot say this is a changing therapy, but it is an option that you may use if it is available in your market. The LEAP is a very interesting concept where they looked into a totally different. So patients who received already the PD-1 inhibitors, but then again, when they have a progression, they went into using pembrolizumab and lenvatinib. This was a single arm, and they included patients who was the last dose less than 3 months. This is a phase 2 trial where the main primary endpoint was overall response rate, and the secondary was duration and progression-free survival. And they looked into that addition of lenvatinib to pembrolizumab. Even pembro was used in the first line. In the second line showed still we have further response, about 21%, and the disease control was about 66%. So this is another option that you may use. This is not approved, this is not standard of care, but options that you may explore according to the criteria of your patient. Now, a very interesting concept, which is the tumor infiltrating lymphocytes. So this is the C11401 trial. It's a phase 2 trial with rifilucil in patients who already metastatic unresectable, who received at least one line with anti-PD-1. In this category, they allowed the use of patients who received anti-MEK, anti-BRAF therapy, and the primary endpoint was overall response rate, and the second endpoints were duration of response as well, progression-free and overall. And if you look at these patients, this is a single arm, you can see that we have about 31% response rate with this new category of medications. And this has given the approval. I think it's accelerated approval in 2024, where you can use this category medication. Now, the interesting part was the duration of the response. Patients who have responded had more than 14 months of response, and it is continuation until now with about 41% had more than 18 months of response. And the progression-free survival about 4 months for both categories. It is an option. There's an accelerated approval, but then again, not standard of care, but it can be used if it is available. Now, the downside of this therapy was the use of non-myeloablative lymphodepletion therapy with cyclophosphamide and fludarabine. In this trial, with the significant grade 3 to grade 4 side effects, which mainly leukopenias, anemia, significant, they have 6 deaths on this clinical trial, which makes your choice of therapy very challenging and make sure that who you choose for this therapy from your patients or not. So you have to be very personalized in this way. And the therapy side effects has been mainly in the first 2 weeks. So this was really alarming. But then again, when another trial looked into that, where they used the tumor infiltrating versus ipilimumab. Now we all agree that the second line single agent ipilimumab is no more used. There's always a combination, but this was used with a phase 3 trial in patients who have already progressed under 1 line of therapy. There's no prior ipilimumab received, and the endpoint was progression-free survival. One infusion of tumor-infiltrating lymphocytes has after 9 myeloablative lymphodepletion versus ipilimumab for a maximum of 4 doses. And you can see the median progression-free survival was more than double with a single infusion of tumor-infiltrating lymphocytes therapy. Now, in the study, they did not find, for the response rate was about 50% versus 21%, and this was significant in the previous trial as well. So this is a new type of therapy that, if available, it is one option that we use. The interesting thing is that they did not have any death on this clinical trial. All patients had grade 3 to more than grade 3 side effects related to the non-myeloablative lymphodepletion. And this is what we will learn from experience, the same as we did with immunotherapy before, the same with CAR T cell, bispecifics, with the side effects. We learn every time with the clinical trials how we can manage these side effects. So still, despite the side effect profile, there's an outcome that was trending that the quality of life using the tumor-infiltrating lymphocytes was better than using ipilimumab. So this is something to look into. Now, after all this discussion, I wish I can tell you go back to the guidelines and see the guidelines is not updated for the last 1 year regarding the topic. So just in a nutshell, you can see that we divide them. If patients who had a BRAF mutation, you have the advantage of using targeted therapy compared to the patients who are wild type. I put them in a way that according to the overall response rates and the progression-free survival, how you can use them. And I think this is the data. It depends again on your patient and depends again on the availability of the medications in your country. Now, just a take-home message. I think my message will be more clear than the guidelines whenever you read it. Really, it's very confusing. So the sequencing, we have been seeing clear that in patients who have a BRAF mutation, that going with the immunotherapy at the beginning followed by target therapy is the best way to go for these patients. There was some documentation that they are suggesting that for patients who had high LDH or patients who had poor performance status or probably symptomatic CNS, in these patients, possibly starting target therapy is better than immunotherapy. But then again, we all have a clear idea that immunotherapy at the beginning is more often. And in these patients, the second line would be target therapy. For the PD-1 refractory disease, multiple effective options exist. None of them is strict or standard. The leratinib, the LAG-3 inhibitor, pembrolizumab, or the tumor-infiltrating lymphocytes all have shown a benefit either in the response rate or in the progression-free survival. In the tumor-infiltrating lymphocyte therapy, they provide a durable response in heavily pretreated patients, but we had to be very careful due to the toxicity. So your management, we go to the initial slides, will depend on the mutation status, disease burden, CNS, LDH, performance status, and what are the prior therapies, and especially the patient preferences. And we're seeing right now more data with new agents coming on in addition to the PD-1 inhibitors. So you see additions and not omissions. We're keeping the PD-1 inhibitor probably re-challenging and adding further drugs, new categories, and hoping that we have better outcomes. Thank you again for listening.
Hello. Thank you, Dr. Abdul Rahman, for giving us nice presentation overview about the melanoma. Any question about the
Just one question, yes.
Hassan, okay, I got it first, yeah. Okay, so thank you for the excellent talk on a rare topic. In the first line, metastatic setting, patients who have BRAF mutation, what would be your preferred option? You would go for immuno or a BRAF-directed therapy?
I think the two data, one phase 2, phase 3 trial, have very consistent outcomes. Both of them, they had a 2-year overall survival of 72% whenever they compare to the other arm when they started target therapy versus immuno. So I think it's clear by now that probably starting immunotherapy at the beginning as frontline will be the options for all these patients. That will be my choice.
Along the same lines. So
Yes.
when you look at the curves, however, there is a big crossover after 6 months. So we're losing patients in the first 6 months on immunotherapy alone. So any suggestion that maybe we need something on top in the beginning to avoid maybe for locally advanced disease or metastatic burden high? Should we give combination to avoid that big crossover?
So what you're alluding at is to the triple therapy, where you're combining target therapy with immunotherapy. And this is possibly with patients with high burden disease. And this is the question where UFC is not yet confirmed what you want to choose, but probably with high burden disease, symptomatic CNS, probably going with the combination with immunotherapy and target therapy would be a better option. It depends on the patients, how fit it is for all these therapy together.
Because in both of your trial that you showed, the DreamSeq and the first one, there is always crossover. The other drug, I guess we didn't talk much about, is the LAG3 inhibitor, the Opdualag, which is a combination of nivolumab plus the anti-LAG3. What do you think?
Relatimab is a LAG3 inhibitor, but I did not mention this trial, yes.
Right, so because that's being used more and more instead of Epi-Nivo in clinical practice, mainly because we have preserved efficacy or similar almost to Epi-Nivo, but much less toxicity. Remember, the Epi here is 3 milligram per kilogram with much higher potential side effects.
Not only less side effects, but I think the duration of response for the patients who have responded, it seems to be more prolonged than the use of Ipilimumab.
One question to Dr. Abdel Basit, because he's one of our panelists. So Dr. Abdel Basit, in melanoma, after failure on immune checkpoint inhibitor, do you usually go for a second biopsy, or what is usually our strategy in our tumor?
Yes, in second line, obviously, it's always if we find on imaging that one lesion has a discordant growth and maybe the other lesions are responding, maybe we can check that for like we can to send tissue for NGS to find any further target which we can target it with some targeted therapy. Other than that, I don't see in most of the patients we generally don't need to do a repeat biopsy.
So we still have 2 more questions. I want to
ask about how you see the re-challenging about the immunotherapy.
Well, to tell you the truth, my experience in the challenge is not much, but it looks already the duration of progression. If the patient has progressed within the first 6 months, it is less likely that you're going to go and re-challenge these patients. But if the patient had a metastasis, the progression after probably 1-2 years of stopping the therapy, they may be a benefit of re-challenging. And there is data to suggest that there is another response for these patients. But my experience with that is unfortunately poor with this.
Thank you, Dr. Abdurrahman. Thank you very much.
Okay, they have been 2 full days, and I would love to thank every single one who have participated in this, our first shot of the PMOC. And I would like to welcome here on the stage the 2 behind this huge work, Dr. Syed Hamad Termazi, Head of Department of Medical Oncology, Dubai Hospital. And Dr. Muhammad Farouk, the chairman of the PMOC. And would love to thank our pharma colleagues and friends who have participated and made this conference come to the light. Our main sponsor is AstraZeneca. Lily. MSD, Novartis, thank you. Amgen, Astellas, thank you so much. JSK, one's here. Merck, Bayer, Bristol Myers, BMS, Gilead, Hikma, Menarini, Stemline, Pierre Fabre, last but not least, the two beautiful ladies from Roche. And the two behind this work, Dr. Muhammad Farouk Latif. And our team leader, Dr. Syed Hamad Termezi. Thank you so much, and I would love to me. I don't have certificate. Poor lady, wallahi, poor lady. We would love to invite the physician to go for the workshop, for the gynae workshop, which is going to start right now. And see you next year, inshallah, 23rd and 24th of Jan. Thanks to all of you. And thank you, Micheline, Convenience. Thank you so much for all this work behind all this. Thank you.